185 ऐसे ये सारे जो एलिमेंट्स है इनके वैल्यू
सारे 3 मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना है कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं इन अ फिनोमेना नोन एज वॉकिंग।
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis. But which kind of episodes, everybody? Chronic episodes.
We have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in two axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, it is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or brow presentation.
If they're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I've given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe-ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added, and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
As I was looking at the file, maybe I was half sleepy. Something interesting happened. The file just slipped off my hand and fell. What happened was, when the file went and fell down next to the child suddenly startled. The moment the child startled, my sleep went away. I was wondering what happened. I just took the file again, put it down again. The gush of air, another startle. That's when my brain tickled and said, could it be something which we are missing? I took a water bottle nearby, poured water next to the child. The child started gasping and startling. That is what we call as hydrophobia. Most important point was, this child was in neurology wards under the best doctors for about 3 days before, and nobody had picked up rabies in that child. When I saw with half sleep, picked it up. What is most interesting to say here is, anytime when I doubt my clinical abilities, I remember this and I say, Sunil, clinical skills will always help you. So, welcome to Marofy edition, where we'll be talking about a lot of clinical vignettes and a lot of things which will matter for life, not just for the entrance. Natural or environment phobias could be something like hydrophobia, which makes you not go to places where there's a lot of water, lakes, ponds, swimming pools, such kind of natural environments, and those can make them trigger having extreme fear, hydrophobia. They can also have acrophobia, which makes them find it difficult to go to hill stations and those where heights kind of are a bother to them.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स हैं इनके वैल्यू सारी तीन मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना पड़ेगा कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walking.
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis, but which kind of episodes, everybody? Chronic episodes.
So we have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in two axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, it is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or brow presentation.
They're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I have given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added, and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
As I was looking at the file, maybe I was half sleepy. Something interesting happened. The file just slipped off my hand and fell. What happened was, when the file went and fell down next to the child suddenly startled. The moment the child startled, my sleep went away. I was wondering what happened. I just took the file again, put it down again. The gush of air, another startle. That's when my brain tickled and said, could it be something which we are missing? I took a water bottle nearby, poured water next to the child. The child started gasping and startling. That is what we call as hydrophobia. Most important point was, this child was in neurology wards under the best doctors for about 3 days before, and nobody had picked up rabies in that child. When I saw with half sleep, picked it up. What is most interesting to say here is, anytime when I doubt my clinical abilities, I remember this and I say, Sunil, clinical skills will always help you. So, welcome to Marofy edition, where we'll be talking about a lot of clinical vignettes and a lot of things which will matter for life, not just for the entrance. Natural or environment phobias could be something like hydrophobia, which makes you not go to places where there's a lot of water, lakes, ponds, swimming pools, such kind of natural environments, and those can make them trigger having extreme fear, hydrophobia. They can also have acrophobia, which makes them find it difficult to go to hill stations and those where heights kind of are a bother to them.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स है, इनके वैल्यू सारी 3 मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना पड़ेगा, कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walk.
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis, but which kind of episodes, everybody? Chronic episodes.
We have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in 2 axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, it is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or bro presentation.
If they're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I have given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe-ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6 by 6 by 6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added, and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
Halgekar, the in charge for today's events, would like to welcome you all to the second day of Respirare 2021. Respirare has been successfully organized each year since its inception in 2015. It began as a state-level conference in 2015, which grew into a national conference in the year 2016. Since last year, we are organizing it as an international conference. The conference comprises of workshops, lectures from the finest doctors of India, debates, symposiums, case and paper presentations, and brainstorming quizzes. Every year, we receive a great response from eminent doctors across the country as guest speakers and 3,000 plus undergraduate as well as postgraduate students across the country as our delegates. Main aim of the conference is to give first-hand information regarding medical procedures in several workshops, Interactive sessions help to build an environment for cumulative growth of all aspects of one's personality. The ultimate result being students get exposed to varied experiences through thoughts and ideas shared by our eminent speakers. The theme for today's conference is Mind and Medicine. I would now like to familiarize you with the events for today. At 9 a.m., we shall have a session on staying happy and conquering stress as medical students by Dr. Swati Bhave. At 10 a.m., we shall have a session on Introduction to Biostatistics in Clinical Research by Dr. Nikhil Gupte. At 11 a.m., we shall have a short presentation of a promo by Spec Labs. At 11:20, we shall have a small introduction session of our first ever research club, Jidnyasa. At 11:45, we will have an online oration by offline oration by Dr. Bharat Watwani on the topic Humanitarian Outreach and Medical Fraternity. The lunch break will be from 1 p.m. to 2 p.m. We are having 3 academic events today: Vocalize, the debate competition starting at 9 a.m., Cynosure, the case presentation competition starting at 10 a.m., Cognizance, the medical quiz starting at 9. The final rounds of Vocalize and Cognizance shall be held at 2 p.m. and 4 p.m. respectively in the Mahatma Gandhi Auditorium. So pull your socks up and stay tuned as we begin with the events for day 2 of Respirare 2021. We shall shortly begin with the oration lecture by Dr. Swati Bhave on staying happy and conquering stress as medical students. Thank you so much. Over to you, Rutuja.
A very warm good morning to everyone. The greatest weapon against stress is the ability to choose one thought over another. Most of the stress that we have in our everyday life doesn't come from having a lot to do, but it comes from not finishing what we started. In the medical profession, where stress is our daily companion, it is important to know how to cope with this stress and utilize it in a productive way. Team Respirare 2021 proudly welcomes Dr. Swati Bhave, the Executive Director of Association of Adolescent and Child Care in India, Mumbai, for an oration on staying happy, conquering stress as medical student. I feel privileged to introduce ma'am. She is MD DCH FCPA. At present, she is working as Adolescent Pediatrics Consultant and Head of Adolescent Clinic at Jahangir Hospital, Pune. She was a Professor of Pediatrics in BJ Medical College, Pune, and Associate Professor of Pediatrics at Grant Medical College, Mumbai. She was IAP President in 2000 and got fellowship from IAP and AAP in 2001. She was the member of WHO Technical Steering Committee on Child and Adolescent Health in 2009-2010. IAP RCH awarded her with Lifetime Achievement Award 2019. She worked as Honorary IMA Professor for 2017 to 2020. To add glory, ma'am is the IAP Lady of the Millennium 2000. She is unique in that she has combined her medical knowledge with mental health issues, and she does programs for corporates on stress management. I would like to request ma'am to begin with her oration.
Thank you, Murtija. It's a pleasure to see all of you on the screen and come for this very prestigious conference which you have over years, and I'm very happy to know it's international now. So this topic is very dear to my heart because as a medical student, we all have undergone a lot of stress and it's not easy to remain happy, and especially for all of you during the COVID situation. Last 2 years have been really hard. So I hope this lecture helps you all to conquer your stress and remain happy. I thank Shaunik Pimpalkar and Meher Kaur for giving me this opportunity to address all of you in this International Youth Student Program. The topic is staying happy and conquering stress as medical students. We all know the medical profession is very joyful but full of stress, and hence as doctors, heal thyself. We have to first understand how to conquer our own stress and be happy, so then we can advise and guide the patients who come to us. So the contents of this lecture will be first What is meant by happiness? Second, what is meant by stress? And I will be discussing a little about the adolescent brain development, because the adolescent brain handles stress and relates to happiness quite different from adults. Then we learn healthy ways to conquer stress and how a healthy lifestyle helps us to be happy and stress free. So I have started a NGO 14 years back called AKI, Adolescent and Childcare in India, under the chairmanship of Padma Bhushan Dr. Lele. And we have more than 170 volunteers who are doctors and all specialities and other stakeholders around the country. And the slides which I am sharing today are part of the AKI modules which we take for stress management and happiness. These are for educational purposes, and though we make efforts not to use copyright material, we normally put the source. So I am requesting you, please don't take photos and circulate. We will not be liable for any violation. So whenever somebody is speaking, we always want to know the credentials. And I'm often asked, what is a pediatrician and an adolescent expert talking so much about mind-body medicine? So for the last 20 years, when I switched from pediatrics to adolescent medicine, I did a lot of courses online on psychiatry, psychology, and those who know these MOOC courses online of Coursera. Last 2 years, while the COVID shut down, I have done positive psychology, mindfulness, art and science of relationship, and understanding human needs. So to some extent, though I'm a pediatrician, I am qualified to speak for this subject, and I do speak as a motivational speaker in many corporates. So let us discuss what is meant by happiness and what is meant by stress. Happiness is very elusive. It's an electrifying state. And since 1990, there's a whole branch of psychology called positive psychology, which teaches us how to be happy. And there are two keys to happiness. One is gratitude, count your blessings, and altruism, doing good to somebody. Now as doctors, we are fortunate that we are doing good to somebody every day. So we can just keep counting our blessings, and doctors should be the happiest people on earth. Now we all are having a good IQ. That is why we get admission to medical college. But how many of us concentrate on our emotional intelligence? That is raising your EQ, learning to understand and handle your own emotions. And if you also concentrate on a health quotient, that is healthy lifestyle, happiness quotient will automatically follow. So when you talk of happiness, there are many definitions. Happiness is not just a simple positive mood. It's a state of well-being, enjoying your life. And happiness means different things to different people. Being spiritual, doing social work, being with nature, being in a loving relationship, a romantic relationship, being with friends, loving your pet, or just enjoying being a family. It is important for us as doctors to understand that being happy has health perks as well. There is a benefit to cardiovascular system, immune system, inflammatory levels are down, you have a longer lifespan, a better quality of life, and hence, especially during the COVID time, we must learn to be stress-free and happy to keep our immunity level high and our mind calm. And we also know that there's an International Happiness Day on 20th March. Can one always be happy? Can one always have positive emotions? Very difficult. This plastic wheel of emotions. Human mind has a myriad of emotions. You can see the simple emotion of anger. It may be mild irritation, annoyance, or it can go to rage. You can be happy, serenity, calmness, or joyful, or ecstasy. Or you can have a little apprehension, which can be fear and go into terror. So yes, a human mind is going to experience all these emotions. But balancing them is very important, because uncontrolled emotions can lead us to do wrong decisions, which we may regret for life. And just as we say, as long as something is not affecting your function, it doesn't become a pathology. For example, some of us may have an OCD obsessive trait, like being very careful about hand washing or clearing your table. But as long as it doesn't affect your function, we don't call it a disease. We don't say you have OCD. Now, God has made us a wonderful, if you don't believe in God, some entity upstairs has made our human body a beautiful machine. And what, as doctors, we need to understand that we also have our own factory of positive neurotransmitters. We have batteries to recharge our happiness and reduce our stress. And we have dopamine, which gives us pleasure. We have norepinephrine, which helps us to deal with our stress. We have serotonin, which helps us to keep calm. And you know that people who have antidepressant contain the serotonin replacement. You have glutamic and you have GABA. So if you don't have a psychiatric illness, when there are neurochemical imbalance, all of us who are healthy and normal can recharge our batteries every day and create our own neurotransmitters and positive mental health. We don't need to go to drugs and smoking and alcohol. Oxytocin is a cuddling hormone. We all know during lactation, it helps the mother to bond with the baby. But now it is also known that it helps social connectedness and people come closer together with oxytocin. And in psychopaths, this is very low. And during COVID, we have realized how much we need oxytocin and we are dying to meet people. We are trying to do it virtually. Endorphins are natural opiates which make you feel very good, reduces your pain, and these are released by daily exercise. So we have so much in our own body to create happiness and reduce our stress. Our emotions also depend on our endocrine system. We know if you have hypothyroid, you can go into low mental state or depression. If you have hypothyroid, you can be restless, edgy, irritable. If you are stressed out, our stress hormones, cortisol, epinephrine, norepinephrine are related. And we have the autonomic system, nervous system. In Japanese, they call it yin and yang. And we know that if we are stressed out, the sympathetic system gets stimulated. We get palpitations, we get excitation, we get fear. Whereas parasympathetic system, the vagal nerve, if we can stimulate it by yoga, by meditation, by soothing music, chanting, it makes us feel calm. So let us discuss what is pleasure and what is happiness. Pleasure is given by dopamine. Happiness is given by serotonin, oxytocin, and endorphins. Dopamine is quick fixes which we get with junk food, social media, buying something, immediate reward, very easy to achieve. But then you get addicted to the dopamine reward pathway and you crave for it again and again. All dopamine products have a label, you can buy it. And the brain says, dil mange more. And since most of these are single personal enjoyment, pornography, video addiction, gaming, you ultimately become quite isolated. And one becomes selfish, a taker. Whereas, if you try to get these neurotransmitters, they are long lasting, sustainable. It takes time. There's a delayed gratification, requires effort. Like if you want to get good marks for studies, you have to study the whole year round. If you want to be a good tennis player, you have to practice hard. But once you get this, the sense of achievement and contentment is very long lasting. It doesn't cause addiction. It gives internal peace, promotes physical mental health. You can't buy this. You have to work for it. Brain is happy and content. And normally it requires group activities. So you do volunteerism. Less serotonin, less happiness and contentment. If you see it in the brain, dopamine is just in the hypothalamic limbic system, whereas all these neurotransmitters spread throughout the brain. So what is stress and what are symptoms of stress? Let us discuss, do we need stress in our human life? Can stress be helpful? We know stress is harmful, but how harmful is it? Does it affect our health? And is there an optimal amount of stress which we need daily? Stress is often termed as the 20th century syndrome. Our ancestors were much more stress-free than us. In Western culture, stress means loss of control over one's life, and then they go for negotiating skills, time management, etc. Whereas in our culture, stress is absence of inner peace, and that is why when we are stressed out, we look for vipassana, art of living, calming mind, yoga, meditation. And today the Westerners also are looking for this peace. However, as with all our things, they give it a different label. So meditation is now called mindfulness, and there's a lot of courses in Western culture on mindfulness. So what is the medical definition of stress? Stress is a combination of physical and mental symptoms and emotions that result from pressure, worry, and anxiety. Stress is a state of anxiety produced when events and responsibilities exceed one's coping abilities. It's a non-specific response or reaction of the mind and body to any demand placed on it to adopt, whether that demand produces pleasure or pain. So we know as doctors to understand the general adaptation syndrome, which means when you have stress, phase 1 is the alarm reaction where you mobilize all your resources. Phase 2 is resistance where your body is trying to cope up. But body cannot cope up forever. And so it goes into phase 3 when you go into adrenaline exhaustion or your results are depleted. Let us see in medical terms. Stress stimulates the hypothalamus, which goes to the pituitary. The pituitary stimulates the adrenal gland, and we have an outpouring of the sympathetic nervous system, cortisol, adrenaline, noradrenaline. This stage 1 is called the alarm reaction. And when there's an adrenaline in the body, we either fight or we flight. And that is why, since you have to fight or flight, your heart rate increases, your breathing increases, the blood supply to the muscles increases. And then you go to the stage of resistance and ultimately exhaustion. Adrenal depletion occurs. Sometimes you can have a freeze response when you are paralyzed with fear. So what are the symptoms of stress? They can be any symptom. Physical, it can affect your heart. You can get palpitation, cardiac neurosis, GI, ulcers. You can get pain in the neck, in the body, headache, body ache, allergic responses, diarrhea. You can get reduced immunity. Menstruation cycles can be changed. And any medical condition, be it diabetic, asthma, arthritis, increases when you are stressed out. As a doctor, you have to understand mind and body medicine. And many of them are psychosomatic symptoms. Psychosomatic does not mean malingering. The symptoms are real. The patient is suffering, but they are due to stress. And hence we have to often differentiate. Is this organic pathology or is it psychosomatic? But one thing remember, before labeling a person psychosomatic, please rule out organic pathology. Mental symptoms. Many of you, when you're depressed with stress, you get lack of interest, lack of enjoyment, you are not able to sleep properly, you either eat too much or don't eat, you are excessively worried, you are irritable. And this behavior shows like you fight with people, you're short-tempered, you blame others, you become impatient, you do procrastination, you're not motivated to do things which you want, you may get suicidal feelings, and you can get addicted to tobacco, alcohol, and drugs. So anything which causes a change in our life causes stress. And anything which we perceive, it may be real or it may be imagined. The real stressors are external. That means you lose somebody, there's a relocation, or there's a change in environment. But most of our stress is internal, which is due to our thoughts, our beliefs, and our attitudes. The external is not under our control, but the internal certainly is. So when you talk of human performance curve, any stress which motivates or stimulates is called good stress, that is eustress. And anything which paralyzes is called distress or bad stress. So there's an inverted U hypothesis that if you see the lower graph, for optimal performance, that is known as zone of optimal performance, a human mind requires optimal stress so that there is optimal performance. If the stress is too low, the motivation is too low, you don't feel like performing. If the stress is too high, you cannot cope up and your performance goes down. So let us now understand the adolescent brain and how does it process emotions and stress. Because as an adult, we learn to cope up with our emotions and we handle stress differently. But as adolescents, it is not easy. So first let us understand how the brain of an adolescent works. The WHO definition of adolescent is 10 to 19, and those of you are first and second year students will be in this age. Those of you are higher in the final or interns or residents are young adults, that is 20 to 24. So when we talk of AYA, we mean adolescents and young adults. So when we do face-to-face, we normally have an interaction. At what age does the human brain completely mature? And do all parts of the brain mature at the same time? And the answer generally is given 18 or 21 because that's a legal age to vote and many places legal age to drive. But in the last 20 plus years, the brain imaging technologies have told us the brain does not mature till 25 to 30 years, though legally you're an adult. And the brain does not mature at the same time. It matures from behind forward. That means the cerebellum matures first and the prefrontal cortex matures last. And that is why you'll see that the coordination of young adolescents exceeds those of adults. None of us can compete in video games with you all and win. And the stars, the tennis stars, all talents is at adolescent age. What is important for us to remember, right from childhood, especially during the adolescent age, there's a constant pruning of the neurons, and the neurons which you use are kept and the neurons which you don't use are lost. This is seen in childhood. If a child does not use writing skills and is texting in UK, they found the children who came in the nursery were not able to hold a pencil and write because they are constantly doing swiping on the mobile. They could not use their small fingers. And this is what we call sanskar. What you learn in childhood, those neurons develop. So even as an adolescent, you have to learn to use your good neurons. If you start getting addicted to tobacco and alcohol, that is what will proliferate. If you have a healthy lifestyle, that is what will proliferate. So use your neurons wisely and make them proliferate in a healthy manner. So we often tell our parents when we do parenting workshops that it is not your adolescent who's a problem, but it is his developing brain. Hot emotions, instant gratification, poor impulse control, risk-taking, labile emotions, mood swings, excess sleep, late morning rising, quick to adult criticism. All this is because you are mostly working through your limbic brain. So when you become an adult, the prefrontal cortex, which is the CEO of the brain, controls your emotions. That means the control is from above downwards. Whereas when you're an adolescent and the prefrontal cortex is not fully mature, the control of the brain is below upwards. That means your amygdala or your hypothalamic limbic system. And this responds to instant gratification. And the prefrontal cortex normally controls impulsive behavior, understands consequence of actions, cares about social reputation, makes us responsible for actions. So an adult will rarely photograph himself in nude or make a video, unlike an adolescent. And then when it becomes viral, you get emotionally and psychologically blackmailed. So let us understand that what is the amygdala in an adolescent? It's very hyperactive. And that is why adolescents are always on hot emotions compared to the cool emotions of adults. So adolescent emotions are frequent, intense, short-lived, labile, and you yourself can't understand. In the morning you feel so happy, by evening for no reason you're feeling down. But of course we must say that some of the adults also are still working at the limbic system. So amygdala is the primitive or the reptilian brain. This was when we used to hunt in jungles, and when a tiger came in front of us, we had to either fight the tiger if there was no way to run, or you had to run away from the tiger. So this is a very primary source of our responses. But as human beings, we have to understand who's got the control over our emotions and our stress. Is it the amygdala, our emotional brain, or is it the prefrontal cortex? And by practice, we can learn to control our emotions through the prefrontal cortex and not get stressed out. Again, If you learn to control your emotions with the prefrontal cortex, you are rational, and this is known as high road processing. Whereas if you allow the emotional brain to control you, this is known as low road processing. It is automatic, things are not under your control. So learn to develop your prefrontal cortex and rational pathway. We all know about the dopamine. Dopamine is nirvana. People feel so happy with dopamine. But again, dopamine is primitive. Thirst, this is elevating. Sexual activity, this is a reward. But unfortunately, the same dopamine receptors are also stimulated by nicotine, by drugs, by sugary and salty snacks. One has to also understand the nucleic accumbens is the motivation which manages reward and pleasure processing. And in adolescents, this nucleus is less mature as compared to an adult. And that is why most adolescents want instant gratification with less effort. And whenever adolescents get instant gratification, where do you get it from? When you go on Facebook and you get 400 followers, in real life you may have only 5, but you get instant gratification with the emojis, with the thumbs up. And when you play video games, every level you have those balloons bursting and clapping and reward. You feel so great. So people get addicted to video games because there's so much reward and appreciation and motivation. And comparatively, unlike studying hard, working hard to establish relationships, this reward comes with very little effort. So what is motivation? We teach this to parents right from the beginning, that you have to train your children to delay gratification. And for short-term pain, you learn to have long-term things. So what happens is, for short-term pain, I would rather watch TV and eat junk food because eating healthy requires effort. But what is the long-term pleasure? I will end up fitter, healthier, and happiness. And for short-term pleasure of unhealthy lifestyle and eating junk food, what is the long-term pain? I'll be overweight, obese. I will get non-communicable diseases like diabetes and hypertension and ultimately be unhappy. So those who can look past their short-term impulses and their actions and learn to delay gratification and work harder are more happy, less stressful, and more successful in life. So let us now understand how to do stress management and how to control our emotions and learn to be happy. So ultimately, what is stress management? It's a balance between the high demand from the environment, which is stressor, and your coping skills. That means your control over the situation. And it also depends on your own capacity. Some people feel very strong. I can manage any stress. Some people feel very paralyzed. No, I can't cope up with stress. The more you improve your coping skills and the more you change your perception about stress, the more confident you will be about handling stress in your life. WHO has got 10 core life skills. This life skill education is extremely important for adolescents. In many CBSE schools, this is part of curriculum. These are coping with stress and emotions, self-awareness, empathy, effective communication and interpersonal skills, and problem solving, decision making, creative thinking, and critical thinking. Those of you have not undergone these life skills, I suggest please contact us and we'll take these programs for you. So stress leads to unhappiness and vice versa. It's a vicious cycle. So how do you deal with stress and become happy? The first step for both is a self-analysis. And you all must have heard of SWOT. Strengths, weakness, opportunities, and threats. And SWOT analysis is regularly done by corporates, by business management. And we all must do our own personal SWOT. I regularly do my own SWOT weekly and monthly basis. And based on the SWOT, you can then set your goals in life, which are SMART, specific, measurable, achievable, realistic, and timely. And you can make a SWOT and SMART goal for yourself, deciding where am I 1 year down the line 5 years down the line, 10 years down the line. You have to also analyze your own personality. Type A personality is fiercely competitive. They are high achievers, perfectionists, constantly having a need to be recognized. And these people are highly successful. But are they really happy? Most of them are constantly stressed out for the competition. Type B are more laid back. They may not be as successful, but they are certainly more happier than the type A personality. Then we have people who have inferiority complex. They have a low self-esteem, inability to say no, inability to take decisions, bottling their emotions, and they're pessimistic. They always see the glass half empty. Stress and anxiety is infectious. Everyone around a stressed person also gets stressed out. And when we are stressed out, we perceive everything as an emergency. We all know about airway breathing circulation. So practice ABC, be aware of your stress, balance your emotions, and learn to control stress. Don't try to be too perfect. Being perfect not only stresses you out, stresses the people around you. So learn areas where you should be perfect, but don't try to be perfect always. Learn the joys of imperfection. Indecision. Not making a decision is tremendously stressful, and hence, with life skills, we teach how to make a decision in a protocol manner way. If you cannot control our environment, change your response. Many things in our life is beyond our control, especially the behavior of people. Rather than trying to change your environment, change your responses. Learn to respond and not react. Major cause of stress is poor time management. Time management is a skill that needs to be learned. Many people work very hard, but they don't work smart, and that is why they do not achieve the results which they want. Pareto principle of time management is used in businesses. 20% of our time produces 80% of the results. But we have to smartly understand which is this 20% where we should be working on, which will give us 80% of the results. Each one of us should learn to make a personal priority. People ask me, how do I manage so many things over the years? Because I make my priority matrix every week, every month. And you have to classify what is urgent and important but not important but not urgent, and not urgent and not important. And for each one of us, we have to decide the categories. Majority of us do things which are most enjoyable, like social media gossip, time pass activities, TV and movies, and then the urgent things get left out. We all are used. Learn to make a time audit timetable for yourself, and you will realize how much time you waste in your 24 hours, 8 hours of sleep, and you're not using the rest of the hours productively. You can also divide your time in buckets like college, your room, your girlfriend, boyfriend, studies, parents, some social work, recreation, me time, health, etc. So whatever happens, happens for the best. All is well. Keep that mantra. Don't have negative thoughts. Differentiate between the things you can change and cannot. And this is a very well-known prayer. Dear God, give me strength to change what I can, patience to endure what I can't, and the wisdom to differentiate between the two. Don't stress out on things which are beyond your control. Make a plan. Find out what is the cause of your stress or unhappiness. Is it situational or personal? If it's personal, do emotion-focused strategies. If it's situational, problem-focused strategies. Be aware of your own symptoms of stress and negative emotions. Take help if professional if needed. There are various stress principles like HERO, happening, evaluation, response and outcome. That means if something is happening and you evaluate it positively, your response is positive and the outcome is always positive. Certain mnemonics: acknowledge as inevitable fact, appreciate the causes of stress for you, elevate with stress busters, avoid stress builders, analyze what gives you relief, alter your lifestyle. And if you have built some stress building traits like perfectionism, control freak, people pleasing, low self esteem, change those. And there are various stress reduction methods. Avoid excessive visual and auditory assault when you're stressed out. And sometimes the best way of stress reduction is do nothing, just chill. Sit and look at the sun, look at the sky, and do mindful meditation. Managing emotions and staying happy. Most people think that stress or unhappiness is caused by what happens to them. In reality, it is their own response which causes tension and anxiety. So one can always be happy and stress free if we can control our thoughts, because then we can control our behavior and our fears. So this is known as cognitive behavioral therapy. Thoughts are not in your hand, but you can control that the thoughts don't lead to emotions. And if you control your emotions, your behavior comes under control. So the event is not what makes you sad, unhappy, or stressful. Interpretation of that event. For example, suppose I give a lecture and my friend tells me that today your lecture was not that good. If I care about her, I will say, yes, what do you think? Give me some suggestions. What went wrong today? But if I have a rival and that person says your lecture was not good, immediately my amygdala jumps in. How dare he say this to me? He is jealous of me. Why should I tolerate his criticism? So the event is the same, but the responses differ depending on the prejudices and our thoughts. So if we can change our pattern of thinking, we can reduce our stress and be happy. For example, if your thoughts are I'm worthless, my future is bleak, nothing will change, I'll feel sad and I'll go into depression. If I have thoughts I'm in danger, something is terrible is going to happen, I can't cope, I'll go into anxiety. If I feel it's unfair, I've been disrespected, I won't stand for it, these thoughts will go into the emotion of anger. And once these thoughts go into emotions, chronic emotions means feelings, and then I can feel anxious and then the behavior is avoidance or escape. So what happens for a depressed person? If he gets up in the morning, he has these thoughts. There's no point. I'm going to mess up again. So this thought makes him further depressed and tired. So what is the behavior? I'll stay in bed. I'll just pull over the covers on my head and not do anything. But if a depressed person can learn to change his thoughts that no, life is good, I'm happy, I will be okay, the feelings of depression will go away and his behavior will be positive. And if you see that the moment you control your thoughts, then your feelings don't occur. If your feelings are under control, your behavior does not come. Because the moment your feelings are activated, you have adrenaline response and that gives you body reactions and your behavior changes. And it's very important to do self-talk. This may sound funny, but I've done it. Every morning when you're brushing your teeth, look at the mirror and say, today is a good day. Today I'm going to achieve my best. And this positive self-talk does have an imprint on the brain. And this has been known that if I say, I don't want to get fat, the brain hears fat. If I say I'm going to get slim and healthy, the brain remembers slim and healthy. And that is why talk positive, self-talk. Your brain also gets activated for self-talking. And always learn to have the builder talk and not the stress buster talk, not the builder talk. Learn to say, I will stay focused and do my work, not say I'll never be able to do this. You can see here that whenever you are moderately stressed, you are still in tight control about your thoughts and emotions. And when you are very much stressed, the chemicals can flood the brain and the amygdala comes into amygdala hijack and you cannot work well. So our yoga and meditation, as I said, has gone into the Western medicine as mindfulness. And that's why our mind should not be full, but we should be mindful of whatever you're doing. Enjoy your eating, enjoy your sleeping, enjoy your talking. Whatever action you do, be into the moment, be mindful. That will make you happy and less stressed out. Now, very often, we are faced with sad situation. Kubler-Ross cycle, stages of grief cycle was mainly brought out for cancer patients and dealing with death. But this can be used even for the day-to-day disappointments which we have in life. For example, you wanted to get very good marks in the exam, somehow you didn't get it. You didn't get into admission in something you wanted. You wanted a relationship, but that girl or boy didn't respond to you, or a relationship somehow got broken. What happens in the initial stage? You are in shock and denial. Then you get angry. Then you feel depressed. Then you start bargaining. I'll go to God and I'll do these somvars and all that. And ultimately, you come to acceptance, where you now become empowered to return to meaningful life. Sometimes, when you're going through some sad situation or disappointment, you may again keep switching from anger to depression to bargaining. But what we have to realize is ultimately, whenever there's a negative disappointment or negative feeling or a loss of somebody in COVID situation, many people had to go through this grief cycle because they lost loved ones. But ultimately, we have to learn to accept and return to meaningful life. And though the emancipated women today don't believe in Venus woman and Mars men, and they feel it's nature versus nurture. That means women, if they're brought up equally, they'll be just like men. But old-fashioned people like me still know that there's a different wiring about women and men. And when you see handling of negative emotions or grief, women express their feelings. They have a network of girlfriends, sisters. They express their feelings and they're more able to talk about the feelings. Whereas men intellectualize their emotions. Very few men go to a counselor. Women are more okay to go to counselor and seek help. Now, all of you are under stress, whether it is physical stress. You all have, of course, passed puberty, but you still have body image issues, romantic relationship issues, family issues, medical illnesses, society, norms and expectations, judgmental attitude, nosy relatives, school and college pressure, family, academic pressure, values, parent and peer conflicts. And what happens when you as adolescents get stressed out? And for the last 2 years, we are seeing the news on the TV. How much drug abuse has increased in the youth of India. It is scary what the new generation is going through. And we know that compared to adults, the incidence of drug use is much higher, children and adolescents. Who are the people more likely to go into abuse and addictions? People who feel hopeless, that means depression, psychiatric illness. People who have a lot of anxiety and not able to cope up with their emotions. People who are impulsive because they have ADHD or neurodevelopment disorders, or they have a lot of money so they can just impulsively do anything. And thrill-seeking personalities who want life to be just bungee jumping all the time. How do most adolescents deal with stress? When they're feeling low, what gives them instant relief? And why does this happen? They will have junk food, caffeine, tobacco, smoking or chewing, alcohol, substance abuse, or internet. Why? Because all this gives instant pleasure. This is the dopamine reward pathway. And we know that the dopamine receptors are the same. You can see sugary food or sugary drink stimulates as much as cocaine. And once you get used to this reward motivation addiction, one addiction gets replaced by the other. If you give up smoking, you will start eating junk food. If you give up alcohol, you will start smoking. And hence we have to learn not to activate this reward pathway by addictive drugs or addictive activities. The social media is a new cocaine, and the reward center of the brain lights up the more likes you get. Why do teenagers enjoy social networking so much? But only few get addicted. Who are the ones who get addicted? Those teenagers who do not find fulfillment in real life, whether it is academic or other success, whether it's emotional relationship with parents, peers. This virtual stage or the real life gives them a chance to be an avatar, where they can be somebody, they want to get recognition, appreciation, large number of friends. So if you want not to be an internet gaming addict, learn to find happiness in real life so you will not a virtual life. And in D.Y. Patil Medical College, we have peer educators trained by Aki, and we go to schools and we teach them the do's and don'ts and the positive and negative of the digital world. So to feel good, we learn to have the neurotransmitters, dopamine, by healthy ways. Exercise, walks, music, dancing, talking with loved ones, hugging, not just your girlfriend or boyfriend, your mother, your grandmother, your pet. Outdoor, indoor games. Now we can't have outdoor, but yes, indoor games. Reading good books, jokes, poems, and drawing and painting and other talents. Now we all know that when you eat healthy food, it does not give you instant happiness, but it gives you satiety, feeling of full. So normally when you eat 1 or 2 oranges, you don't binge on 10 oranges or you don't binge on 4 bowls of food or salad because you don't get craving for healthy foods. And if you want your dopamine, try to have foods which are rich in tyrosine, which increases your dopamine like almonds, bananas, avocados, etc. Why do we feel like eating junk food again and again? High salt, high sugar, high fat. Because this gives you instant dopamine and you learn to get sugar salt craving. Can anybody stop eating 2 chips? You can eat 2 packets. So hence, this gives you a craving and you start seeking for snacks at the same time. Create your own dopamine and your neurotransmitters by healthy life. 8 hours good sleep every night replenishes the body dopamine. Healthy eating gives you a sustained release of dopamine. Regular exercise gives you endorphins. Why depend on outside stimulants and unhealthy habits to make you happy and stress-free? Tobacco and alcohol are gateway drugs. Research has shown those who consume tobacco or alcohol are more likely to go into drugs and also risky behavior like unprotected sex. And today, unfortunately, smoking and drinking has got acceptability. And as adults, we feel so shocked and we feel so sad when we see the younger generation taking these vodka shots and going into hookah parlors and binging on these unhealthy habits. So why do teens smoke? Curiosity, experiment, friends, being part of gang, boredom, loneliness, role models in films, keeping slim because smoking models always smoke, looking havoc, and of course if you have psychiatric problems. Why do teens drink? Same, relieving stress, feeling good, lack of emotional connection, overcome some mental problems, cope with sorrow and rejection. And then you come into young adults. There are a lot of factors where by starting smoking and drinking in adolescent, it becomes a pattern. You become addicted. It becomes a social thing. Drinking and smoking is being hip, being in the upper class of the society. And peer pressure, work, many multinational companies have a high stress profile. And you'll see though smoking is prohibited in public areas, they have a smoking balcony and they take such frequent breaks to continue smoking. So tobacco experimentation, unlike adults, it has been now found that even one single cigarette can start the pathway of nicotine addiction. And teenagers and adolescents get quickly addicted to alcohol. So every adolescent should be reminded, especially those who take drugs, that the colors and the ecstasy of floating may be good to resist, but you're killing yourself inch by inch, day by day, and killing your family also. It's not easy to have an addict son or a daughter. And as doctors, we have enough evidence by MRI and brain images of the harmful effects of alcohol, nicotine, drinking, and the teenage brain which is developing. It has been well seen that those who drink at 14 years or below 21, the hippocampus, which is our memory, which is so important for academic progress, is reduced, and hence we must ourselves avoid teenage drinking and adolescent drinking. Otherwise, what right have we got as doctors to tell our patients not to smoke and drink? And it has been well documented that nicotine receptors start proliferating when you start smoking as a young teen. And once proliferated, they don't go back. It's like our obesity fat cells. They never go away, they only shrink and they can become fat anytime. So once you proliferate your fat cells, you can be fat for life. Similarly, once you proliferate your nicotine cells at a young age, you're more likely to be a chronic adult smoker. And most people know about cancer, but cancer is only one of the aspects. Remember the World War days when the soldiers were given packets of cigarette as part of their ration, because nobody that time realized the harmful effect of nicotine. Nicotine is called lady nicotine because it first stimulates and then it paralyzes. Every artery in our body goes into spasm with nicotine. So you have 30-year-old needing bypasses, kidney failure. Take any part of the body and nicotine affects it, including gangrene. And hence, we do a lot of awareness programs in schools and colleges that experimentation with tobacco and alcohol will be a killer for you. Secondhand smoking is equally bad. There are many teenagers who say, no, we don't smoke. But if their friends say, do you mind if I smoke? They think it's cool to say, okay, I don't mind. No, secondhand tobacco smoke is even worse than primary smoking. And you must not allow people to smoke around you. And now we know that secondhand tobacco smoke causes problems and inflammation, and we can get more prone to inflammation and endothelial dysfunction and cardiac issues. And again, we did not know that how much damage alcohol causes. We only knew about cirrhosis and delirium tremens. But like tobacco, over the years now we know that alcohol also can affect every part of your body, including many cancers. And you can use this craft screening to understand your own addiction. And if you have got more than 2 points, you know that you need to see a psychiatrist. Now, girls are more affected when they drink. I'm not trying to be a gender biased person that women should not smoke or drink, but I would just like to bring to notice that women metabolize alcohol differently and they achieve higher concentration of alcohol at a lower level. And if you see non-drinker women, they have less incidence of heart attack and other cancers, but women who drink have a higher incidence of cancers. And secondhand tobacco smoke affects infants. They have increased asthma, pulmonary function decrease, ear infection. And if a woman is pregnant and she smokes, there are stillbirth, SIDS, sudden infant death syndrome, prematurity, low birth weight, can be even infertility. So a woman, if she decides to be a mother, has to be very careful that she doesn't smoke during pregnancy and in front of children. And now we have a concept of third act tobacco smoke. That means if you go to a bar and the smoke is lying on the table and you touch it, you can inhale it. And most important, in the past, there were a lot of levels. How much can a pregnant woman drink? How much pegs are safe? Now it has been found that alcohol is not at all safe in pregnancy, and we are getting more and more cases of fetal alcohol syndrome. And hence, if a woman is addicted to alcohol and she gets pregnant and she can't leave it, it's very unfair. You bring a baby with fetal alcohol syndrome. As you bring a baby, cocaine addicts bring out a jittery baby syndrome. So now let's come, what is the importance of healthy lifestyle? Because it helps us to manage stress and emotions and helps us to stay happy. And we have the concept of mind-body medicine. We have now specialists and there are conferences held on this. And we know that if we can keep our emotions under control, then we can have proper neurotransmitters. And many diseases whether it is heart, whether it is endocrine or GI, that triggered by an unhappy mind and an unhappy lifestyle. And mental stress can lead to addictions, and it can lead to obesity, and it can lead to high blood pressure and non-communicable diseases. So bad lifestyle has to be stopped because WHO also has seen 4 behavioral factors in adolescent: unhealthy food, lack of physical activity, tobacco and alcohol leads to high incidence of adult NCD. So I don't have to teach you about diet. We all are doctors. We need to understand to take a very balanced and nutritious diet. We all need to do exercise, and exercise doesn't mean going to gym or doing sports. During COVID, we all have realized that we can continue physical activity at home: yoga, aerobics, Zumba dancing, putting a tape, stretches, just household work, just household cleaning. So many of us are doing utensils, washing, household cleaning. All that is physical activity. And the human body requires 30 to 90 minutes of physical activity per day. Not taking a lift and climbing stairs is also physical activity. And as doctors, we must understand the circadian rhythm. And in the past, when there was no electricity, we all slept when the sun went down, and we all got up when the sun rose. And this kept our biological clock going in a proper manner. But today, with the advent of electricity and all the gadgets, many of us are not following this circadian rhythm. And we are awake late into night, texting, binging, and the blue light of the screen reduces our melatonin syndrome, our secretion, and we are getting sleep disorders. And this is affecting our entire body cycle. And we know that if you follow the circadian rhythm, your entire body system, your endocrines, they remain in optimal function. And sleep deprivation, again, affects every part of your body, whether it is your heart, your muscles, your brain, and there's a risk of type 2 diabetes. It suppresses your immunity. And this is especially important for interns and resident doctors. Now there's a big science which studies what happens to the disturbance of circadian rhythm in shift workers. And this is known as shift work disorder. And they have seen that if you have sleep deprivation, 2 weeks of 6 hours is as bad as 2 full nights awake. And hence, if you are resident doctors and you are in night shifts, please take care that you don't accumulate this sleep debt. And best sleep is 10 to 6 a.m. because that is the body circadian rhythm. If you can't achieve it, you at least try to take over that you don't get sleep debt syndrome. You can see the cat here also is so zonked by continuous watching the TV. And shift worker syndrome can affect every part of your body. It is known to cause menstrual difficulties, some menstrual cancers of the gynec system. It is known to cause anxiety, depression. It is known to increase your cardiovascular risk factors. So please take care that you have adequate sleep. And I love this thing by Vivekanand. Mind is not a dustbin to keep anger, hatred and jealousy. It's a treasure box to keep love, happiness and sweet memories. And the first thing you have to learn to let go. Let go your anger, your jealousy, your hatred, your stress, and don't keep an emotional baggage. You know, when you are just going to a shopping and you're coming so with a heavy shopping bag, don't you realize how heavy your steps become? So if even physical baggage causes you stress, imagine if your mind is full of negative emotional balance. It's like an attic full of garbage. Learn to clean that attic every day. Learn to get rid of your negative emotions and keep positivity in your mind. That will keep you stress-free and happy. And acceptance is the key to handling life well. If there's an undesired event and you don't accept it, you get angry. You accept your tolerance. If there's uncertainty and you don't accept it, fear. So many people had gone into corona anxiety and fear. But if you accept it, it becomes an adventure. How to learn happily during the COVID period. If there's a bad behavior towards you, if you don't accept you get hatred and anger and revenge. If you accept, you forgive and move on. If you see success of others and don't accept, you get jealousy. But if you accept, you get inspiration. Let me be like that person. And I think WhatsApp and mobile has taught us a very important message. Whatever makes you happy, save it. Save your happy memories. Save your enjoyable moments and treasure them. And make a collage in your mind, or you can make it on your desktop also. All the happy memories, your lovely relationships, the lovely holidays. So whenever you feel stressed out or you're unhappy, open this collage and relive those happy memories. Whatever can make others happy, forward it, share jokes, share inspirational quotes, and whatever makes no one happy, things can hurt others, things which are bad about others, just delete them. Delete them from your mobile, delete them from your mind. Thank you so much. It's a pleasure having given this lecture.
Thank you, ma'am. It was such a relaxing and stress-busting session. You found time for us through your precious and tight schedule. It was an honor to hear you, and I think this has added a real glory to our Respirare conference. I'm sure that all of us would utilize this knowledge about stress so that we can overcome and face every challenge that gives stress to us. Thank you. Thank you once again.
Thank you so much for inviting me. It was a pleasure to address all of you.
Thank you, ma'am.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स हैं इनके वैल्यू सारे तीन मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करने पड़ेगा कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walking.
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis, but which kind of episodes, everybody? Chronic episodes.
We have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in two axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, it is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or bro presentation.
They're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I have given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich's test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added, and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
As I was looking at the file, maybe I was half sleepy. Something interesting happened. The file just slipped off my hand and fell. What happened was, when the file went and fell down next to the child suddenly startled. The moment the child startled, my sleep went away. I was wondering what happened. I just took the file again, put it down again. The gush of air, another startle. That's when my brain tickled and said, could it be something which we are missing? I took a water bottle nearby, poured water next to the child. The child started gasping and startling. That is what we call as hydrophobia. Most important point was this.
Stop your A very warm good morning to everyone present here. I, Rutuja Sawan, second year MBBS student, would like to welcome you all to Respirare 2021. Martin Bose Savant rightly said, be able to analyze statistics which can be used to support or undercut any argument. Being able to interpret and implement research articles as a doctor has become a need of ours in this evidence-based era of medicine. But research enthusiasts and medical students often find it difficult to, in the biostat section of research paper or article. To gain insight into this arena of biostatistics, Team Respirare 2021 proudly welcomes Dr. Nikhil Gupte, the Director of Biostats and Data Management Center for Clinical Global Health and Education at Johns Hopkins University and JHU, India. Sir will introduce us to biostatistics and its utilization in clinical research. Dr. Nikhil Gupte, the Director of Biostatistics and Data Management Center for Clinical Global Health and Education, Johns Hopkins University and JHU, India. Dr. Nikhil Gupte did his undergraduate and postgraduate studies in the discipline of biostats from University of Pune. Then he did his PhD in biostats from Johns Hopkins University. He has over 20 years of experience in public health research, clinical trials, data analysis, and data management. He worked primarily on US NIH, US FDA, Department of Biotechnology, ICMR-funded clinical trials for HIV and tuberculosis. He has teaching experience at Johns Hopkins University and Statistics Department at the University of Pune, India. In collaboration with SGPI MER, Lucknow, he conducted several workshops in biostats and research methodologies. He has authored and co-authored several manuscripts in peer-reviewed journals. He has received the prestigious awards like Helen Abbey and Thomas Dublin from JHU for excellence in teaching and research, respectively. He has been inducted in the Delta Omega Alpha chapter of the Johns Hopkins University. He is the lead statistician on several NIH, FDA, CDC, ICMR, DBT-sponsored studies in HIV or AIDS and tuberculosis. We heartily welcome you, sir, and now I would request you to take it over from here.
Well, thank you very much for those kind words and introduction. Let me share my screen so that I can start my presentation. Let me know once you're able to see my screen. Are you able to see the screen okay?
Yes, sir.
Great. Well, thank you very much again for the introduction and inviting me to this conference. Because of the current scenario that's going on with COVID, unfortunately, I was not able to be there in person, as I myself have started getting some symptoms over a couple of days back. So I decided to do this online. So I have my contact information on the screen. So in case anybody needs any kind of help with their research studies or statistics or interpretation of your data, please feel free to touch base with me, and I can help you in whatever you need. I have been working with leaders from BG Medical College for the past 20 years, and it has been a fantastic and a wonderful collaboration, I must say. I will not be able to cover everything of statistics in today's talk, which would probably last for like 30 to 40 minutes. However, this might give you a flavor of how statistics can be used in medical sciences, and what are the different tests that have to be used, and what are the different conditions that need to be looked at before you start any kind of research study. But as again I said, that I'm based in Pune. My contact information is there on the screen. In case you have any problems, or in case you have questions about your existing studies, please feel free to touch base with me. Let's start with the most important slide, research question. And I'm going to start over here with a motivating example. I wanted to paint my house, and this is something regularly what people do. And so I also decided to paint my house. My neighbor, whose house is exactly the same as mine and had recently painted his house, I asked him a question: how many buckets of paint did you buy? And his answer was very simple, straightforward: 10 buckets. At the end of the painting exercise, I had 2 unopened buckets, and I met my neighbor again and told him I had 2 extra unopened buckets of paint. And he said that happened to you as well. What happened over here? What happened is I asked the wrong question. My question should have been, how many buckets of paint did you use? So if you see in your day-to-day life also, if you ask the wrong question, you will not get the right answer. So it's absolutely important for medical sciences or clinicians and young researchers like you to ask the right question so that you can collect the right data to answer it. So again, I said, ask the right question. An imperfect and an incorrect question would lead to misinterpretation of study data. The research question that you select, or research question that you want to answer, would drive the following. It would drive the right study design to use, what should be the sample size, what should be the data collection tools, what should be the analytic methods to use, and how you should report your results. So let's start. Look at an example. So this is the oldest, biggest randomized controlled trial that was conducted in public health history, and it is called the polio vaccine trial. In this the polio vaccine trial was conducted in 1954, in which the school children, approximately 400,000 of them, were randomized to receive either the polio vaccine or the placebo. As you can see on the slide, exactly the same number of children received the vaccine, and approximately the same number of individuals received the placebo. What we see at the end of the study is that those in the 82 in the vaccinated group got polio, and 162 in the placebo group got the polio. What are the design features of this trial? One, let's start with the research question. The research question was, is vaccine effective in reducing the number of cases of polio as compared to a placebo? There was a comparison group. The placebo is a comparison group, which is absolutely important because you cannot just use the vaccine on everyone and say that the vaccine was effective. So a comparison group is absolutely necessary. The study was randomized. What it means is that the individual or the investigator did not have any bias in assigning the vaccine or the placebo to the school children. And taking care of this bias is absolutely important, because if you assign treatment in a biased fashion, then the conclusions that you make from this study cannot be generalized. It was a placebo-controlled trial, which means that the second group of individuals, a second group of school children, did not receive any drug. Nowadays, there are treatments available for almost everything. So ethically, it's not possible to conduct a placebo-controlled trial, but a placebo-controlled trials are always wanted. This was a double-blind trial, which means that not the investigator nor the recipients knew what they were getting. Only the statistician was aware of the random treatment assignment. And the objective of the study was that the two groups were equivalent except for the factor of the vaccine. That means the school children in both the groups were exactly similar in their characteristics, and the only difference among them was the vaccine. So which means that this is necessary to do is because if there are more number of polio cases in the placebo group, those can be attributed to the placebo and not to the vaccine, and or not. Well, the question is, there are almost twice as many as polio cases in the placebo as compared to the vaccine group. And could this result be because of chance, or was there an actual difference? As you saw in the earlier slides, in the vaccine group we had 82 cases. Statistical methods may tell you how to make the probability calculations whether the imbalance in the vaccine and the placebo group is because of chance. Now, these are the typical steps that are involved in a research project. Once you have a research question, then you start some planning on selecting what study design should be used. Then comes what data collection methods are to be used, then the data analysis part, then the presentation part, and then the interpretation part. So this is a 5-step process in which a statistician can help you in every step. However, most of the time, the statisticians are only called for the data analysis part, and the earlier 2 points are completely forgotten. So the damage is already done over here in the first 2 parts, and the damage is irreparable. And if the statistician is called at the point of data analysis, the statistician can help you only answer the question what the study died of. The topics I intend to cover are relatively straightforward. We'll talk about what are the different types of data, what does testing of hypothesis means, what is a population and what's a sample, and what are the common statistical tests that can be used for answering most of the research questions. And we're going to talk about study designs a little bit and what are the measures of association that can be used in any kind of study design. As again, I said that in the 45-minute session, we cannot possibly cover everything, but this might give you just a sense of what biostatistics is and maybe help you in understanding research articles a little bit. Types of data. So I'm going to run through the slides very quickly because most of you will be familiar with this. You might have studied this in your biostatistics sessions during the preventive medicine courses. So there are typically 4 different types of data. One is binary data, which we collect very often. Second one is categorical data. Third one is continuous data. And the fourth one is time to event data. Binary data, or often called as dichotomous data, are often data which are yes/no type, like whether you had polio, yes or no, whether you got cured, yes or no, what's your gender, male or female. Or if you have to ask a question that is a subject male, then the answer could be yes or no. So whenever you have yes or no data, then these data are typically called as binary data and are most commonly collected in medical sciences. Then there are categorical data which has more than one category, like place individuals in different categories. For example, nominal categorical data where you have categories as race, country of birth, what is the religious affiliation, where you have more than 2 categories. And then there is what is called as ordinal categorical data, which is usually collected on Likert scale. Like, for example, what is the degree of pain? It is more severe, moderate, less moderate, none. So these are called as Likert scales. So these are called categorical data. Then there are continuous data, like, for example, blood pressure, weight, height, age, income. And most of the time what happens that continuous data need to be converted into a binary categorical data for purposes of analysis. Like, for example, if you're looking at blood pressure, a continuous blood pressure may not be as informative as whether you have hypertension. So you might want to classify the data as, say, whether the hypertension systolic was more than 120. So that you know that continuous data is converted into a more interpretable data variable, which is hypertension. Similar to, like, for example, diabetes. If your fasting blood glucose is your fasting blood sugar is more than 120 or less than 120, because just the fasting blood sugar, for that matter, is not of information to us. It will just give you a number, but for analysis purposes, you might want to classify them whether they have diabetes or not, which is more of a variable that can be interpreted very easily. Other examples of continuous data are age, income levels, height, etc. And then there is this interesting type of data which is called as hybrid data or combination data, where you look at a discrete and a continuous variable. Like, for example, let's take the scenario for the COVID patients who were admitted to the hospital. So we are looking at a variable which is, say, time to discharge or time to death. So whether once the COVID patient is admitted to the hospital, the patient either dies or the patient has survived and got discharged. So the time required for the patient to either die or patient to survive and get discharged is recorded. So the outcome of interest over here are both the time required, the time spent in the hospital, and what the outcome was. So this is the combination data, which is called survival type of data, where we are interested in looking at time to a certain event. Now, why it is important for us to know what data type is? Because the type of the data that you have collected will decide on the statistical method that has to be used for analysis. You cannot use analysis methods for continuous data for binary data. So different statistical approaches are required depending upon the type of data that you have selected. Like, for example, if you want to look at the polio trial, then the test that is typically used would be a Fisher's exact test or a chi-square test. But if you're looking for continuous data, for example, if you're looking at certain blood pressure lowering agent, then you want to look at the average blood pressure in two groups, then you would possibly go with a two-sample t-test or a Wilcoxon-Ransom test. So depending upon the type of data, you decide the statistical method that has to be used for analysis. So let's look at what is a population and what is a sample. Now, you often must have seen your mother cooking in the kitchen, and what happens typically is that once a particular food item is prepared, your mother or you might be taking a small portion of it and tasting it for adequacy of salt and taste. So the portion that you take is a sample, and the population is the entire food item that has been prepared. So what you do is basically from the sample, you draw conclusions about the population, right? I mean, you taste the food item and see whether the salt or the spices are properly incorporated in the primary dish, which is the food item that has been prepared. So a sample is nothing but, in statistical terms, a sample is nothing but a subset of a larger group, which is a population from which information is collected to learn about the larger group. So it's impossible to study the entire group. So often you take a sample, which is a representative sample from the population, and you study the sample and you assume that the sample is properly collected and apply the conclusions that you draw from the sample to the population. For example, a sample of blood pressure of 5 18-year-old male college students in India. The population is nothing but the entire group for which the information is wanted. For example, the blood pressure of all 18-year college male students in India. As you can see, that it's impossible to study the entire population. So you draw a sample and you basically make your studies or conclusions on the samples and apply them to the population. Okay. What is random sampling? For studies, it's optimal if the sample which provides the data is representative of the population under study. It's always not possible, because if you want to study 18-year-old male college students in India, you probably will do the study in your own college. You may not even go to other colleges apart from your college in Pune. So the sample that you select is not a representative sample. It is not always possible, but this sample is a good enough sample. Now, one way of getting a representative sample is called a simple random sample, a sampling method in which every possible subsample of size n from a population is equally likely to be selected in the sample. Think of this as if you're putting all the names of the students in a hat, and then you basically draw each chit from the hat to ascertain what their characteristics are. So you might have heard of terms as sample mean and sample standard deviation, or mean and standard deviation. So as the sample has the mean and standard deviation, the population also has the mean and standard deviation, and the population mean and standard deviation are called mu and sigma. The sample standard deviation are called x bar and s. What we are trying to do over here is, based on the data that is collected in the sample, we estimate x bar and try to make conclusions that how close is x bar to the mu, or what is there any difference between x bar and mu, so that you can make conclusions about your population based on a sample. This problem is called as a testing of hypothesis problem, where you have a sample, and on the sample you measure your statistic, x bar and mu, and you draw the inference of the population from the sample of the population parameters, which are often called as mu or sigma. So a testing of hypothesis is a procedure for making inferences about the population based on a sample. Hypothesis testing often allows us to determine whether enough statistical evidence exists to conclude that a belief about a population parameter is supported by the data that you have collected. Often there are two hypotheses. One is called as the null hypothesis, and other one is called as the alternative hypothesis or the research hypothesis. Null hypothesis is typically pronounced as H0, and the alternative hypothesis is usually written as HA. So the alternative hypothesis is basically your research question. So the null hypothesis always starts with that there is no difference. To give you a parallel example, in a court of law, when the criminal is standing in the court of law, the judge often starts with the belief that the criminal is not guilty, or the person standing over there is not guilty. And the lawyers, they basically provide evidence or create evidence to prove otherwise, or prove that the criminal is guilty. So this is exactly what testing of hypothesis is. You basically start with very safe saying that there is no difference between the two groups, or there is no difference between, or the drug is not effective, for example, and then you basically create evidence or collect evidence over here is data to ascertain whether the drug is effective or not in treating a particular disease. Now let's talk about different types of statistical tests. Now I'm going to do this slightly differently. Instead of giving you several formulas over here, I've decided to motivate this session using different kind of examples. I'm going to try and use as less as formulas as possible, so that the session is not too boring. And anyway, as medical practitioners or medicine experts like you all, you would hardly use a formula for calculating anything, and you would often probably use a statistical software or take help from a statistician to do the analysis. Let's talk with the most common test that has been used and the most favorite one, which is the paired t-test. And let's look at the paired t-test by using this motivational example. Okay, 1 second. All right. So paired data are nothing but data that are collected in a scenario where we have a before and after scenario. For example, 10 non-pregnant premenopausal women in the age group of 16 to 49 years old who were beginning a regimen of oral contraceptive use had their blood pressures measured prior to starting of oral contraceptive use and 3 months after consistent use of oral contraceptives. The goal of this small study was to see what, if any, changes in average blood pressure were associated with the oral contraceptive use in such women. The data on the following slide shows the results of pre and post oral contraceptive use systolic blood pressure of the 10 women in the study. So you have your data collection done. There are 10 women in the study. We have blood pressure that was measured before oral contraceptive use, and then the blood pressure that was measured after oral contraceptive use. And the third column is nothing but the difference in the blood pressure that was measured before and after. The mean blood pressure before oral contraceptive use was 115.6. The mean blood pressure after oral contraceptive use was 120.4, and the difference in the blood pressure was 4.8. So we want to set up a null hypothesis and alternative hypothesis. So we start with the null hypothesis saying that oral contraceptive use had no effect on the change in blood pressure, which means that the mean blood pressure before and the mean blood pressure after were very similar to each other, or there was no change in the blood pressure, which means that the mu, which is the difference in the blood pressure for before and after, is equal to 0. And the alternative hypothesis is whether mu is not equal to 0, which means that oral contraceptive use had some effect on the difference in the blood pressure pre and post. we will use the results, or we will use the data or the evidence from the study to choose whether the null hypothesis is true or the alternate hypothesis is true. We are not going to do this analysis using a calculator. We are going to use the statistical software. And the software that I have used over here is called Stata. Any statistician will use a software to do the analysis. Irrespective of the software that you use to do the analysis, the results will be very similar to each other or approximately the same. Let's understand what we see in the output over here. We had 10 observations. The mean difference was 4.8. The standard error of difference was 1.5. The standard deviation was 4.6. And this is what is called as a 95% confidence interval, which we can ignore for the time being. And then what we have is p-value. And here you often must have heard of the term p-value. And p-value over here is 0.009. And if you want to round it off, it is 0.01. Based on the p-value, what we can conclude is that since the p-value is less than 1, we decide to reject the null hypothesis, which means that reject the hypothesis that oral contraceptive use had no effect on the change in blood pressure, and we accept the alternative hypothesis, which says that oral contraceptive had some effect in the change in blood pressure, and since the difference was positive, it had a positive effect, which means that use of oral contraceptive actually increased the blood pressure among women who were in the study. So the interpretation of this data is if the true before oral contraceptive use, after oral contraceptive use blood pressure is 0 among all the women taking oral contraceptives, then the chance of seeing a mean difference as extreme or more extreme as 4.8 in the sample of 10 women is 0.009. When you're writing this up in your manuscript, this is what is expected of you to write. Blood pressure measurements increase on an average 4.8 millimeters per hemoglobin with standard deviation of 4.6. The 95% confidence interval of mean change was 1.5 to 8.1, and we will come back to that in a second, how to interpret that. The blood pressure measurements after oral contraceptive use were statistically significantly higher than before oral contraceptive use with a p-value of 0.009. Now, what does the confidence interval mean when you're talking about 1.5 to 8.1? So remember, we have used a small sample of women to study this, and you make a conclusion about the population. But we cannot make a conclusion of such a large population based on just a small number. So what the confidence interval means is that in the population, the difference in the mean blood pressure will be as low as 1.5 or as high as 8.1. What we have given is the range of what the difference in the population will be, and this will be correct 95% of the times. So that's what the interpretation of confidence interval is. In your discussion section of the manuscript, you will write, a limitation of this study is that there was no comparison group of women who did not use oral contraceptives use, which is obvious. We do not know if the blood pressure may have risen without the oral contraceptive use. And to answer this question, you need a rigorous study or what is called as a huge cohort study to assess whether there was any effect of oral contraceptive use on increase in blood pressure on these women. So a paired design is typically done to generate a bigger hypothesis or a bigger research question. Another test that is commonly used are for comparing 2 or more independent populations. There's a 2-sample t-test, which you must have heard as unpaired t-test, and there's something called as ANOVA when it is used when you are comparing more than 2 independent populations. Let's talk about a 2-sample t-test. Again, we can start with an example. A low carbohydrate as compared to a low fat diet in severe obesity. 132 severely obese subjects were randomized to one of the 2 diets. Subjects were followed for a period of 6 months. At the end of the study period, subjects on a low carb diet lost more weight than those on a low fat diet. The 95% confidence interval for the difference in the weight loss between the groups was minus 1.6 to minus 6.2. And the p-value was statistically significant. So the scientific question here is the weight change associated with a diet type? So if you look at the null hypothesis here will be the diet type did not have any effect on the weight change, which means that the weight loss in the low carb diet was similar to weight loss in the low fat diet. And the alternative hypothesis here was the weight loss was different. We had 64 individuals that were randomized to a low carb diet and 68 that were randomized to a low fat diet. Mean weight change in the low carb diet was 5.7 and in the low fat diet was 1.8. The standard deviation was higher in the low carb diet, which is 8.6, and in the low fat diet, it was 3.9. Now, if you have to write this in terms of statistics, then you will say mu1 is equal to mu2, where mu1 is the mean weight loss in the low carb diet, and mu2 is the mean weight loss in the low fat diet. And the null hypothesis is that the mean weight loss in both these groups was same. And then the alternative hypothesis is that there were difference in the weight losses, which is our research question. Again, you would use a statistical software to do this analysis, and what you get over here is a 95% confidence interval and a p-value. Now, if you want to describe this study in the statistical methods section, it would go as follows. We randomly assign 132 severely obese patients to a low carbohydrate restricted diet or a calorie and a fat restricted diet for comparison of continuous variables between the two groups. We calculated the change from baseline to 6 months in each subject and compared the mean change in the two diet groups using an unpaired t-test. The results say that subjects on a low carbohydrate diet lost more weight than those on the low fat diet, with a 95% confidence interval of the difference in the weight loss to be 1.6 to 6.2 with a p-value of 0.001. What this confidence interval says that if you are looking at this analysis in a population, the difference would be as low as 1.6 or it would be as high as 6.2. Now, sometimes we often have a situation where we are looking at more than two groups and not just two groups. So what do we do in such scenarios? When we are comparing two or multiple groups, what we resort to is what is known as the analysis of variance. And some of you might have heard this term already. Let's take an example. Suppose you're interested in the relationship between smoking and meat expiratory flow, which is a measure of pulmonary health. Suppose you recruit study subjects and classify them into one of the 6 smoking categories: non-smokers, passive smokers, non-inhaling smokers, light smokers, moderate smokers, and heavy smokers. You are interested in whether difference exists in the mean expiratory flow among these 6 groups. The main outcome variable over here is the mean expiratory flow, which is measured as liters per second. And now one strategy is that we perform several 2-sample t-tests, but this is not the best strategy because you'll end up doing 15 comparisons and you may not have time to do so. So is there a way that we can catch all in the same time or catch all at once? Something which will tell us whether there were any differences among the 6 groups. If so, you could then, if there were differences, but in the 6th group, but then there's no other option for us but to do each pairwise comparison. Analysis of variance is often called as one-way analysis of variance because there's also two-way analysis of variance. There's also a multi-way analysis of variance. For example, if you want to do the same study by gender, then you would have 2 categories of gender and you will have 6 categories of different types of smokers. And then that will be a two-way analysis of variance. If you want to do it by smokers, gender, and BMI, then you have 3 categories of BMI, say underweight, normal, and overweight. Gender at 2 categories, and then smoking at 6 categories. Then this will be a 3-way ANOVA. But in this case, we are looking only at a one-way ANOVA, where we're just looking at the effect, whether there was any effect of smoking on the mean expiratory flow. Uh, the ANOVA compares the means amongst two or more population with just one test. The p-value from ANOVA helps us to answer the question, are there any differences in the mean among the population? The general idea of ANOVA is that we say that the null hypothesis is mu1 is equal to mu2 is equal to mu k, where mu is nothing but the mean of the group 1, mu2 is mean in the group 2, and mu k is the mean in the k group. And in this particular case, our k is 6. And the alternative hypothesis over here is that there are at least two groups where the mean differs. We are not going to do the calculation of ANOVA over here, but I'm just going to give you an example. A sample of over 3,000 persons was classified into one of the 6 smoking categories based on responses of smoking related questions. These were the different categories of smokers. From each smoking group, a random sample of 200 men was drawn, except for the non-inhaling smokers, where we only had 50. FEF measurements were taken on each of these subjects. And what we observe is these are the means and these are the standard deviations with the samples of the mean FEF levels, which are measured in liters per second. As expected in the non-inhaling smokers, the mean FEF levels are very high, which is expected. And as the smoking level increases, the FEF level changes. So based on this one-way analysis of variance, the statistically significant difference in the mean levels among the 6 smoking groups with the p-value was 0.001. So what it means that the FEF levels by the smoking categories differs. So if you're a smoker, then you're expected to have lower levels of mean FEF. How do you write the statistical methods in the manuscript for this? 200 men were randomly selected from each of the 5 smoking classification groups, as well as 50 men were classified as non-inhaling smokers for study design to analyze the relationship between smoking and respiratory function. Statistical methods, analysis of variance was used to test for any difference in the FEF levels among the 6 groups of men. Individual group comparisons were performed with a series of 2 sample t-tests, and 95% confidence intervals were constructed for mean differences in the FEF between each combination of groups. Analysis of variance showed statistically significant differences in the FEF levels. The 6 group of smokers, non-smokers had a highest mean FEF values at 3.78, and this was statistically significantly larger than the 5 other smoking categories. In the results section, this is what is expected to be included. Analysis of variance showed statistically significant p less than 0.001 differences in the FEF levels. Non-smokers had a highest mean FEF level value at 3.78, and this was statistically significantly larger than the 5 other smoking classification groups. The mean FEF value of non-smokers was 1.19 higher than the mean FEF of heavy smokers, the 95% confidence interval of 1.03 to 1.35, the largest mean difference between any 2 smoking groups. Confidence levels of all smoking group FEF comparisons were in table 1. So this is just a summary of what you are expected to write in your results section and your methods section. Now, what if the data are not binary or not categorical? So there are some statistical methods specially designed for non-continuous data. They're called as they're called as 2-sample comparison of proportions or a z-test. Now, again, we basically start with a motivating example, and I'm going to use the same example for all the rest of my slides. This was a very famous ACTG clinical trial. It was called ACTG Protocol 076, and if some of you might know that the BJ Medical College site is ACTG site, which is an NIH-funded network, and it has been a successful ACTG site for last more than 15 years. Unfortunately, this study was not conducted in BJ Medical College. This study was a very old study. It was a study that was done in 1994, and the results of this study were published in the New England Journal of Medicine. This was a study on preventing HIV transmission from mother to child. It was a randomized clinical trial to assess the safety and the efficacy of AZT in reducing the risk of maternal-infant HIV transmission. 363 HIV-infected pregnant women were randomized to receiving either AZT or placebo. One of the things I would like to mention over here, as a follow-up of this study, BJ Medical College proudly was participating in another trial to check whether nevirapine was effective in reducing HIV transmission from mother to child. It was a very successful trial where mothers were randomized to receive a single-dose nevirapine in the postpartum period, and infants got 6 weeks of extended nevirapine. And the results of this study were published in the Lancet in I think in later part of 2006 or 7. We can check that out later. Anyway, but you know, so we did a BJ Medical College did a study which was more of a follow-up study for this study. So I think it was important for us to look at this example because this was a primary study that motivated most of the studies that followed after this. So 363 HIV-infected pregnant women were randomized to receiving either AZT or placebo. Of the 180 women randomized to the AZT group, 13 gave birth to children who were tested positive for HIV within 18 months. Of the 183 women randomized to the placebo group, 40 gave birth to children who were tested positive for HIV within 18 months of birth. Notes on study design. This was a randomized treatment trial to help ensure that groups are comparable. This was a double-blinded study where the patient nor the physician could request a particular treatment, and the patient and the physician were not aware of the treatment assignment. We calculate the probability of HIV transmission in the AZT group. That was 13 divided by 180, which is 7%, and the probability of HIV transmission in the placebo group, which is 40 divided by 160, which is 22%. Again, we use some statistical software to do some calculations. Or what you can see over here in the AZT group, the probability is 7%, and the 95% confidence interval over here is 4% to 12%, which means that if AZT was given to pregnant women, the HIV transmission rate in this women for the entire population would be anywhere between 4 and 12%. And if no drug or placebo was given to all the pregnant women, the range of HIV transmission in these women would be 16% to 29%. Now the question is this difference significant, or it can be explained by chance? One way to do this is look at the confidence intervals, and since the confidence intervals do not overlap each other, it tells us that the difference is significant. However, most of us understand p-values, so can we calculate a p-value? And the answer to that is yes, we can calculate a p-value. We have to set up what is called as a null and alternative hypothesis, where P1 is the probability of HIV transmission from mother to child in the AZT group, and P2 is the probability of HIV transmission from mother to child in the placebo group. The null hypothesis of P1 equal to P2 means that AZT has no effect on HIV transmission or a difference in HIV transmission, and the alternative hypothesis P1 not equal to P2 would mean that AZT has some effect in reducing the HIV transmission between mother to child. The same null hypothesis and the alternative hypothesis can be restated as P1 minus P2 is equal to 0, that is, there's no effect, and P1 minus P2 is not equal to 0. In summary, we conducted a randomized double-blind placebo-controlled trial of efficacy and safety of AZT in reducing the risk of maternal infant HIV transmission. The proportion of infants diagnosed as HIV positive within 18 months of birth was compared between the AZT and the placebo groups using a 2-sample Z-test for proportion. A 95% confidence interval was calculated for 18-month infection proportion in each of these groups. The proportion of infants who tested positive for HIV within 18 months was 7%, and we saw that the confidence interval was 4 to 12%, and in 22% in the placebo group, and we also saw that this confidence interval was 16 to 28%, and the difference was statistically significant with a p-value of 0.001. The study results estimate a decrease in the proportion of HIV positive infants born to HIV positive mothers associated with AZT to be as low as 8% and as high as 22%. Now, this study was a very successful trial, and it helped change the WHO guidelines for treatment of pregnant women who are HIV infected. Let's quickly look over in the remaining time that we have on the common study designs. These are randomized controlled trials. There are some natural experiments, there are some other observational studies, and there are case control studies. A randomized controlled trial is typically a two-arm study where population is randomized to receive either a new treatment or a current treatment. And then in each of this group, you identify those who improved and who did not improve. And the same thing for the current treatment, you assess whether those who improved or did not improve. Randomized controlled trials are usually prospective cohort study where the exposure is monitored, exposure is controlled. We always choose a fixed number of patients who will get an exposure and who will not get an exposure. And all the study participants are followed for a defined period of time. The measures of association that you could use in randomized controlled trial is you could calculate the differential proportion, which means, for example, difference in those who cured in the treatment group versus the control group. You could calculate the risk, or you could calculate an odds ratio. We're going to skip this trial slide because this slide tells us how a random treatment is assigned. But sometimes it's not always possible to randomize. Like, for example, for ethical reasons, you cannot randomize individuals to smokers or non-smokers because that's unethical, and you might have a big backlash of ethics committees over here. But these are called natural experiments where the exposure happens as a part of certain certain characteristics or certain behavioral factors. And these studies or these populations are equally good. They're as good as randomized because it's an individual decision to smoke or not. Assignment may not have been based on a random number or a flip of a coin, but it's almost good. It usually doesn't happen often, but it happens. It's good for researcher, but not necessary for the study subjects. So this is what is called as a cohort study, where individuals are naturally exposed to a certain characteristics, and we identify among those who are exposed who get the disease and who are not exposed to certain characteristics, and these are the ones who do not get the disease. You can often write the data into a 2x2 table where disease is developed, yes or no, exposure happens, yes or no, and then you have these 4 types of individuals in this box. You can calculate R1, which is the risk of disease among the exposed group, and R2, which is the risk of disease among the non-exposed group. And then what you calculate is the relative risk, which is the ratio of the two risks. Another type of non-randomized study is called as a case control study, where case control studies are typically done where the disease is very, very rare. And you probably would need to enroll thousands and lakhs of individuals to assess whether they have a disease or not, and it might not be time effective, it might not be cost effective. So you often choose patients with the disease and without the disease, and assess what the exposure was. Case control studies are typically done when the disease is rare, and these are also called as hypothesis generating studies. There's one other type of study design which is called as a cross-sectional study, where you have a designed population where you assess the exposure and the outcome at the same time. And you see among those who are exposed and non-exposed who have the disease or not. And this is often done in a clinical setting. Again, these are not very good studies to make an association between exposure and disease, but these are good hypothesis generating studies. Then there are, based on the types of study that you do, there are different types of associations that can be measured. One is the risk difference, second one is relative risk, and third one is an odds ratio. We will use the same example of the ACTG clinical trial on AZT to maternal infant HIV transmission. We are aware of the slide we saw before that of the 180 women that were randomized to the AZT group, 13 gave birth to children who were tested positive for HIV at 18 months, and of the 183 women, 40 gave birth to HIV positive children. Risk difference is calculated, is nothing but the difference between the two risks. which is 7% minus 22%, and that gives us a risk difference of 15%. And again, a software can be used to estimate this risk difference with the corresponding 95% confidence interval. The way you interpret the risk difference changes. And depending upon who you are, the risk difference, the interpretation is important. Like, for example, if you're a public health planner or a policymaker, then you would interpret this data as, if AZT was given to 1,000 HIV-infected pregnant women, this would reduce the number of HIV-positive infants by 150, relative to the number of HIV-positive infants born to 1,000 women who were not treated with AZT. Now, another measure of association is the risk ratio, where we have the same two probabilities estimated. Now, instead of taking a difference, we just divide the two, and we get 7% divided by 22%, which gives us 0.32. The risk of HIV transmission with AZT is about 1/3 the risk of transmission with placebo. And again, we can use a software to do this. The interpretation now is not a public health interpretation, but an interpretation between a clinician and his patient. An HIV-positive pregnant woman could reduce her personal risk of giving birth to HIV-positive child by nearly 70% if she takes AZT during a pregnancy. And this is what the patient would explain to the doctor would explain to a patient sitting in front of him. Look, if you decide to take AZT, then you're going to reduce your individual risk of giving birth to a HIV-infected child by almost 70%. And then there is another calculation of association, which is called as an odds ratio. Odds is nothing but the risk, that is P, divided by 1 minus P. And we calculate the odds ratio, odds for each of these groups, and then we divide the two odds ratios and odds, and that's how we get an odds ratio. Again, the odds ratio can be calculated using the software. You will never have to do these calculations yourself, but a statistician will help you do it. But what your job is to interpret this data. So when you're calculating an odds ratio, the interpretation will be AZT is associated with an estimated 72% reduction in the odds of giving birth to an HIV-infected child among HIV-infected pregnant women. So as you saw in the same example, you can calculate 3 different measures of association, and each measure of association has a different interpretation and can be used by different public health professionals. I think this is the end of my slide, and thank you very much for your time and patient listening. If you have any questions, I'm happy to take some.
Thank you, sir. It was such a novel and informative session. It has aroused interest in the minds of all the young researchers who are watching you now to pursue biostats. I thank you on behalf of the entire Respirare team for finding time from your busy schedule and guiding us all. We have some questions. So we generally say that the p-value should be less than 0.05. But what if the p-value is exactly 0.05 or a little greater than 0.05? Will it still remain significant?
So the thing is that we often look for p-value that is less than 0.05, which is correct. The p-value is never exactly equal to 0.05. It is a rounded off p-value. If the p-value is, say, for example, 0.52 or 0.06, then what it means is that your study lacks a bit of power to make the conclusions. So if you had a higher sample size, you might have a p-value that is significant, but it's definitely a directionality that can be seen.
Thank you, sir. Thank you once again.
You're welcome. Are there any more questions?
No, sir.
Can I log off then, or?
Yes, sir.
Okay, thank you so much.
Thank you so much, sir.
Bye. Thank you very much. I loved it as well. And hopefully next time I can be there in person.
Yes, sir. We'll love to have you offline in our college.
Bye-bye.
Here I am interested in identify ऐसे ये सारे जो एलिमेंट्स है इनके वैल्यूज सारी तीन मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करने पड़ेगा कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं इन अ फिनोमेना नोन एज वॉक।
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis. But which kind of episodes, everybody? Chronic episodes.
We have the tonsil, then we have the lateral walls of pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in two axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, it is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or brow presentation.
They're talking about altered sensorium, then they're talking about delirium tremens.
I'm Dr. Gauri Khajindar. I'll be speaking about applications of nuclear medicine in current clinical practice. It's just a small overview. There are a number of multiple applications. I'm just covering the most commonly used ones. Nuclear medicine uses unsealed radioactive sources which attack with biomolecules, which are specific for certain organs or the function that we are looking for, and also in treatment of certain diseases. Basically, we use gamma camera and PET-CT scanners for diagnostic, and beta emitters labeled with biomolecules for radioactive therapy. Just sorry for the disturbance. Next slide. Yeah, the most commonly used scan that at least from maybe last 50 years we've been doing, that is the thyroid scan. Technetium pertechnetate is an analog of iodine. So it gets transported to the thyroid gland just similarly as iodine goes into it. It's an intravenous injection, say 1 to 2 millicurie, and within 20 minutes we do the scan under a gamma camera. This is how a normal thyroid scan looks. Normally you have sodium iodide symphotas in the follicles. They take up technetium, and this is how the scan looks. Next slide. Now, this is a child who was hypothyroid since birth, and TSH was very high, T3, T4 very low. And when he came for the scan, we found that there was no functioning thyroid tissue in the neck. It was complete thyroid agenesis that was found. Next slide. This is another case where we have ectopic thyroid gland, which is seen in the lingual region, and the patient had difficulty in deglutition. As the size increases, because it is a stimulated gland, it becomes difficult for deglutition. So he underwent a surgery, and this lingual thyroid was removed and placed in a subcutaneous plane in the thigh region. Next slide, please. This is how it was. Preoperative, you see there is one focus near the tongue that was sublingual. Post-op, it was removed and put in the anterior aspect of the left thigh. That is how the functioning thyroid tissue was preserved. Next. Here you have Graves' disease, where there's increased trapping function of the thyroid gland, and you see there's intense uptake in both the lobes of the thyroid gland. Here, radioactive iodine therapy is a very good response that we get to treatment. Next slide, please. Treatment options for Graves' disease include antithyroid medication, surgery, or radioactive iodine, that is RAI. The mechanism of action of RAI is physiological. Iodine is a precursor of thyroxine. The radioactive iodine form of iodine is taken up by iodide transporter of the thyroid just the same way as natural iodine and is similarly processed. The beta particle destroys the follicular cell, gradually leading to volume reduction and control of thyrotoxicosis. Radioactive iodine therapy is acknowledged to have the clear-cut advantage of being safe with very low morbidity as well as cost. Otherwise, there are patients who continue to take antithyroid drugs for years together, continue to be hyperthyroid, and have symptoms related to that. Radioiodine gives a very safe option, and it gives a one-dose treatment. Most often, the patient is rendered euthyroid with one dose. Very rarely, say about 10 to 15% of patients become hypothyroid. They can be easily treated with Eltroxin or thyroid supplements. Next slide, please. The indications for radioiodine therapy will be hyperthyroidism, that is due to Graves' disease, can be due to toxic multinodular goiter, or even due to hyperfunctioning thyroid nodules, as you see in AFTNs or autonomically functioning thyroid nodules. Contraindication, it is a radioactive isotope. So it is always be contraindicated in pregnancy because there'll be radiation hazards to the fetus in situ, as well as for breastfeeding women. Next. This is one place where you have a thyrotoxic status, the TSH is low, and your biochemical study says it is thyrotoxic, but the scan shows that there is no uptake in the thyroid bed. That is because this patient is having thyroiditis, only circulating hormones are high. In this case, the patient just takes supportive treatment and there's no need of antithyroid drugs as well as no indication of radioiodine. This is where it is important to distinguish between Graves' disease and thyroiditis. The treatment completely changes once you know what the clinical condition is. Next. Slide skips, Ali. Can you just go back? Next. Yeah. In patients who have solitary thyroid nodules, there are hypofunctioning nodules that you can see the left lobe inferior part. There you see it is completely cold. And there you know it is a non-functioning nodule. These nodules are quite likely to be malignant. And when you do this scan, you can say that a hypofunctioning nodule or a non-functioning nodule is needed to be sampled, FNA or cytology should be done, and then you know whether it is malignant or not. This is how it is important. Sometimes it is just a colloid nodule where you see functioning tissue and you can just reassure the patient that there's no need to sample it. Next. Myocardial perfusion and metabolism imaging. Next. This is another indication of nuclear medicine studies where we have non-invasive detection of CAD in patients without a diagnosis of coronary artery disease or in patients with suspected coronary disease and with intermediate risk. We do these studies to exclude the diagnosis in those with suspected CAD. It is also used as a screening test in those with intermediate and high risk of CAD, like for those who have a family history of hyperlipidemia, for diabetics, for hypertensives, and there's family history of CAD. And there are atypical symptoms where you have right-sided chest pain or just heaviness, which is not explained properly. We have role of nuclear scans even before angiography. It is possible to detect coronary artery disease non-invasively with very high accuracy. Normal scan helps to avoid coronary angiography in low and intermediate clinical probability patients. An abnormal scan helps to estimate the global ischemic burden. Prior to angio, you know what the ischemic burden is, which territory, which coronary territory may be the one which is the critical one, and then you can decide revascularization technique. Scan is useful in cardiac risk assessment for non-cardiac surgery. Like you have a pre-anesthetic checkup where the anesthetist wants to be reassured that there's no cardiac issue before induction. These cases, you have a stress MPI done, stress myocardial perfusion imaging done. And if that is bang normal, then he's assured that he can go ahead with the procedure. After coronary angiogram, what is the role? The scan helps us to assess borderline stenosis. It also helps to identify the culprit vessels. Sometimes you have number of lesions in number of territories, but if you have a perfusion defect in single one, you know which one you have to tackle. You need not go and take care of all the coronary arteries at the same time. You know which one is critical and you go and deal with it. You also estimate ischemia in individual coronary territory using this study, and this helps to plan all the procedures, revascularization technique, or even medical management in doing this. After infarction, say a patient has developed an infarction and you are doing this study, it also helps us to estimate viable myocardium. If there's a scarred myocardium, there's no use in doing revascularization. There's just waste of putting the patient on the high risk surgery. After intervention or CABG, scan helps to detect restenosis or graft stenosis. So in coronary artery disease, using a nuclear scan can be done at number of stages before the diagnosis, before angiography, after angiography, and even after revascularization procedures. The tracers that we use for technetium tetrophosphane or technetium sestamebe, these are used as cold kits labeled with technetium 99M, which is an isotope from the generator. This is how a normal scan looks. We usually image the left ventricle more often. You are sectioning from apex to base in short axis. Horizontal axis, what you see medially is the septum, laterally is the lateral LV wall. In the vertical long axis, that is the VLA, we see anterior wall and inferior wall. And here you see there is complete orange color in all areas, all sections. So this is a normal scan. In cases where you can see the angiography image, there is a borderline stenosis, but still there is filling of the distal vessels. So should we deal with it? We don't know. Sometimes the patient does well with medical management as well. Now, if you do a stress myocardial perfusion image, you put the patient to treadmill, then inject the tracer, do the scan. Then you repeat the scan at rest and you compare. You see the first image is at stress. And you see inferiorly, there is a perfusion defect. The color is blue. And at rest, what you see, it is filling. So there is a stress-inducible ischemia in the inferior myocardium. So this lesion needs to be dealt. It needs to be opened unless the patient will have issues. There might be infarction in future. A stenosis without corresponding defect is considered hemodynamically not significant. Suppose there's no perfusion defect in this study, then you may just continue with medical management. And if you see a perfusion defect, then it surely needs some kind of management in future. Here you see a reversible defect. The first line, top line, it is stress line. And you see the lateral, inferolateral is showing perfusion defect. At rest, you see it is filling up back. That means that the circumflex territory is having a lesion which is causing ischemia at stress. It is not adequate perfusion, and that is why it needs to be dealt. Similarly, the lower lines, the top one shows lateral wall is hypoperfused, and the below one shows how it is perfused well at rest. So it needs to be dealt with. Viability. You have a patient who has had infarction, but still at times, because of low flow, it reduces itself and it does not function well. There's no wall motion, but still it may be viable. Hibernating myocardium is a situation of chronically reduced myocardial perfusion at rest because of a stenosed vessel, and it is associated with an impairment in contractile function. So on echo, you see it is not moving well and you think it is not viable, but it can still be reversed after revascularization. So we have a perfusion defect, and if you have FDG uptake, FDG is fluorodeoxyglucose. It is a glucose analog, and glucose, if it is reaching the myocardium, then it says it is viable. And if it is match, that is there is a perfusion defect and there is FDG defect, that is a metabolism defect, then it is a scar tissue. There's no point in opening the vessels or revascularization that area, because that lesion is not going to improve. Here you see the first image is perfusion, you see a defect, and the second image is metabolism. You see it is shining in that area. So if you reperfuse it, it is going to do well, it is going to contract well, and the patient is going to improve. Here again, you have a mismatch on the lateral wall. In the first image, you see it is nicely filling up in the second image. Again, in third and fourth, you see a defect which is reperfusing or a metabolic improvement. This is an image of matched defects. You have first line, there is a anteroseptal defect, and second line, it is showing match. So it is a scar tissue and it will not improve. Here again, you have mismatch. You see the apex is not showing a defect, and immediate, you have FDG, it is showing similar ones. Now, applications in nephrourology. This is how a normal renogram looks. You acquire in posterior imaging, you inject intravenously, you also give diuretic as required. Here there's one more thing that we are able to see. It is a horseshoe kidney. You can see both the lower poles are fused in between, and there's a faint area of tissue uptake. So it is a horseshoe kidney, but you see in the third image, the kidneys are showing bright color, and as you go to the sequence, you see in the last image, there's complete loss of color and the bladder is filling. So both the kidneys are draining very well. Now this is a patient with cross-fused ectopia. On ultrasound, they did not find the left kidney in place. Now where is the left kidney? Probably it is agenesis, or probably it is a very small kidney, we don't know. This is a dynamic renogram we have acquired. You see the right kidney in place, it is elongated, a bit enlarged. If you see the third image in the second row, you see two different areas that are highlighting. So it is the right kidney which is crossed the midline, it is fused to the left kidney at inferior pole, and you see two kidneys and both of them are draining well. The last image is an anterior image where you see the right kidney on right side. The same patient, you see there's the arrow marked area, there are two ureters and both of them are going and merging with the kidneys there. So you see it is a cross-fused ectopia where both the ureters are also merging there. Now this is a situation with ectopic pelvic kidney, anterior view imaging, because ectopic kidneys are anteriorly placed. Normally kidneys are placed posteriorly. Here you see in the first image itself, you are seeing pelvic tracer accumulation, the black color that you see, and that area is gradually draining, and you see by the end of the scan, it is draining well. PUJO, that is pelviureteric junction obstruction. Where do we use nuclear scans? First is to diagnose whether there is an obstruction, plan the management. If the kidney is doing well, the function is very well preserved, you don't need to intervene immediately. You may follow up. Sometimes there are PUJOs which improve even on conservative management. You also know the status of opposite kidney with this. And you can use these scans for post-op follow-up. Now, this is a patient where you see left kidney is not seen in the first two images, 3, 4, gradually it is picking up. By the end of the study, you see it is an enlarged kidney and the tracer is seen brightly by end. It is not draining at all and it is an obstructed left kidney. And the function is also poor. You see the right kidney, how bright it is in the second image. The left is not showing uptake at all. Now, this is a patient who had a pre-op study. You see the first slide, the top image. The first kidney that you see left side, it is not filling in the first few images, say 4, 5, and gradually by end you see it is filling. Now this is post-op, the downs image, and you see how bright it looks in the first image itself. That is how the left kidney function has improved post-pyeloplasty. This is radionuclide voiding cystography, where we inject the tracer directly into the urinary bladder and the patient voids in front of the machine. And you see how the tracer is going to the left kidney immediately, even before the patient starts voiding. The large white spot you see is the bladder. It is emptying as the patient micturates, and see how the left kidney shines. So there is grade 4 VUR, that is vesico-ureteric reflux. Bone scans or skeletal scintigraphy. The advantages are it is an extremely sensitive study. It gives a whole body scan in one image. You do radiographs, you do regional radiographs, AP, lateral. Here you do a complete head-to-toe scan in one image. It has early detection of lesions as compared to other modalities. You can decide which area you need, what modality you need to use after you do a bone scan. It is also utilized in determining the clinical significance of radiologically demonstrable lesions. There are 4 phases of a bone scan. The phase 1 is scintiangio. Phase 2, you do it within 5 minutes. It shows blood pool or soft tissue region. Phase 3 is the bone uptake. Phase 4, at 24 hours, it shows exclusive bone activity. Imaging is done in different views. You do a whole body image, you take spot images in anterior, posterior views, lateral views, oblique views. You also do tomographic acquisition, SPECT, for obscured areas. This is how a normal bone scan looks. A patient with skeletal metastasis, malignancy, stage 4 disease, where there are skeletal deposits. This is how the scan looks. This is a patient with CA prostate and there are skeletal deposits. You see head to toe, there are a number of black spots, disseminated skeletal metastasis, stage 4 CA prostate. This is multiple myeloma, where you see number of tiny spots in the ribs, in some vertebrae, and that is because of multiple myeloma. This is a super scan. It's really too good to be true. This is how it looks. Almost uniform skeletal activity, faint or absent kidney activity. Disseminated micrometastasis may also show, or metabolic bone disease. This is a patient with Paget's disease. You see the proximal left femur, head, neck, and proximal almost mid-shaft, and right acetabulum. It is showing intense uptake. That is a multifocal Paget's disease. Osteoid osteoma, a lesion that can be cortical, medullary, periosteal, and a normal bone scan virtually excludes the diagnosis of an osteoid osteoma. This is how it looks on a 3-phase bone scan. On flow, you see hypervascularity in the distal leg, or you can say the proximal ankle region. Blood pool, you see nice focal uptake, and delayed image, you see the talus is showing nice focus. That is because of osteoid osteoma of talus. Here you have osteoid osteoma of shaft of tibia. There also all 3 phases, it is showing nice uptake. Acute osteomyelitis. Sometimes you don't know there is pain. You on radiology, you're not sure whether there is inflammation, infection. Here again, you have all 3 phases show intense uptake. It is proximal tibia, which is showing uptake in all 3 phases. That is because of acute osteomyelitis. There are patients with diabetes. There's lower limb edema and cellulitis, there's fever, and you don't know whether the underlying bones are involved or not. The management changes completely if it is cellulitis or if there is osteomyelitis. In this patient, you see there is hypervascularity, there is hyperemia, but in the delayed phase, all the soft tissue uptake has vanished and the bones are clean and clear. So this patient has only cellulitis, and broad spectrum antibiotics deal with it very well. There's no need of surgical intervention. the patient does well with that. This patient was diabetic and has got a grade 2 amputation done. And here how you see the X-ray is also showing some lysis, and intense uptake on bone scan says there is persistent infection. It needs to be dealt with immediately. Pot spine, very nice uptake in delayed image. Contiguous vertebral involvement, which is very common in pot spine. Coming to PET, FDG PET scan, a commonest algorithm used in diagnosis and treatment of malignancy. It is metabolic imaging using short-lived isotopes tagged to organic molecules. Mostly we are doing FDG, that is fluorodeoxyglucose. All malignant cells, because they are active metabolically, they need more glucose. And this analog is taken up very well by them. A structure without function is a corpse. A function without structure is a ghost. So a CT cannot tell you about function, and PET, which is metabolism, does not tell you about the structure. What we need is both. So PET is metabolism, CT is anatomy. So physiology and anatomy together, what we get is PET CT. You get both the benefits. The patient gets a head-to-toe scan, a complete staging one-stop shop. A patient diagnosed with malignancy and you have high tumor markers or high clinical suspicion of metastasis, a PET CT helps in deciding the line of management. A patient can go to definitive or palliative care once you know what the status of disease is. You use it for staging, restaging, monitoring treatment response. It is also used in radiation treatment planning. Most common indications are lymphoma, CA lung, breast malignancies, GITs where you have esophagus, stomach, colorectal cancers, hepatobiliary malignancies, genitourinary, you do it for renal RCCs, TCCs or transitional cell carcinomas of ureters, bladder, musculoskeletal, Ewing's, PNET, and malignant melanoma. There are still more. This is a patient who came for staging of CA lung. The second line, you see number of hot spots, that is the orange color that goes for primary lung malignancy. Plus what we see, the first one is a dorsal vertebra. Lower you see pelvic bones. They're showing hot spots. The sacrum, bilateral iliac bones are showing hot spots. Those are the areas where there is metastasis. The patient directly goes to stage 4 and goes for palliative treatment. Here also you can see there is a focus in the liver and there are multiple skeletal lesions. So that says that there are hepatic metastasis, there are skeletal metastasis with primary lung. This patient presented with nodal peritoneal lesions and the unknown primary. UKP stands for unknown primary. In the first image, you see posteriorly, there is a cystic lesion with focal areas. That is the left ovary. It turned out to be cystadenocarcinoma. And there are a number of para-aortic nodes, perihepatic peritoneal nodules, perisplenic nodules, and stage 4 CA ovary. Restaging. A patient treated, operated for sigmoid carcinoma, adenocarcinoma sigmoid. And there are post-op changes. On CT, you cannot decide whether there is post-op changes versus there's disease recurrence. Here on PET, you see an intense dark focus. The lower image is showing in the presacral region. That is local recurrence. The patient, if you diagnose early, you treat early, and there are higher chances of better outcome. Monitoring treatment response. The first image is lymphoma, axillary nodes, abdominal nodes, inguinal nodes, pelvic nodes, high intense yellow color. After 2 cycles of chemotherapy, what do you see? They're all vanished. So you can decide that the line of treatment, the regimen of chemotherapy that you have taken is correct. The patient is responding. So you can continue. At times, there are patients who continue to have uptake. Then they need to add another drug or they need to change the regimen. Here you have guidance to interventional radiologist. There is, if you see the image on the right side, on CT, you don't know from where you need to take a sample. On left, you see the PET image, and you know the red color, orange red color is metabolically active. If you take a sample from there, you're bound to get a good result. The yield is good. Taking inconclusive yield is not of any use to anyone. All that glitters is not malignant in PET. What you see yellow is not always malignant. Tuberculosis, a rampant infection that we have in India. This patient, you find number of liver lesions, big ones, and they were very hot on FDG. What you find on histopath is AFB positive. They found active AFB bacilli on it, and he was treated with AKT and did well. So all that you see yellow on FDG is not always malignant. You also get tuberculosis. There are certain tumors where the metabolism is not glucose dependent. There, the metabolism is fatty acid dependent or elsewhere. There, the FDG uptake is low and we are likely to be misguided. They are low-grade lymphomas, lobular carcinoma of breast, bronchoalveolar carcinoma, mucinous tumors, clear cell signet cell cancer, mostly colorectal. Prostate cancer, we have a specific PSMA scan for that. Well-differentiated thyroid cancers also are low FDG avid. I think I've taken a little longer time, but this is all. Thank you.
Hello. देख यार. Okay. Hello, everyone. Thank you for your applause. I would like to tell you that we have a next inspiring session by Dr. Bharat Watwani, sir. Please have some patience. Wait for 5 minutes. Soon we will begin with our next schedule. Thank you.
Please maintain some social distancing. I can see all of you very crowded. Please maintain some social distancing.
Guys, please sit apart. मुझे दिख रहा है उधर बहुत crowding है. Please. जल्दी. Quick. And put your masks on.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स हैं इनके वैल्यू सारे तीन मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना पड़ेगा कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walking.
As soon as you see such a pupil, this is characteristic of uveitis. Anterior uveitis, but which kind of episodes, everybody? Chronic episodes.
We have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in two axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, it is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or bro presentation.
They're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as Link 25 system.
I have given you the way to remember Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe-ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added and the patient responded immediately.
I, Rutuja Savan, second year MBBS student, welcome you all to Respirare 2021. In recognizing the humanity of our fellow beings, we pay ourselves the highest tribute. Medicine is one of the noble professions which justifies this saying. Doctors are always striving hard for the betterment of their patients and community. There are a few of them who go an extra mile and try to bring about a change by taking extraordinary efforts. Team Respirare 2021 proudly welcomes Dr. Bharat Watwani, the founder trustee of Shraddha Rehabilitation Foundation, for an oration on humanitarian outreach and medical fraternity. It's an immense pleasure and privilege for me to introduce you, sir. Dr. Bharat Watwani, sir, is an alumnus of Grant Medical College and GS Medical College, Mumbai. He has been in clinical psychiatric practice for over 4 decades. To correct the injustice which mentally ill patients suffer, he found Shraddha Rehabilitation Center for the homeless mentally ill. Initially, it was started from a 2-room tenement and was shifted in a building in 1997, Mumbai. But the journey was not easy. Dr. Watwani sir and Smita Watwani ma'am had an initial resistance when the neighbors filed a case against them for starting the center in a residential area. But the High Court judge gave a landmark judgment favoring Dr. Sir. Inspired by his mentor, legendary social worker Baba Amte set up a rehabilitation center on a 6.5-acre land in Karjat in 2006. So far, 10,000 and more homeless persons with mental illness have joined with their families in the service of Shraddha Foundation. His service in the COVID pandemic is beyond words. He provided food, hospitality, medical treatment, and ambulance service to migrant workers who were fleeing the state. His service is recognized nationally and internationally. He was an amazing Indian in times now. He is one of the heroes in the Satyamev Jayate series. In 2018, he was awarded the Raman Magsaysay Award. We welcome you to our institute, sir. Now I request our respected Dean, Dr. Vinayak Kare, sir, to felicitate Dr. Bharat Watwani, sir. Thank you, sir. I request our respected Deputy Dean, Dr. Rajesh Karyakarte, sir, to felicitate our Dean, Dr. Vinayak Kare, sir. Now I request Meher Kaur, the organizing secretary of Respirare 2021, to felicitate our Deputy Dean, Dr. Rajesh Karyakarta sir. Directly, I request sir to enlighten us with his words. Now I request Simran, the Joint Organizing Secretary, to felicitate Dr. Rupa Tekchandani, the trustee of Shraddha Foundation and an alumni of BJ Medical College. Thank you, Simran.
Now may I request our respected Dean Sir and our respected Deputy Dean Sir to kindly take place in front of the stage. And I request Dr. Bharat Watwani Sir to please remain on the stage.
His words.
Mic check. Mic check. Check, check.
Hello, hello. Okay, hello. Can you guys at the back benches hear me? Okay. Shall I begin? Yeah. So I am Dr. Bharat Watwani here. I happen to get the Raymond Magsaysay Award by pure fluke in 2018. Had the award not come my way, I would not be standing here in front of you. And I would be just about as lukha as what all of you are. So credit to the Raymond Magsaysay people who chose me. I mean, surprised. Anyway, all stories, all good stories, begin with a love story. So, let me tell you my background. I was in the entrance exam, I was second in the University of Bombay. I picked up JJ by choice because my brothers were there, and I entered medicine. So when I entered medicine, I found medicine very difficult, very, very, very difficult. I mean, Gray's Anatomy, that optic nerve chapter, that guy Gray went on and on and on the optic nerve. मैं बोला साला बच्चे को मार डालेगा क्या? कितना लिखेगा एक single नस के ऊपर? How much can you write यार? But he went on. Anyway, I cleared my first MBBS with great difficulty. I cleared my second MBBS with even more difficulty. And third MBBS, there was a senior of mine called Dr. Rajan Garg. He's no more. But he was responsible for me passing. After I'd finished my MBBS, I was fed up, absolutely nauseated of studies. मुझे लगा इस जन्म में साला किताब को हाथ लगाने का ही नहीं है. So I went into general practice, and I went to Vasai, Virar, which was quite far in those days. And I flopped in my general practice. So that was after 1.5 years of trial, I flopped. So like that dog with the tail between the legs, I came back. And my brother, I lost my dad a long time back when I was in the 8th standard. So my brother suggested that let's pick up a non-medical job. So I was doing a non-medical job as an administrative officer in some Institute of Energy Management. So at that time, one of my seniors, Dr. Ghanshyam Bhimani, he suggested, why don't we pick up psychiatry? Ek post vacant ja raha hai, diploma in psychiatry. So I said, see boss, my family is in a very bad shape financially. I can't dare lose out on this job. तो मेरा attendance का कुछ करते हैं तो मैं join करता हूँ. He said, I'll do it. So I didn't attend a single day. Legally it was not required also. I didn't attend a single day. Took out 10-15 days just before the diploma in part 1 exam. And by pure simple fluke, I passed the exam. Same thing happened for diploma in psychiatry part 2. So I was literally, So I was literally a psychiatrist having seen exactly 3 or 4 exam going cases, and I was a diploma in psychiatry. That is luck. Then suddenly somebody told me there's an MD seat going vacant in KEM. I said, chal wo bhi le lete hain. So when I was in KEM, I was posted to Cooper Hospital. And when I was in Cooper Hospital, my lecturer, I was a houseman, my lecturer turned out to be one Dr. Smita Ganla. And boy, oh boy, was she a good looker or was she a good looker? अभी हमको तो पढ़ाई में इंटरेस्ट था ही नहीं, हम लेक्चरर को देखते रहते थे. Finally, she fell in love with me, I fell in love with her. So, the houseman falling in love with the lecturer was a bomb, yeah. Cooper Hospital हिल गया. So, अभी मोहब्बत तो थी, and as it is, I was not interested in study. And on top of that, she was a gold medalist in MD psychiatry. Oh boy. So, she would teach me side effects of lithium 1, 2, 3, 4. हमको side effects मालूम नहीं, हम तो साला उंगलियां देखते रहते थे. अभी net result ऐसा हुआ कि finally I failed in my MD psychiatry. When I failed in my MD psychiatry, my father-in-law, prospective father-in-law, was one Dr. Vishwas Ganla. He was the retired director of medical education research, and he was the dean of this college once upon a time. So you know how deans are. He's sitting in front of you. So he called me and he said, Bharat, either you clear in the next attempt or, when he said or, I realized it was or. So gaya. So then I started studying little bit, whatever little I could. My wife also, my fiancée also started putting in effort. And with the grace of God, in those days, I used to go to Mahim church, I used to go to the Gurdwara, I used to go to Siddhi Vinayak, I should go to Haji Ali and take a visit to the Dargah. Everything I did, whatever was possible, barring academics, whatever was possible, I did. And in the exam, there was a case. So that guy, one famous psychiatrist, Anand Natkar, he was standing outside trying to help me. All the people had come around trying to help me. So he said, boss, अंदर जो केस है ना वो bipolar लगता है लेकिन bipolar नहीं है, schizophrenia है. मैं बोला यार जब तेरे को इतना मालूम है थोड़ा मेरे को differences भी बोलना bipolar और schizophrenia के बीच में. So that is the way it went through. Finally, I passed April 1st, 1987, and April 30th, 1987, I got married. And of course, she was a lecturer. So she gave up the lecturership and she joined me in practice, which was very important because I didn't know what the patient was. And she was the gold medalist. मैं हर एक time उसको पूछे कि क्या करूँ आगे क्या करूँ. Finally, anyway, things worked out. So the love story is the most important thing. And the lecturer is the most important thing. Follow that, all the backbenchers. Now coming to the basics. I and my wife were sitting in a restaurant, like a routine, this thing, eating vada sambar, whatever. When suddenly across the road, there was a guy who was long hair, matted appearance, half naked, laughing and talking to himself, and which we realized was having schizophrenia. We had no intention of doing anything at that time. When suddenly this boy picked up an empty coconut shell, dumped it into the nala beyond, and drank the entire gutter water at a single shot. Oh boy, what a scene. And that touched us so badly, that without realizing what we were doing, we just walked across to the road and asked him, will you come with us? Hey, Bada, this is unbelievable. Yeah. And we walked across the road and he agreed to come with us. We asked him, will you come with us? He agreed to come with us. And that boy became the first patient that we had picked up. That boy turned out to be a BSc, Diploma in Medical Lab Technology. He was educated. He turned out to be knowing English. We wrote a letter in those days to his village in Andhra Pradesh. His father turned out to be the superintendent of the Zilla Parishad in his district. And he was educated and he came down by flight to take the son. That was something, that was something that really made me and my wife believe that, look, there's nobody doing this work. Nobody doing this work of picking up a person who is on the road and laughing and talking to himself, a wandering mentally ill. So we had a very small nursing home, very small, 5-bedded nursing home. सब मेरे wife के गहने वहने सब बेच करके finally हम लोगों ने छोटा nursing home चालू किया था. That's how the ball game started. We took up one patient, second patient, third patient, like that. And every time the success story was good and every time we were emotionally rewarded by whatever we did. Then there was a private patient of mine, his son told me that his lecturer, a gold medalist from JJ School of Arts, was on the roads. I couldn't believe that a JJ School of Arts gold medalist, premier institute of the whole of Asia, lecturer, gold medalist was on the road. I couldn't believe. We went personally to pick him up. He was a very difficult case, catatonic, schizophrenic. We brought him, we gave him ECTs. With very great difficulty, he improved. Riles tube feeding, no consent, no relatives, there's no question of consent in a roadside patient. And finally, the person improved. When he improved, all his colleagues and all his people said, why don't you have a fundraising art exhibition? So we didn't know anything about art. They said, no, we'll help you out. So they got us the booking in Jahangir Art Gallery, very famous gallery of Mumbai, 1993. And in 1993, at that time, there was an artist called Manu Parekh who was very involved with this particular case. And we ended up meeting Manu Parekh. I went to Delhi. He got so moved, Manu Parekh, that he said, wait, yaar, what you're doing with only my painting, I'll ring up a few more people. Then everybody, Anjali Laman, Raza, you, Krishnan Khanna, name the people, Bikash Bhattacharya in Calcutta. I gave up my practice for 3 months at a shot. Delhi, Calcutta, Madras, Hyderabad, Bangalore, the whole works. We had 141 paintings. And with the sale of those paintings, we bought a small plot in Dahisar in Mumbai, in the outskirts of Mumbai. So giving you an idea of what exactly we are doing. These are the wandering mentally ill whom we pick up from the roads. They are there everywhere. They'll be there in Pune. They'll be there in every metro. Wherever the train ends, invariably they are there because the trains are offloaded, they are cleaned, and they are removed from the station and literally thrown out. Nobody turns and looks at them. Nobody turns and looks at them. People, in fact, shun them. People beat them up with sticks. This guy on the left is badly depressed. And this guy on the right is having active hallucinations. You see this female, this is life. Somebody has put a helmet on top of her head. This is life. And the same female at the time of reunion. This gentleman who's there, Dhruv Badekar, he's one of my earliest social workers. He's there right now, over here. Such is life. I mean, the person at one point of time, everybody's mocking her, everybody's laughing at her, some people may even get together and rape her. But the same person with the family in Maharashtra. So what we are doing is we are picking up the patients from the road, bringing them to our shelter, which in those days was Daisar, and reuniting with the family, and there is grassroots awareness. You see the patient at the beginning, same patient gradually improving, and with her sister in Madhya Pradesh. One minute. I have kept this slide for a very important, this video for a very important reason. You see what moves the person. What moves the person is the emotionality behind that reunion. It is not the accolades, it is not the applause, it is not the awards, it is not the felicitations, it is not the coverage by the media, but the emotionality within the reunion. These are two sisters who are meeting with each other after a long time. Volume there. As simple as that. Just those two sisters looking at that small, you can't call it a necklace, but whatever. Just that small twinkling, I mean, so happy you feel. This boy is a chartered accountant. This boy is a chartered accountant. Again, picked up by Dhruv Badekar, who's sitting here. Now comes the philosophical question. Where is the knowledge? We have lost in information. Where is the wisdom? We have lost in knowledge. And where is the life? We have lost in living. These are questions which at some point of time touched me, and I hope at some point of time they touch you, being medicos. This is the small setup that I was telling you about. This is my father-in-law, ex-dean of BJ Medical College. And this is us, 3rd June 1990, the first article got printed. We had already picked up 6 patients by then. In those days, we had a guy who was brought in by our ward boy. The ward boy is still with us. On the pretext that he'll be given a good meal. In those days, there are no mobiles. That boy gave a number. I rang up that number. That number turned out to be of the mother. That mother rushed down from Srinagar by flight to this. And he wrote a very nice letter, the father. And he said, welcome to Srinagar anytime. This is what takes you forward. Newspaper coverage has been huge over the years. But despite all the newspaper coverage, the awareness has been very poor. This is the JJ School of Arts lecturer which I told you about. I mean, in those days that this art exhibition was covered by literally every newspaper. Sunil Dutt had come down to inaugurate the function. This boy, which you see on the left, is a VJTI civil engineer. VJTI civil engineer. He's still with us. Perhaps because of the fact of the shame involved in acknowledging the fact that your relative is a psychiatric patient, no relative came forward. No relative came forward. And this girl is still following up with us, still following up. This is us in the good old days. That is me. And in my arms is my first daughter. And that is my wife. We had gone to Jalgaon by car to reunite the person. You see this boy who's looking up with his arm in black. This boy, after 20 years, came to our center. I could not recognize him. And he said, you helped pick me up. You helped me lead a better life. And I've come to donate something. And he gave us mangoes and achar from his hometown. 20 years after he was reunited. Innumerable newspapers covered us. This is the first patient, which you see on the left, the boy and the father. And this is the first structure that we had in Daisa. A small setup, 2-floor structure, small bungalow. And Jayantiben Mehta, who was the member of parliament at that time, she came down to inaugurate this. And she wrote that this is a Tirth Sthal. What is written there is that this is a Tirth Sthal. And she has written that Shraddha ke doctor nahi, Devdoot hai. But despite her inauguration, despite everything, the people around that building, the residents of that area, went to court against us. They had a signature campaign. They went to court. At one point when my wife was alone over there, 100 of them gathered and said, Gali Gali mein shor hai, Dr. Watwani chor hai, Shraddha Murdabad, this, that, everything. Now when they went to court, the court was in South Bombay. I was staying in North Bombay. I didn't have a car. I didn't have anything. Daily going to that court. Or at least thrice a week going to that court, meeting that lawyer, sitting over there for 3 hours, coming back. 1.5 years this went on. 1.5 years this went on. Not 1 day, 2 days, 3 days. We were at our wits' end. We sat because the advocate didn't know anything about mental health. We sat and took out references from here, there, we sat down in libraries, wrote about mental health ourselves and sorted that we had given him a huge file, you can say a dossier of what mental health was all about and what the wandering mental ill were all about. And on every day of that 1.5 years, let me tell you, I had my wife and Dr. Ghanshyam Bhimani. We were the three trustees at that time. We felt like throwing in the towel. We felt like if society has got no appreciation for us, if society does not give a damn for the work that we are doing, why are we doing all this? Why are we doing all this? I mean, I would burst out in tears. My wife would burst out in tears. Everybody was in such a bad shape. But despite that, the gods being there, we continued. But if there was one thing which we realized, that if you give up the struggle, not a single soul will touch this man on the street ever again. That is the important point. Now you can either look at your own conscience in the mirror, or you can let go. Touch wood every day, despite all the tears, despite everything, we continue. It was by far the most difficult period in the entire tenure of the NGO. In the entire tenure of the NGO. You're young. You are young. You have never fought such battles before. You're not exactly in the richer category. You have not set up your own practice, and you're fighting for a cause. You are fighting for a cause because you believe You believe that you are lucky that you're on this side of the road and there's another man on the opposite side of the road who has nobody. Nobody looks at him. Nobody cares for him. Nobody gives a damn. And you can either leave him there or carry on the fight. Touch wood, we carried on the fight. This is a strong letter of support given at that time for the court purposes by TISS, Tata Institute, signed by the entire faculty of Tata Institute of Social Sciences. And finally, you see, this is just one article, Residents Wage War Against Mental Hospital in Dahisar. Times of India carried 2 articles. I mean, imagine somebody shouting, Gali Gali mein shor hai, Dr. Watwani chor hai, and Shraddha Murdabad and all that. Yeah, it is too much. My wife was literally pushed to the ground. After that, we met Jayanti Ben Mehta again. Jayanti Ben Mehta told us to go and meet the police commissioner of Mumbai. We went and met the police commissioner of Mumbai. That police commissioner told us to go and meet the deputy commissioner over there. We went and met the deputy commissioner of police. That guy appointed a Havaldar 24/7 outside our door of the NGO. Oh boy, you're doing social service under police protection. You're serving the citizens of society, of your society, under police protection. How far can people go in an attempt to block work which involves them? It was not that I was doing this for anybody else. They were not my relatives. So you are doing work under police protection for people who belong to society. How far can society go in neglecting its own? That is the golden question. But finally, after 1.5 years, the High Court gave a nod. Our advocate was one Anand Grover, who just now fought the LGBT case and won in the Supreme Court. And the opposite lawyer was Dhananjay Chandrachud, who is right now the Supreme Court judge. And the High Court said that the mentally ill roadside destitutes are as much entitled to medical help as any physically indisposed person. That was a shot in the arm. Now comes the question of why did we ever do all this? Why did we ever do all this? I mean, after having got the award and having read a lot on philosophy and whatever, one of the most enlightening passages that I've ever read is in a book called The Buddha and His Dhamma by Baba Saheb Ambedkar, who wrote the Constitution of India. He has written that men are born unequal. Some are robust, others are weaklings. This is quote unquote. Huh? Some have more capacity, more intelligence, others have less. Some are well-to-do, others are poor. All have to enter into what is called the struggle for existence. And if in this struggle for existence, inequality is recognized as the rule of the game, the weakest will always go to the wall. The weakest will always go to the wall. Should this rule of inequality be allowed to be the rule of life? That is the golden question which all of us, not just me alone, have to think and ponder upon. That should this rule of inequality be allowed to be the rule of life? Some answer in the affirmative, saying that yes, it is survival of the fittest. But are the fittest the best? That is the question. It is because of this doubt that religion preaches equality. It is because of this doubt that religion preaches equality. Now comes the tricky part. Our country is full of religiosity. You have multiple gods, multiple faiths, multiple temples, multiple mosques, multiple churches, multiple gurdwaras, multiple monasteries, multiple agyaris. You name it and everywhere you'll find a temple or something or the other. But are we actually practicing that equality that we talk about, that should be practiced? Are we practicing that? You do a fast before Ram Navami. You do a fast before Eid. You do a fast before the Durga Puja. The Catholics do a fast before in their Lent, this thing. But are we doing it for ourselves or are we doing it for somebody else? How many of us humans actually strive for this equality, actually pray for the hopes and aspirations of the underprivileged in India, wishing for them the dawn of a new morning? That is the golden question. Should this real rule of inequality be allowed to be the rule of life? It's a very simple thing. Where is justice? Where is compassion? Where is empathy? Where is love? Where is brotherhood? Where is equality in this thinking? What did you do to deserve to be on this chair today in BJ Medical College? And what did that guy do to deserve to be on the road in a badly state, wandering naked and getting raped? What did he do and what did you do? This is inequality. And then we say, where is the love? Where is that supposed God within all of us? Where is that supposed God? Therein lies the hub of true social work. I am not a psychiatrist. I am trying to do social work, whether success or not, I'm trying to do social work. It is a fight for social injustice, which Shraddha is doing. This is a principal on the road from Calcutta. And then thinking that we were not doing much, came the next point of change. My meeting Baba Amte. So at that time we had a social worker. He expired recently, Arvind Shenoy. And he said, let's go and meet Baba Amte. I said, chal, let's go and meet. So we were booked to go by train. When the teacher who was teaching maths to my children suddenly said, "Are yaar, me Babache bhakt hai, mala tumi घेऊन जा. तुम्ही जाऊच नको, मला घेऊन जायला लागेल तुम्हाला 100%." So out of pure respect for the teacher, we decided to go by car. When we went by car, we saw Anand Mandir. It was huge. 2,500 leprosy patients. I mean, those of you who have not seen have missed something. But Baba Amte was not there in Anand. He was in Hemal Kasa with Prakash Amte. Now came the key thing that we had the car. So I rang up my wife and I said, look, yaar, he's not there. We have to meet him. Finally, Bhagwan ko to milna hi padega. So she said, carry on. 100 kilometers before that Hemal Kasa, we came across a schizophrenic patient in the jungles of Gadchiroli walking alone. And both his hands and both his legs were in chains. Not a soul inside, not a soul. Unbelievable, yaar. Couldn't believe that this kind of thing could happen. Now, the first thing that happens, which happens to you and which happens to me and which happens to everybody, is that you get scared and you feel, chona yaar, kaun panga le. So I told that Arvind Shenoy, ask him, yaar, will he come? So Arvind Shenoy asked him, that boy was a Marathi. He said, nahi, kasha. I said, chal yaar, bala tal gayi, chona aage jate hain. I went 20 kilometers ahead when the sun was setting. And my conscience got the better of me. And I felt, my God, the entire 20 kilometers, there was not a single person on the road, yaar. Pura jungle hai. Sham ho rahi hai. Raat hone wali hai. What will this guy do on the road, yaar? And I did a U-turn. When I did a U-turn, I got down myself. Being a psychiatrist, I was able to put on him. He was passing urine and motions in his clothes since God knows when, because he was both hands, both legs in chains. I had a scissor. I cut all his clothes, made him naked. I had a chadar, put it around him and put him into the car. In those days, mobile were not there. Baba Amte didn't know I was coming. Prakash Amte didn't know I was coming. Mera haath kaapne laga. Bola sala na jaan na pehchan. They'll bloody abuse me. But I went. It was 8 o'clock in the night by the time I reached. Prakash Amte had just finished a massive OPD and almost on the verge of a collapse. So I said, sir, please, aap bura mat mano, I am doing this work. I explained very short and I told him to open the chains. I said, only then he can go to sleep. Now you look at the compassion of that person. Prakash Amte called for a chinni and a hathoda and started doing the work on his own. It took him 1.5 hours. This is Prakash Amte and this is the patient. These are the chains. This is a schizophrenic guy. You see how thin, emaciated, gaunt, marasmic the guy is. It was very delicate work. And he actually brought that hacksaw and started doing it. You see the patient in the background. Oh boy, what shape here, what shape. Zindagi यूं हुई गुजर तन्हा, काफिला साथ और सफर तन्हा. You see the chains which are removed. And I met the God in my life. I met Baba Amte. Now came the change. We had gone to sleep. The patient had gone up to sleep. I went to sleep. I got up at 4 o'clock in the morning. When I got up at 4 o'clock in the morning, I went down and Baba was awake. And he had tears in his eyes. He had tears in his eyes. So I asked him what happened. He said, whole night I could not sleep. Whole night I could not sleep, thinking as to how can society do this, that put a man in chains and leave him under this. And he actually took the chains. He actually took the chains and attempted to walk. I mean, for a guy who had received the ultimate awards, he had received Padma Shri, Padma Bhushan, everything on God's green earth. He had a whole room of awards here. To show compassion, to show empathy, to show love, to try and be equal to that person in chains was something out of this world. 4 o'clock in the morning, my life changed. As simple as that. And I knew that I had to do something. 4 o'clock in the morning, on that particular day, my destiny changed. And I realized that if he can reach this far, if he can reach this far, and if he can still hold on to compassion, then what you need to carry on is compassion. What you need to carry on is empathy. It is the heart which matters. Again, I was not in great financial shape or something, and he also, after leaving, when I left after 2 days, he told me just one simple thing. He said, Bharat, काम तुमचे चांगलं आहे पण खूप लहानपेक्षा तुम्ही करते, काय मोठा कर ना. That was the order, command of the decade. So when he said motha kar, now finally when you want to do motha, you have to get out of Bombay. So hunting, I came across a plot in Karjat. Before that, every 2 weeks he would ring up and say, Bharat, kitparant tumcha project pochlela hai? Are yaar, halat kharab yaar. I mean, imagine his involvement with the project and with me as a person. One day I was so toxic with that guy ringing him. I said, Budde ko kuch kaam dana nahi, mere piche pad gaya yaar. But he continued until I got the project. Moment I got the project, I rang him up and told him, Baba, jaga medali. He said, Bharat, मी येते. I said, कशासाठी? बोले नाही मी येते ना. I said, काय झाले का? उद्घाटन करायला येते. I said, बाबा तिथे लाईट पण नाही, पाणी पण नाही, काय नाही. अंधार आहे. त्यांच्या तुम्ही काळजी नको करा भरत. I am used to living in the jungle. I will come, you manage the inauguration. That is the level of commitment that he showed to a person whom he had met for the first time on that particular day, in that particular moment. That is something. Finally, he didn't come. I had printed the cards. I sent them to the courier when I saw a flash on the TV that he's critical and he's admitted. I dropped everything, took my 3 children, went in the car, drove non-stop, went to Anandvan, found him alive, and said, let's take it easy. And he didn't come. Finally, Prakash Amte did the. Battery down. Okay. In his biography, Baba Amte has written, I have always been drawn to this fellowship of pain. I think God created pain because without it, there would be no tenderness. It is very easy for a man to love God, but it is difficult for him to follow the commandment, love thy neighbor. The herd doesn't wait for the wounded deer. Therefore, someone else must help. The herd doesn't wait for the wounded deer. Therefore, someone else must help. That was the cornerstone of his existence, and that became the cornerstone of our existence. This is the plot in Karjat. It's a 6.5 acre plot with 5 units like this. You see, it is open to the sky so that the patient doesn't feel that he's enclosed and trapped and whatever. And we have around 20 patients in each unit, 20, 24, and you end up having around 120 patients. This is Prakash Amte inaugurating this is my wife with me. That is the fellow trustee Ashok Monani over there. And this is the words which Baba Amte had written for me in those days, 2005. Blessings to a person who had met him exactly for a few occasions. But the blessings have taken us this far. Like I said, what set Baba Amte apart from all other human beings was his compassion for the downtrodden. His understanding of the pain of human existence, his overpowering desire to reach out and try to ameliorate it was the guiding star of his life. He cared with his soul. He actually cared with his soul. When he died, I had gone to attend the funeral. In my lifetime, I have not seen so many people who are unrelated to a person, unrelated to the person who is dying, and weeping like as if it is their own relative, as if it is their own father, as if it is their own brother. And my luck being what it is, and his affection towards me, his attachment towards me, his communication with me, reached a point wherein when finally both of them, he and his wife Sadhna Tai, are buried in the premises of Anandvan, and they have named that place as Shraddhavan. Such is life. The word Shraddha comes from the Sanskrit meaning devotion. The logo of Shraddha which we chose, on the left side is the Ganpati. After that is the symbol of Allah. After that is the cross of Jesus Christ. After that is the Ek Omkara of Punjabi, Gurmukhi. And after that is the Parsi symbol of fire. All humanity is one. All faith is one. All suffering is one. The most important thing, all suffering is one. You, I, all of us are fellow brethren in our suffering. Some suffer more, some suffer less. But there is suffering. There is suffering. And I had a lot of people whom I regard as my mentor. I have met Mother Teresa personally. I have 3 adopted children apart from my biological daughter, all adopted from missionaries of charity. Tagore's Santiniketan I have visited. This is us in the good old days. This is my wife who's escorting the patient into Tamil in Andhra Pradesh. You see the thing at the beginning and you see at the time of the reunion. It is with her mother and father. This is the patient at the beginning, again after. Now the point is that the patient becomes so changed, so marasmic, so gaunt, so long-haired, so matted in his appearance that you can't recognize him even if you cross him on the road. This is a female who is depressed. Now I am showing you this. I mean, I wish that the pointer was there. Yeah. Yeah. Now you see over here, in the right corner, you'll come across this boy's grandfather just walking across, holding his cheek and going back. Oh boy, what a moment.
Recording channel.
You see his grandfather on the extreme right coming forward. He's not wearing a shirt. I mean, I remember seeing this video the first time I burst out crying. I couldn't believe that I had actually contributed to the joy of that elderly grandfather. It was perhaps one of the most emotional moments of my life because I felt, my God, we did this. Did we actually do it? This boy is depressed. I mean, the difference between the time of pickup and the time of reunion is something which is unbelievable. This is a bipolar patient. Again, the female down is bipolar. In this upper case, the relative has come down to our center to take him. Hurdles faced during treatment and care. Since you people are in the medical line, I mean, this is the state in which patients are. Somebody has put a tavi, somebody has done this, somebody has done that, maggots. We are handling everything. We don't have an MD psychiatrist, we don't have an MD general medicine, we don't have a surgeon nearby. Things are very difficult. But at the end of the day, you start doing all this. You start learning and you start taking care of all this. You are handling the diabetes, you are handling the hypertension, you are handling the thyroid, you are handling everything. This one on the left with the abdominal tear was with 3 children on the roads, female. Innumerable wounds because invariably they are beaten up with sticks, invariably they are malnourished, invariably they are subjected to a lot of heat, winter, rains. This boy was picked up by a student of a neighboring college. So the entire students had come down from for an NSS camp, and they ended up, I told them that, look, if ever you find anybody on the road, please bring him. And this boy actually had a temper and brought this fellow. Now my RMO who was there at that time got so scared, he said, nothing doing, we'll not admit this guy. That fellow got hold of my number, he rang me up and he said, sir, आपने तो बोला था, sir, patient दिखेगा तो आप लेके आओ, मैं लेके आया और ये लोग लेने को ready नहीं है. I rang up my RMO and I told him, forget the case, yaar. You don't show me that. That time WhatsApp was not there. So I said, forget everything, you first take the patient. My classmate, Dr. Sanjay Vaidya, did the plastic surgery and the guy improved and we reunited him in Bangladesh. And those boys of that particular college now have ended up literally picking up patients on their motorcycle and bringing them, in rickshaws and bringing them. All the auto rickshaw people, all the police people, everybody in the neighboring area knows that this center will do good. This is awareness. This is huge awareness as far as mental illness is concerned. Our dean is a psychiatrist. He will understand that what is missing in today's society is awareness in the whole of India. So we don't end up reuniting a person just because he has given us the address. We end up reuniting the person when he's much, much better. So the entire community understands that finally the patient is treatable. Huge number of females coming out and 2 or 3 patients are taken at a time. So the society realizes that, look, this is a treatable problem. This breaks the myth that people are not accepted in society just because they have mental illness. The truth is that they are not aware. There's no proper treatment going on. This is again another video. It's a rare one which I put. The child is crying because he met his father. The child is crying because he met his father. When you see a child, you realize the trauma that must be going on in the child's mind because he has lost his parent to mental illness, and mental illness has separated the parent, and the child doesn't know what is mental illness. Huge awareness is going on due thanks to the social workers involved. All these patients which you see sitting on the ground, all of them belong to Andhra Pradesh. All of them we have taken combined at a single shot in a single ambulance trip. The reason being that when you take it by ambulance, there's a huge amount of awareness which is created in society. So during the train travel, during the stay at the lodge, during the ambulance trip, during interactions, everywhere there is awareness, awareness, awareness. Female cases, unbelievable. You see this. It's a very rare video. I mean, I don't have like this occasions when such a video is taken. There's a young guy, maybe 7, 8 years old. He's admonishing his mother for running away, and the fact that all his classmates, all the people in the village are saying, your mother, aapki mother pagal hai aur wo bhag gayi. And they are going on taunting that boy. It's an unbelievable thing. This is in Bihar. You see how the mothering instinct of the mother takes over.
जवान जवान दूगो लड़का है कमा रहे एक लड़का अभी दूगो कमा रहा लड़का इसको दूगो तीन गो लड़का इसको कमा.
This is another case wherein the child is admonishing the mother for having run away. Another case. This happened just recently, 1 month back in Andhra Pradesh. Sound देना. Such is life. And awareness is generated. And there is debunking, delinking, dissociating the stigma that surrounds mental illness. This is a guy who was with us, this boy in the center. This is a boy who was with us for 1.5 years. Why? Because we couldn't understand his language. He was shifted from Chennai Mental Hospital to us. Until finally, somehow we came to know that he's in a remote area of Punjab where Punjabi is spoken a different language, different dialect. These are his relatives. And this gentleman, the elderly gentleman, gave our social worker 1,000 rupees as donation. It made us feel so miserable that finally for 1.5 years, for no fault of his, the patient was with us because we didn't have the social worker who could speak that particular language. That has made us focus on getting social workers who can speak different dialects. These are all patients shifted from a particular NGO. NGOs don't have social workers who can do all this work. This is from Trichy, from an NGO called Shantivanam. This lady which you see is the mother of an orthopedic surgeon. This guy on the extreme right is the orthopedic surgeon. It is in Surat. The mother of an orthopedic surgeon is in Chennai Mental Hospital purely because nobody can understand the language. So we shifted over here at our place and finally reunited her. There are a crowd of at least 5,000 people who turned up at that point. The orthopedic guy was very famous. This is an Iranian patient. You see that guy with the bag and with this Iranian patient picked up by us by pure fluke. It was I who was involved in the pickup. We picked him up. When he came to our nursing home, we realized, oh my God, we can't understand his language. Then we realized that he's speaking something Arabic. While telling him all the names of all the countries in the entire globe which speak Arabic, suddenly his face flashed when we spoke Iran. This is how he communicated with us. We had one social worker called Rehan Raza. He was well versed with Arabic. Telling his wife, telling his girl's name, and finally giving the phone number. And we contacted the Consulate General of the Islamic Republic of Iran. And finally, we sent him back home. Like I said, the newspapers have covered us up a lot. This is the mother of a politician in Andhra Pradesh. This is a gentleman who was reunited 54 years after leaving home. 54 years in Jalandhar. This is Maneka Gandhi giving us a testimonial to take in patients from all the mental hospitals all over India. At that time, she was Union Minister for Women and Child Development. We are interacting with various government. We are interacting with 14 government institutes right now, mental hospitals, with 42 NGOs, and innumerable police people have referred patients to us. These are innumerable students who have come over for NSS camps. I hope and pray that one day BJ Medical also sends its students for at least a day visit. Innumerable supporters have come forward over a period of time. And this is me getting the Raymond Magsaysay Award. There is that saying, you know, Allah Meherban to Gadha Pelwan. I happen to be that Gadha. Now, you look at the entire gestalt of the whole thing. 65,000 crores are spent on health. And guess how much is spent on mental health? 40 crores. 40 crores is all that the government can spare for the mental health of the citizens of India. So at the end of the day, you realize, which is very common nowadays in the younger generation, that they say, the government should do something. Yerada Mental Hospital should do something. This one should do something. That one should do something. The MP should do something. The corporator should do something. It is not the responsibility of anybody other than you. And you at your single individual level, if you do what you can, that's the best thing that can ever happen. It is the voice of the individual which matters. It is not the voice of XYZ representatives of the government. What are you doing? Why are you not reaching out? That takes it forward. Why is it that it is left to social workers? Is it not the responsibility of medicos? Are we not trained in the line? Whose job is it to look after all those wounds which are there on the roads? Whose job is it to look after all the pregnancies which are happening on the road? It is ours. We are the medicos. We are not chartered accountants. We are not lawyers. We are medicos. And we are the blessed few in this country. And BJ Medical College is one of the topmost colleges in the whole of India. And it is your responsibility to reach out and help them. Now, people say that, my God, Dr. Bharat Watwani, he's like a devta, you know. What is the actual truth? Let me tell you the actual truth. There is 1.8 million people who are homeless. 18 lakh people in the whole of India who are homeless. Incidence of mental illness per se in the homeless is 60%. So almost 10 lakh Indians are homeless and mentally ill. So you have 10 lakh people who are wandering mentally ill. And what has Shraddha done? All that Shraddha did over 30 years of struggle was picked up, treated and reunited 9,000 of these destitutes. Now the golden question is, what happens to the remaining 9,91,000? What happens to the 9,91,000? So it is not one Shraddha which is required. It is innumerable Shraddhas which have to be spearheaded by all of you. This guy is a resident of Pune. This guy who you see, he was one of the earliest pickups that we had. He was picked up from Missionaries of Charity. He was, when I went for the visit to Missionaries of Charity, I used to go there as a psychiatrist. His hands and legs were in chains. They said he's very violent. So I said, untie the chains, send him over just now. We didn't have a bed at that time. We kept him on the floor. I didn't have anything. I didn't have a social worker. I had a motorcycle. On the motorcycle, I came till Wakad. 20 kilometers before his place, everybody said, "Arey, te Wakad la rate, Wakad la rate." And I met his parents. They didn't come with me on that particular day, so I was very upset. But they came on the next day. The reason being that they wanted to felicitate me in the typical traditional Maharashtrian fashion. And this is me being felicitated. This is his father and this is his grandfather. You see in the bottom photo. And this guy is right now doing very well in business. He owns a Toyota Fortuner and he has contributed almost every year to Shraddha. And when I told him that Mumbai Mirror wanted to take an interview with a live person, will you come? He said, I'll readily come. That is stigma being broken. His name is there. He has acknowledged his name. He has acknowledged everything. He came for my daughter's wedding also. This is me being covered in the Time magazine. You see this Gujarati Chitralekha. The guy who journalist was one gentleman called Devanshu Desai. Earlier also he had met me. You know, while talking to him, he told me that there is a lady who was there when he was in the 8th standard or the 9th standard in his village in Valsad. And that lady was mentally ill. And they used to get very scared of her. And he said that that lady is still there on the same place. Now that I've become a journalist, and he must be 50 years old. So I thought to myself, 35 years have gone by, boss. 35 years have gone by and that lady is still there. Where must she be going when she was having her menses? Where must she be going when she wanted to go for urine motions? Where the hell must she be going? This is us. How far can society go in neglecting the wounded within its own? How far can society go? Oh boy, just that hearing that thing, you know, my hair stood up and I said, I had done nothing here. I mean, the Raymond Magsaysay Award is worth nothing. At the end of the day, that lady is still there. She is still there. That is the tragedy of life. That is the tragedy of life. You know, when in one of the psychiatric conferences, at that time the president was one Dr. Ajit Bide. So he said openly that despite 30 years having been over, I have never heard of Shraddha and I have never heard of Dr. Bharat Watwani. He candidly acknowledged. And he made it out as if we were very altruistic. So I thought to myself that, am I actually that altruistic? And the heartfelt answer was, no, I was not that altruistic. I was doing it for all the strokes, for that sense of joy, for that sense of emotional fulfillment, which I was getting in the job. And this is one of those examples. This lady was in Shimla Mental Hospital. Shimla Mental Hospital. The Chief Minister, Jairam Thakur, his wife, Sadhna Thakur, happened to see this lady in her village in Himachal Pradesh. She shifted him to Shimla Mental Hospital. We are coordinating with various mental hospitals. After 2 years, somehow our social workers chanced upon her, spoke to her. She was a Maharashtrian and she was from Nagpur. Tribal lady. We brought her to Karjat, gave her a little more fine-tuning of the treatment and took her to Nagpur. She turned out to be tribal. She turned out to be a Catholic. And this reunion has taken place on the day of Christmas. This reunion has taken place on the day of Christmas. And you see in this house, if you see on top, it is written, Jesus loves you. Oh boy, Jesus loves you. Just that 3 words, makes you feel you're in heaven. I mean, I couldn't believe that such a thing could happen, that on Christmas Day, you can actually reunite a person, Catholic lady with her family in a remote village in Nagpur. And here, get to see those words. Jesus loves you. You felt that was the message. That was the message. And these things have taken our social workers forward. None of us are flashing whatever we are doing on WhatsApp and this and that and innumerable Twitter and whatever. This is what takes you forward. It is that feeling that you change the life of that lady and you change the life of those children. This is Jyoti Raut, my social worker, and that is Sulakshna Aher with the stars. She's our social worker. This is in Jammu, the news. This is West Bengal. Anand Bazar Patrika is very famous. This is Bhopal. Reader's Digest covered us up. And you see these 2 people with the towels. They are Asami towels given as a gift by the patient's relatives to our staff. In COVID times, they have actually come from, last week we had somebody, a relative who came from Agartala. Agartala is right at the end of India, on the corner, eastern corner. From there, he came till Guwahati to take his relative and gave the social worker this towel. That takes you to a different level altogether. And touch wood, we have a team of social workers which is out of this world. Recently, one Dr. Arun Gadre, my classmate from Pune, he came and he told me just one single sentence. He said, boss, the whole backbone of Shraddha is the team of social workers. I said, yes, it is the team of social workers. And just when you feel that you have done something and people tell you have done something, I got an email from this guy, this young kid which you see in the photo, saying that I've lost my dad to mental illness. And this is the last photo I have of my family. This is the last photo I have. Can you help me find him? And you're helpless. Till today, I have not been able to reply that email because till today, I have not been able to find his father. Such is life. I think I'm running out of time, but I'll just take up a few more minutes. People ask as to what is the cornerstone of great social work? The cornerstone of great social work, which is where all medicos have to reach, is understanding the emotions of the Samne wala person. Understanding the emotions of the Samne wala person. I'll give you an example. One of my social workers, Farzana Ansari, went to Missionaries of Charity. Elderly lady, 75, 80, gasping. Suddenly developed a bond with her, and my social worker developed a bond with that lady. And that lady told my social worker, "Mala ghari jayche hai, main Sholapur jaye." 2 sentences. That social worker did not bother to ask me. She could have very easily asked me. WhatsApp was on at that time. She didn't bother to ask me. She brought the lady. Next couple of days later, I went for the round and I found this old lady gasping. I said, "My God, yaar, what are we doing picking up almost half dead patients?" She said, "I picked it up. And this lady is relevant and she belongs somewhere to Sholapur." Now, I am a psychiatrist. She was having severe asthma. I didn't know what to do, and there is no medical really great facility nearby. But my RMO, who is a homeopath, said, "Don't worry, I'll manage the asthma." Nilesh Matre. He managed the asthma. Finally, I happened to be a good coordinator. So I told them, I said, look here, you forget my coming or not coming. The day you feel she's somewhat better, that day, take the ambulance, take the nebulizer, take the oxygen cylinder, take 2 nurses, take 2 RMOs, and go in the night, straight push off at 10 o'clock in the night and reach Solapur in the morning. Don't stop anywhere. Take sandwiches, take tea, take everything. Don't stop anywhere. Take her. And they did that. They did that. And I felt that all my life, I'll remember that scene when she held my cheeks in her hands and said, Mala ghari jayche. Baba, tumi mala ghari pocho. Just that single request of an elderly lady who's on the verge of dying. If she would have died in Missionary of Charities, it would not have made a difference, because Missionaries of Charities is created for that, for helping out the dying destitutes. If we would have rejected her, we were fairly okay, because we are psychiatrists. We are not supposed to look after all these difficult patients. But my social worker went the distance, Shraddha went the distance, and that lady reached home. Unbelievable. There is no relationship by blood between anyone concerned. Nor is that action of yours put up anywhere on the media. Nor is it reported in the newspapers. It is reaching out, soul to soul, heart to heart, emotions to emotions. Compassion is where it begins. Compassion has no beginning, no ending. It is the ever-widening river reaching out to the sea. What matters because of your efforts, what matters because of the efforts of the medicos of BJ Medical College is whether the quantum of pain and suffering in the sea of human suffering out there, sweeping across the length and breadth of the country, went down marginally. Went down marginally. That day, you will treasure this college. That day, you will treasure your conscience. That day, you will treasure your heart. And you will believe that what you did was right. And it was right to choose medicine. And it was the best line on the face of this earth. There's a statement made by Mother Teresa. We ourselves feel that what we are doing is just a drop in the ocean. This is so true. I mean, I always feel we did nothing. But the ocean would be less because of the missing drop. So you have to contribute that smallest drop to the pain of human suffering, which is out there in the country. And let me tell you what is the human suffering out there. 363 million people, 36.3 crores of population, almost 27% are living below the poverty line. And guess what is the poverty line? 32 rupees per day in rural India, 47 rupees per day in urban India. The number of disabled in India is 27 million. The number of people having mental illness is 197 million. 19.7 million people are having mental illness. And boy, oh boy, the government gives exactly 40 crores for that. It is their bad luck and it is our good luck. Now, can we bridge that distance? Can we go that one step forward? Can we take it just a little bit forward? Is the golden question which touched my conscience, is the golden question which touched Baba Amte's conscience, is the golden question which has touched each and every social worker's conscience as to can we go that little distance? And I think you can. I think you can. I think you can. If at the end of your journey as a medico, if at the end of all your struggles, the level of compassion, the level of sympathy, the level of empathy, decency, care, concern, and hope, if that sense of justice, equality, and non-discrimination, which all of us have for the underprivileged within society, was to increase even marginally because of all our efforts, your efforts, my efforts, then I would believe from the bottom of my heart that this talk has come true. Otherwise, there is no purpose of this talk. I would believe from the bottom of my heart that this talk has come true, and it is a cherished dream of mine that this talk comes true. So that ultimately, eternally and into infinity, my tears, your tears, our tears mingle with the tears of the common man, and our common tears mingle with the downpour of the common rain to become one. That has to be the faith of the BJ Medicos. That has to be your vision. That has to be your offering. That has to be your prayer That has to be your anthem. That has to be your heaven. That has to be your nirvana. That has to be your dream fulfilled. That has to be your dream fulfilled. Only on that one single hope, only on that one single apeksha, only on that one single ummeed have I traveled this distance all the way from Bombay in COVID times and thought that let me talk it out with you. Let me talk. BJ was, and will remain one of the most prestigious institutions in the whole of India. And this prestigious institution has to come up with doctors who can do their bit for society, who can do their bit for the underprivileged within society. You are the guardians of truth. You are the guardians of truth. I belong to that old school of thought which believes that the doctor with his patient is mightier than the warrior with his sword. Some of us may not be given recognition by society. It doesn't matter. The other time when people, 100, 200 people had gathered and were shouting, "Gali gali mein shor hai, Dr. Watwani chor hai." Let them shout. You have to take it forward. With persistence and with moral courage, all of us can create and nurture good deeds and remove the pessimism that is seeping into society. We can light the spark in the smallest of ways until the goodness cumulatively adds up to a huge tidal wave of truth. Sound there.
In a metro like Mumbai, you would come across on any given day 500 people who are wandering around. So you look at all the metros, there must be lakhs of people who are on the road. No, it can happen to you, it can happen to me, it can happen to anybody. See, that is the tragedy of the whole thing. That basically the person is wandering on the road not because he wants to wander on the road, but because he is afflicted by a mental illness which is overpowering his senses. Then he may end up in a bus or in a train, wherein the people realize that he is mentally ill and nobody bothers to ask him for a ticket or something. Finally, when he ends up in Mumbai, he is offloaded.
So you have to be very supportive, the way you talk, your body language, the way you approach them. That is very important in dealing with these patients, and winning their confidence. That's important.
Providing shelter to the mentally ill and the roadside destitute is Shraddha, a rehabilitation home in Karjat in Maharashtra.
Initially, we are looking after basic hygiene and basic nutrition. Person is in a bad shape physically. Then we gradually start psychiatric medicine on it in a very slow format. So because we have a good vast campus, हम लोग उनको rice cultivation, vegetable cultivation, dairy farming, इसमें हम लगाते हैं. This kind of, brings them back to their roots. I feel more than teaching them a skill, the improvement rate is much faster.
As patients get better and start recalling their past, it is time for Dr. Watwani and his team of social workers to take them back to their homes.
We don't establish contact with the family. We directly take them to that particular village where we believe they belong from, because that creates an impact on the whole village. That is the idea. Finally, they realize that here is a person who has become all right and is being brought back. So mental illness is a treatable commodity. That word tends to spread very fast.
जब हमने संदीप को देखा कि थाना रोड पे बैठा है, वो संदीप था, उसको पिकअप किए हम लोग वहाँ पे। उसकी उस टाइम कंडीशन ऐसी थी, वो एक टूटा सा चश्मा लगा कर था, एक तरफ ग्लास थी, एक तरफ ग्लास नहीं थी, और शर्ट पहन के था, और एक कांग्रेस का एक झंडा लगा के वो गले पे लगाया था। मतलब कि उसका एक स्टाइल था कि वो यहाँ का हीरो है, और मुंबई जगह पहचान के वो अपने हीरो के स्टाइल में चल रहा था।
कहाँ जा रहे हो? इंडिया। इंडिया जा रहे हो? आपका घर कहाँ है? इंडिया। इंडिया में कौन सी जगह?
क्या नाम है आपका? रियूनियन करने ले गए उसको, वो बांकुड़ा जिले का था। गांव पहुंचने के बाद गांव वाले बहुत खुश हुए। 10 साल के बाद वो घर पहुंचे।
बॉम्बे बॉम्बे
उसकी माँ ने जब उसे देखा तो माँ जैसे ही उसे देखी, उसे मिलने से पहले ही वो जाके नदी में छलांग मारी, अपने आप को पवित्र किया, वहां से निकल के आई, फिर अपने बेटे को छुआ, अपने बेटे से बातचीत की। वो हमारे लिए बहुत अच्छा किया। और घर वाले, पूरे गांव वाले जमा हो गए। उसके चाचा भी थे, वो भी पुलिस में थे, उन्होंने भी बहुत तलाश किया, खोज नहीं पाई। लेकिन जब हम लोग लेके गए, हमारा बहुत सम्मान हुआ, हमारी इज्जत भी की वो लोग, तो बहुत खुश हुए वो लोग।
भाई ये तो जंगीरे मिस्त्री का करकड़ा। चलो भी चलो, ये तो बंबे तो आए नहीं छड़ना।
मैं इज्जत करवा कर दे, चलो बैठो।
सारी खुश है, सारा पिंड खुश है, सारा पिंड खुश है।
Another success story is that of Gangadhar Vinod, one of Dr. Vatwani's earliest patients.
He had met with an accident on the road. His leg was fractured. He couldn't walk, and he was literally in a catastrophic state.
मेरी जिंदगी बदल गया। मैं तो मरने वाला था, मैं तो यही रोड के ऊपर पड़ा था। 18 साल था मेरा वो टाइम। इनका बहुत बड़ा काम है, ऐसा कोई घर वाला भी नहीं करता है। अगर कोई थोड़ा सा गलती करता है तो घर वाले भी मारते हैं, लेकिन ये लोग बहुत प्यार से।
To end, Gandhiji has said somewhere that while doing anything, we must think of the last man standing. I have written an autobiography. The book is there outside. But the point is that this talk will be forgotten. I will be forgotten. I will die. The autobiography no one will read. But at the end of the day, that person on the road happens to be the last man standing. And he will continue to be there until someone within all of us does something for him, far beyond what Shraddha has done. And I hope, I pray, I appeal to all the BJ medicos to come forward and do their bit for the underprivileged within society. It is not just one or two last man standing. 363 million people are below the poverty line. There's a lot of work to do, miles to go, prayers to fulfill, dreams to until we sleep. Thank you.
Thank you, sir, for your inspiring words. It has motivated each one of us to work for humanity. Sir has also written 2 books, Unseen, Unheard, and Unsaid. Bedakhal. We have these available at our registration desk outside MGA. I'm sure they are a bundle of wisdom, so please do check them out. Now I request you, sir, to be seated in front of the dais. Before moving ahead, I extend a warm welcome to respected Dr. Pramod Umarjil, sir, to our conference. Moving on, we have a short session by Jigyasa, the BJGMC UG Research Committee. So I call upon Varun Pathak and Manali Raut to felicitate respected Dr. Aarti Kinikar ma'am, the professor and head of Department of Pediatrics and the research advisor of our college council.
Hello and good morning, everyone. I am Varun Pathak, the Research Secretary for the year 2021-22. So most of you attended the inauguration ceremony yesterday. So you must have heard my brief speech about how Jigyasa is now the official undergraduate research committee of BJGMC and Sassoon General Hospitals, Pune. So today, I and Manali, we are going to talk about exactly how this committee came into being and the whole process of development. So I'm proud to say that we have built quite a large community of medical students interested in research on our social media platforms. First, we have our YouTube channel where I'm very proud to say that we have almost reached 1,000 subscribers on our YouTube channel. We have put up a large amount of videos right from the basics of research, from students of our own college and several other videos about recent developments in research. Then on our Instagram, we have reached 900 followers, which is again very close to 1,000 followers on Instagram. We have also put out a lot of posts on our Instagram about relevant research articles, posts about research methodology, and something which can help undergraduate students right from the outset of their research journey. So the basic structure of Jignasa is very simple. We, the core team, come up with ideas and events, and then we discuss these amongst ourselves. Then we hold meetings with our teams, and then finally we reach ideas as a whole team, then disseminate these ideas, delegate work, and then conduct events. And the basic foundation that was laid by Manali has really made this entire process very streamlined. Then let us talk about some of the events that we have done in this year. So first of all, we conducted the induction of the new council on 27th of October, 2021, and where everyone was acquainted with Jignasa. Then on the 31st, we conducted a very interactive webinar on the basics of research and ethics and publication ethics when it comes to research articles. And we also conducted a session on how to read a research articles. And these sessions were attended by more than 250 medical students. Then even on our Instagram, we have several posts about recent developments like the 2021 Nobel Prize for Physiology. We also have a lot of future events planned in case anyone wants to attend. We plan to conduct several events to make the process of ethical approval easier for students. We also plan to release a research newsletter and to organize research exhibitions and competitions like paper and poster and case presentation competitions. So lastly, in these times of evidence-based medicine, students understanding research and having a habit of reading research articles is the need of the hour. Our committee will try its best to get students interested in research to learn and study in a whole new way, conduct and publish their research work, and become better doctors of tomorrow. With excellent guidance from teachers and all professors of this college and students filled with curiosity, we are sure that our college will rise to a higher level of excellence. But you know what? Jignasa wasn't always like this, and it wasn't always so simple to conduct events and just make teams and plan out events on our YouTube and Instagram. So I would now like to call on Manali to tell us how exactly Jignasa came into being. Thank you, everyone, and I hope you enjoy Respirare 2021.
Okay. Okay, so hi everyone. I am Manali Raut, Research Secretary 2019-2020. So like this only in Respirare 2018, Benita Ansam, she was the research secretary before me. So she had conducted this research methodology workshop. And that is how I got intrigued, very intrigued by this whole thing about research. And later, as the council elections came by, and I had seen a lot of things like UG students are not really aware, and we all, even I, at that point of time, knew only about ICMR. So then I applied for the post of research secretary and I was elected. So that time I went to Kinikar ma'am, and then I asked for all her suggestions, and she has been so supportive and she guided me throughout. So she told me that Manali, whatever you do, you have to take everyone along with you. That should be your motto. And I hope that I have done that. So after that, we conducted like basic events, like we had an introduction session for ICMR and symposium, and by MUHS, they have this research competition, research presentation competition, Avishkar. And that's how I met Rohit sir and Neil sir. And during all this time, I realized that UG students are facing a lot of problem because they are not aware of the whole process. There's this whole process of research and they get really scared because they are not aware about it. So then one day, that is 25th November, me, Neil sir and Rohit sir were sitting on stairs and we were discussing that how can we make this easy for the students. And that's when we came up with this plan of having a research committee, that is students who are interested in research, who can help in spreading awareness and spreading this research culture in our college and beyond. So then with this whole proposal, and I had also thought of a name, I wanted to give it an Indian name. So I gave it a name, Jignasa. So then after that, we took the whole proposal and we went to Kinikar ma'am. And she was really supportive. She helped us throughout this process. And after having established pandemic so much, we established we held the first session after establishing the club in February, that is introduction to research. And after that, and we had a lot of events planned, but then COVID pandemic hit us. So then, but we used it to our full benefit and we conducted all the events related to research online, right from how to choose a research topic, biostatistics, study design, how to read a research article, literature search, all the events they were not only conducted by the teachers, but there were some of the events which were conducted by students who had done research, like they had shared their experience, that what all problems they face and how they can overcome it. So the main thing, so all these are the research that we conducted. And we made sure that we took all the feedbacks, like we were trying to improve after every event that we conducted. And the main thing, the quote that I really believe in, the idea of life is to inspire. So during this whole process that we were trying to establish this committee, we were conducting sessions, we got mails from engineering colleges saying that you guys are doing a really great work. And there were colleges, medical colleges, because they didn't have all these facilities. So they approached us and they said that how can we set up a research committee in our college? Please help us. So we helped them and now they have successfully started a research committee in their college as well. So that is the whole story. I hope that you all become a part of Jignasa and take up research so that we all can keep the curiosity in ourselves alive. Thank you so much. Thank you, Varun and Manali. Now we have come to the end of our session. So I would like to propose the vote of thanks. Firstly, I thank our guest speaker, respected Dr. Bharat Watwani sir. It was a great delight to have you here. It has added glory to our Respirare conference. Thank you once again, sir. I also thank Honorable Dr. Rupa Tekchandani ma'am for your help and valuable time. I now thank our respected Dean, Dr. Vinayak Kaya sir, respected Deputy Dean, Dr. Rajesh Karyakarte sir, for your support and graceful presence. I extend my gratitude to our research advisor, Dr. Aarti Kinikar ma'am, Dr. Kagal ma'am, and Dr. Smita Tiwari ma'am, the academic advisor, for your guidance. I also thank our general advisor, Dr. Harish Tatia sir, for your precious time. Lastly, I thank all the dignitaries and senior faculties for your valuable time. Thank you once again.
interested in identify ऐसे ये सारे जो एलिमेंट्स है इनके वैल्यू सारी तीन मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना पड़ेगा कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं इन अ फिनोमेना नोन एज वॉकिंग।
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis, but which kind of episodes, everybody? Chronic episodes.
We have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in two axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, it is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or brow presentation.
They're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I have given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe-ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
As I was looking at the file, maybe I was half sleepy. Something interesting happened. The file just slipped off my hand and fell. What happened was, when the file went and fell down next to the child suddenly startled. The moment the child startled, my sleep went away. I was wondering what happened. I just took the file again, put it down again. The gush of air, another startle. That's when my brain tickled and said, could it be something which we are missing? I took a water bottle nearby, poured water next to the child. The child started gasping and startling. That is what we call as hydrophobia. Most important point was, this child was in neurology wards under the best doctors for about 3 days before, and nobody had picked up rabies in that child. When I saw with half sleep, picked it up. What is most interesting to say here is, anytime when I doubt my clinical abilities, I remember this and I say, Sunil, clinical skills will always help you. So, welcome to Marofy edition, where we'll be talking about a lot of clinical vignettes and a lot of things which will matter for life, not just for the entrance. Natural or environment phobias could be something like hydrophobia, which makes you not go to places where there's a lot of water, lakes, ponds, swimming pools, such kind of natural environments, and those can make them trigger having extreme fear, hydrophobia. They can also have acrophobia, which makes them find it difficult to go to hill stations and those where heights kind of are a bother to them.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स है, इनके वैल्यू सारी 3 मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करने पड़ेगा, कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walk.
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis. But which kind of episodes, everybody? Chronic episodes.
We have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in 2 axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, it is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or bro presentation.
If they're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I have given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe-ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
As I was looking at the file, maybe I was half sleepy. Something interesting happened. The file just slipped off my hand and fell. What happened was, when the file went and fell down next to the child suddenly startled. The moment the child startled, my sleep went away. I was wondering what happened. I just took the file again, put it down again. The gush of air, another startle. That's when my brain tickled and said, could it be something which we are missing? I took a water bottle nearby, poured water next to the child. The child started gasping and startling. That is what we call as hydrophobia. Most important point was, this child was in neurology wards under the best doctors for about 3 days before, and nobody had picked up rabies in that child. When I saw with half sleep, picked it up. What is most interesting to say here is, anytime when I doubt my clinical abilities, I remember this and I say, Sunil, clinical skills will always help you. So, welcome to Marofy edition, where we'll be talking about a lot of clinical vignettes and a lot of things which will matter for life, not just for the entrance. Natural or environment phobias could be something like hydrophobia, which makes you not go to places where there's a lot of water, lakes, ponds, swimming pools, such kind of natural environments, and those can make them trigger having extreme fear, hydrophobia. They can also have acrophobia, which makes them find it difficult to go to hill stations and those where heights kind of are a bother to them.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स हैं, इनके वैल्यू सारे 3 मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना पड़ेगा, कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walk.
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis, but which kind of episodes, everybody? Chronic episodes.
We have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in two axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, which is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or brow presentation.
If they're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I have given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added, and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
As I was looking at the file, maybe I was half sleepy. Something interesting happened. The file just slipped off my hand and fell. What happened was, when the file went and fell down next to the child suddenly startled. The moment the child startled, my sleep went away. I was wondering what happened. I just took the file again, put it down again. The gush of air, another startle. That's when my brain tickled and said, could it be something which we are missing? I took a water bottle nearby, poured water next to the child. The child started gasping and startling. That is what we call as hydrophobia. Most important point was, this child was in neurology wards under the best doctors for about 3 days before, and nobody had picked up rabies in that child. When I saw with half sleep, picked it up. What is most interesting to say here is, anytime when I doubt my clinical abilities, I remember this and I say, Sunil, clinical skills will always help you. So, welcome to Marofy edition, where we'll be talking about a lot of clinical vignettes and a lot of things which will matter for life, not just for the entrance. Natural or environment phobias could be something like hydrophobia, which makes you not go to places where there's a lot of water, lakes, ponds, swimming pools, such kind of natural environments, and those can make them trigger having extreme fear, hydrophobia. They can also have acrophobia, which makes them find it difficult to go to hill stations and those where heights kind of are a bother to them.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स हैं, इनके वैल्यू सारे 3 मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना है, कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walking.
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis, but which kind of episodes, everybody? Chronic episodes.
So we have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in 2 axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, which is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or bro presentation.
If they're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I have given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added, and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
As I was looking at the file, maybe I was half sleepy. Something interesting happened. The file just slipped off my hand and fell. What happened was, when the file went and fell down next to the child suddenly startled. The moment the child startled, my sleep went away. I was wondering what happened. I just took the file again, put it down again. The gush of air, another startle. That's when my brain tickled and said, could it be something which we are missing? I took a water bottle nearby, poured water next to the child. The child started gasping and startling. That is what we call as hydrophobia. Most important point was, this child was in neurology wards under the best doctors for about 3 days before, and nobody had picked up rabies in that child. When I saw with half sleep, picked it up. What is most interesting to say here is, anytime when I doubt my clinical abilities, I remember this and I say, Sunil, clinical skills will always help you. So, welcome to Marofy edition, where we'll be talking about a lot of clinical vignettes and a lot of things which will matter for life, not just for your entrance. Natural or environment phobias could be something like hydrophobia, which makes you not go to places where there's a lot of water, lakes, ponds, swimming pools, such kind of natural environments, and those can make them trigger having extreme fear, hydrophobia. They can also have acrophobia, which makes them find it difficult to go to hill stations and those where heights kind of are a bother to them.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स है, इनके वैल्यू सारी 3 मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना है, कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walk.
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis, but which kind of episodes, everybody? Chronic episodes.
So we have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in two axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, which is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or bro presentation.
If they're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I have given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added, and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
As I was looking at the file, maybe I was half sleepy. Something interesting happened. The file just slipped off my hand and fell. What happened was, when the file went and fell down next to the child suddenly startled. The moment the child startled, my sleep went away. I was wondering what happened. I just took the file again, put it down again. The gush of air, another startle. That's when my brain tickled and said, could it be something which we are missing? I took a water bottle nearby, poured water next to the child. The child started gasping and startling. That is what we call as hydrophobia. Most important point was, this child was in neurology wards under the best doctors for about 3 days before, and nobody had picked up rabies in that child. When I saw with half sleep, picked it up. What is most interesting to say here is, anytime when I doubt my clinical abilities, I remember this and I say, Sunil, clinical skills will always help you. So, welcome to Marofy edition, where we'll be talking about a lot of clinical vignettes and a lot of things which will matter for life, not just for the entrance. Natural or environment phobias could be something like hydrophobia, which makes you not go to places where there's a lot of water, lakes, ponds, swimming pools, such kind of natural environments, and those can make them trigger having extreme fear, hydrophobia. They can also have acrophobia, which makes them find it difficult to go to hill stations and those where heights kind of are a bother to them.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स है इनके वैल्यू सारे 3 मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करने पड़ेगा कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walk.
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis, but which kind of episodes, everybody? Chronic episodes.
We have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in 2 axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, which is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or bro presentation.
If they're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I have given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added, and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
As I was looking at the file, maybe I was half sleepy. Something interesting happened. The file just slipped off my hand and fell. What happened was, when the file went and fell down next to the child suddenly startled. The moment the child startled, my sleep went away. I was wondering what happened. I just took the file again, put it down again. The gush of air, another startle. That's when my brain tickled and said, could it be something which we are missing? I took a water bottle nearby, poured water next to the child. The child started gasping and startling. That is what we call as hydrophobia. Most important point was, this child was in neurology wards under the best doctors for about 3 days before, and nobody had picked up rabies in that child. When I saw with half sleep, picked it up. What is most interesting to say here is, anytime when I doubt my clinical abilities, I remember this and I say, Sunil, clinical skills will always help you. So, welcome to Marofy edition, where we'll be talking about a lot of clinical vignettes and a lot of things which will matter for life, not just for the entrance. Natural or environment phobias could be something like hydrophobia, which makes you not go to places where there's a lot of water, lakes, ponds, swimming pools, such kind of natural environments, and those can make them trigger having extreme fear, hydrophobia. They can also have acrophobia, which makes them find it difficult to go to hill stations and those where heights kind of are a bother to them.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स हैं, इनके वैल्यू सारे 3 मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना पड़ेगा, कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walking.
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis, but which kind of episodes, everybody? Chronic episodes.
So we have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in two axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, which is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or bro presentation.
If they're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I have given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added, and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the clinical core edition
for the final round of Vocalize, the debate competition of Respirare, organized by BJGMC Pune. We have with us today our esteemed judges, Dr. Varsha Sarode ma'am, Dr. Zanzad sir, and Dr. Chaya Zadav ma'am. Thank you for dedicating your time today to judge this competition. Dr. Zanzad sir specializes in forensic medicine and heads the FMT department of BJGMC. Sir has a teaching experience of over 20 years, 22 publications in various national and international journals, and an awe-inspiring teaching history.
Recording in progress.
Class 1 medical officers at Yashwantrao Chavan Academy Development Administration, police officers and CID officers at Center for Police Research, Pune, and Maharashtra Police Academy. Sir has also served as a speaker in various conferences, CMEs, and panel discussions. It is a privilege to have you as our judge. Thank you, sir. I now call upon Meenal to felicitate Dr. Zanzad, sir. Thank you. Sir, can you please come on stage for the felicitation? A round of applause for sir. Thank you. Thank you, sir. Dr. Varsha Sarode ma'am, the head of our physiology department with a specialization in the subject and a keen interest in autonomic function testing, has a professional experience of over 22 years in physiology, both UG and PG, and is also a PG guide for MD in physiology.
Ma'am has many feathers in her cap, just a few of which are being the member secretary of BJGMC CTU Ethics Committee, coordinator of the Medical Education Unit of BJGMC, and recipient of the 2019 Best Medical Teacher Award by DMER. We are honored to have you today with us, ma'am. I now request Nikita Takle to felicitate Dr. Varsha Sahade, ma'am. Thank you. Thank you, ma'am. Dr. Chaya Zadav, ma'am, is a dedicated educator who aims to encourage successful learners. She's a great orator with profound interest in debate and has excellent communication and leadership skills, and a teaching experience of more than 5 years. We are very glad to have you with us today, ma'am. I request Meenal Vakse to felicitate Dr. Chaya, ma'am. Thank you, ma'am. Now introducing our faculty speakers. Dr. Sharad Agarkhedkar, sir, Professor and HOD, Department of Pediatrics of D.Y. Patil Medical College, holds various prestigious positions, having been the former president of IMA Pune and IAP Pune, and has chaired many events. I request Deshna to felicitate, sir. Thank you, sir, for being here. Dr. Manish Machve, sir, has been the Vice President of Pune OBGYN Society, organizing secretary in various conferences. Sir is the first from Pune to be awarded the prestigious FOGSI Padma Shri Dr. Kamini Rao Oration in 2013 and has more than 1,500 deliberations at national and international events. I request Anova Sheikh to felicitate, sir. Thank you. Dr. Kishore Guzar, sir, MD Psychiatry, has served as the organizing secretary in many conferences and as the president of Indian Psychiatric Society and the Indian Association of Child and Adolescent Mental Health. Thank you, sir, for your time. I request Deshna Shah to felicitate, sir. Dr. Kalpana Kulkarni, ma'am, MD Pathology, is the Associate Professor in Department of Pathology at BJGMC Pune. Ma'am is in charge of hematology, histopathology labs for Sassoon General Hospitals with a professional experience of over 28 years. A huge thanks to ma'am for being here on such a short notice. I request Pallavi Sabre to please felicitate ma'am. Thank you. I now pass on the mic to Prachi for the topic and the rules.
Thank you, Shruti. Now, without further ado, let's have a look at our topic for today. Next exam, a curse or a boon for medical students. The next exam is a proposed examination for all medical students in India that is required to pass the final year and obtain a license to practice medicine. The pattern of the next exam is such that it has two parts. Next one, theory, and next two, practical. Next one is before internship, and its result is valid for 2 to 3 years. Next 2 is practical exam. Next 2 is after internship and is a pass-fail type exam. So the question remains, is the next exam a boon or a bane for medical students? Rules for the finale round are as follows. The finale round consists of 2 teams, one team speaking for the topic and the other team speaking against the topic. Each team consists of 4 speakers, 2 student speakers and 2 faculty speakers. The speakers for and against the topic will alternate with each other, with student speakers speaking first, followed by the faculty speakers. Each speaker has 3 minutes to present his or her either for or against the topic. A warning bell will be given at 2 minutes 30 seconds, followed by a final bell at the end of 3 minutes. After this, there will be a time period of 2 minutes for judges' questions, followed by 2 minutes for rebuttal, which would be done by the opposite team. A final bell at the end of 2 minutes will indicate the completion of the time period for rebuttal. After this, the next speaker would be called upon to speak. After the entire debate, there is a time of 10 minutes for a general rebuttal open for all participating members. All participants are requested to adhere to the time limits and uphold dignity and respect for each other's views. So let's begin our much awaited debate. Thank you.
So let's begin. So I invite Urbi Goswami to present her views.
Next, National Exit Test, a soon-to-be reality replacement of the existing NEET PG, INICT, MCI screening test will be a mandatory assessment examination for all medical graduates, both Indian and foreign. Thus establishing uniformity and reducing the dichotomy between graduates from different universities. To begin with, let us have a few particulars regarding this brainchild of NMC 2019. Next will comprise of 2 parts, theory, next 1, and practical, next 2. Theory will be an MCQ type and will be conducted after the final year MBBS. After passing next 1, the students will start their internship. Those who pass theory will have to clear next 2 separately at the end of internship, and which will be a pass-fail type of exam. The theory exam will have 60% problem-solving type question, 30% comprehension analysis type question, and only 10% recall type question, which clearly shows the great emphasis on the clinical aptitude of the examinee and judges how thorough the student is in profession as well as skill. Such qualitative learning will surely enhance the medical system and will give a healthy medical environment with quality doctors. As of now, or as we can say up until now, interns were engaged in preparing for NEET PG, more so in as gaining the theoretical knowledge. And with this stress, they hardly got any time to spare in giving quality care to the patients. However, with next, since internship will come after next 1, the interns can prepare efficiently for the theory exam, and then post-qualifying next 1 can peacefully engage in practice and provide the utmost clinical care and gain practical knowledge, which in turn will help them to ace next 2 and emerge as good clinicians. This new pattern will also eliminate unqualified and inexperienced doctors from practicing and will tend to limit the shortcuts that many of the aspirants have been adopting in the past years. Conceptual learning will replace the rote learning, and students will now have to focus more on the clinical application-based learning. And as goes the well-known saying, there are no shortcuts to success. Well, similarly, there is no use in becoming a doctor without strong fundamentals, good clinical aptitude, and an empathetic approach to healthcare practices. Thank you.
Questions?
Hello. You have presented your topic very nicely. You have covered the exam pattern and all this. But let me ask you, when the universities are there, all the medical colleges, they are affiliated to the universities. Why do you think the next is important? The theory practicals, theory and practical exams, they are also covered in the university. So what is your view about that?
So as we can see in the pattern which in which next is going to be conducted, they are keeping next one, which will be theory based, completely MCQ type. So it will be the exam wherein the competitive nature of our examination will be there. And that will create a uniformity in all kinds of universities. Like in case of our college or all the colleges in Maharashtra, they are affiliated to MUHS, which follow a different kind of study pattern, whereas there is AIMS, which follows a different kind of a pattern. Up until now, they used to take different exam named INICT, which had a different difficulty pattern. And so there was always a dichotomy between the students from various kinds of universities. As in, there used to be a discrimination that education in some universities is better than the others or is different from the others. And so I think with next, this dichotomy will be reduced. There will be a uniformity in the education of students. And with next two, there will be inclusion of the practical knowledge of a student. And so we'll get a better clinically oriented doctors in our healthcare system.
Okay, thank you.
Thank you.
So now is the time for the rebuttal. 2 minutes for each round. We have rebuttal for the speaker. Okay, ma'am. Okay. So then we'll move on to the next speaker, Ashish Simon.
Hello. Good afternoon. I'm Ashish Simon, and I shall speak on the topic next is surely a curse, a bane. Now, what is next? National Exit Test is an entrance exam. Now, why is the NMC making it into a licentiate exam? An entrance exam serves a different purpose, and a licentiate exam doesn't necessarily serve the same purpose. And that's the reason why we don't get admission into MBBS courses by 12th standard marks. The way we are taught in colleges and schools cater to a different need. They basically educate everyone up to a certain level so that everyone knows what they're supposed to know at that age. And entrance serves a bigger purpose. It is a choice for everyone whether or not to appear. An entrance test is a bit more knowledge than imparted in schools and colleges. Hence, there is a need for it to be standardized at the all India level. Just because we design a comprehensive exam doesn't mean we reap comprehensive learning. Testing the students clinically and determining their problem-solving skills cannot be just achieved by changing the status of an exam. We have to adopt a bottoms-up approach where we begin at the grassroots level and impact the learning over there. Secondly, in the earlier NEET pattern of 300 questions, section A was pre and paraclinical, out of which there were 150 questions on the 7 subjects. Now this integrated next exam, so-called, will have only 10% of 540 questions, that is 54 questions. Now my opponents will tell me quality over quantity. Hear me out and just let me tell you, answer me this. isn't an exam which asks about just 200 to 300 questions on all the 19 subjects, much more demanding than another which asks just 540 questions on 6 to 7 major subjects. Because in the 200 questions exam, you never know what is going to be asked from where. Hence, on what basis are my opponents telling that this exam is a comprehensive exam? It is just an illusion. Thirdly, you may argue that a 3-hour single exam shouldn't evaluate the preparation of a year. The pressure level gets too high and it gets to the candidates, they cannot perform well. Let me ask you, isn't this exam for doctors? Aren't they supposed to handle the pressure in do-or-die situations? Moreover, take the example of a football World Cup. Each player must perform their best in the given 90 plus or minus 5 minutes under pressure. They don't get 30 minutes extra just because it's a final. And my dear opponents, pressure is what makes coal into diamonds. Pressure is needed. Let me give you an example of a badminton match. One doesn't separate the sets of any match such that the players will be able to play only forehand shots in one set, backhand in the next set, and so on. Just one match. Play all that you know and win it. But does that mean that the winner is not worthy? No. Similarly, can we ever say that the 3-hour exam doesn't fully test the potential of a doctor? Never. I am sure that all the eminent doctors sitting on the stage right now are products of 3-hour exam, and I don't doubt them at all. Do you, my opponents? Therefore, the statement that a 3-hour exam cannot assess the quality of a doctor is absolutely false. To bring about next so as to solve the issue of the interns being able to focus on clinical work during internship is silly. Because if you bring about next, no one will pay attention to the 4 years in MBBS. 1 साल सवारने चले और 4 साल बर्बाद हो गए. In short, next is a farcical way to evaluate the clinical acumen of a doctor, and it will have long-standing repercussions. I'm sorry for exceeding the time. Thank you.
The judges' questions for this round.
So what do you mean? You know that NEET mainly it focuses on the assessment of cognitive domain. So skills, teaching, and attitude, communication, that is the overall neglected part. No?
Yes.
So can it not be? Can this? Will it not give justice to that?
Yes, ma'am. You are very right, but we are missing out one thing. The practical aspect. I assume that you're talking about the practical aspect, right?
Yeah.
According to the NMC, the next that phase is going to be tested by the university and colleges itself. So where are we bringing in the uniformity? Even then in fourth year exams, final exams, all of this, the attitude and everything is tested in the case presentations and everything. So when we already have the universities which are so competent, in testing everything, why do we need another uniform board to test everything when we have enough teachers to test that right now?
So even when it is now assessed, you are saying that it is being assessed. Are you there in wards? We don't see any students in ward for clinical learning. Okay. We have 24-hour round duty, and in ED ward, there is no one. You are supposed to be there. So I think that is the lacune in the current system.
Yes, ma'am.
Students are not learning and they are not being assessed for clinical skills.
Yes, ma'am.
And including communication skills also.
I think I would just like to add one more thing. What you said is very right, and I agree to all of that. So instead of changing the whole pattern, just add another exam which is a short exam and doesn't change everything so much. Ye license bhi saath mein, PG bhi saath mein, fourth year ke end mein. That is too much of a change. And as a third minor student right now, let me tell you, koi itna bada exam change karega, and just we are not even sure about it. Only 1 year left now. 1 year from today, we have to appear for the exam. Do you think it's fair? I don't think it's fair. I can't ask you as a judge right now.
Okay, you are good. Anyway.
Thank you.
Thank you. Now I call upon Sahiba Manyar, Dr. Sahiba Manyar, to put forth her views.
A brand new stethoscope around his neck. He's clinched a PG seat, they say. Baffled by the patients, his clinical skills are absolutely astray. A story far and wide in colleges all across. Is there any solution for this system's gross? Yes, my friends, there is. And the answer is next. Hence, I, Sahiba Manyar, firmly support the advent of next in today's system. The next exam is a two-step standardized medical licensing exam, assessing, most importantly, the clinical skills of a medical graduate, which is missing in today's NEET exam. This comes as an answer to the rote-learned culture that exists in the 3-hour NEET exam, like my opponent mentioned. It also puts an end to the incompetent internship escapism culture that is practiced in innumerable colleges to ensure their students clinch a NEET PG seat eventually. India today has 558 medical colleges, discrepancied as government, private, and deemed to be universities. While the admissions to government colleges are regularized, there is an enormous culture of seat blocking that still continues to exist in private and deemed to be universities. Unfortunately, the situation is worse in deemed universities, where the government cannot regularize even the final examinations of these students who have in-house examinations, as we can say. Honestly, there is no belittling the credibility of any medical graduate or any institute. We respect them all. However, in a country where differences are so far and wide, there is a need to have some uniformity in the gods, as we mentioned. Additionally, every single year, thousands of Indian students graduate from government institutes of Russia, China, Ukraine, Philippines, trying to come here and contribute to the country they belong to. However, their licensing exam is considered to be the most difficult licensing exam, with a pass rate of only 16%. 84% of them add to the backlog. In India, let me tell you everyone, the doctor-patient ratio is only 1.24 to 1,000. Do you think we can afford to lose this mighty number of medical graduates who could help us ensure that we provide some relief to our patients? There is a need to provide them a standard and uniform chance. With 5.2 million deaths due to medical error, there is a need and high time we provide highly qualified and quality doctors in the country. As I stand here in the most premier medical institute, let me ask you all sitting here, who I'm sure are all against me. Who are you? Who do you think you're going to be? Well, we're all going to be someone's hope someday. We're going to give someone a life. We're going to save a family. I really don't think your white coat shall fear any advent of an extra skill that they want to measure from you. Thank you so much.
Thank you for putting your views.
Sorry, sir.
Okay, not an issue, not an issue. Take your own time. As you have said, government and private colleges, deemed universities are there. Do you think the separate exam should be there for deemed universities and private only? For government students, it should not be there?
So unfortunately, the system that we have today is very erratic with a lot of loopholes. At least a system that is measuring the clinical aspects of knowledge, whether you talk about government, private, or deemed to be, it is giving everyone a uniform opportunity and creating a standardization.
Uniformity will not be there at all. But my question is, if you are saying uniformity should be there, just by next exam, it should not be there. So as you said, in few cases, government doctors are there, the students they are doing in the government hospitals or government medical colleges, private medical colleges, deemed universities, and those who are coming from outsides.
Right.
So do you think the separate exam should be there for all these categories?
Absolutely, sir, because the next exam is not only a uniformity exam, it is also assessing your clinical skills. It is not like my opponent very, very nicely mentioned. It is assessing everything that you have learned from your grassroots level. It is assessing everything that you have amalgamated over 4.5 years. It is not an overnight process. You cannot go and give 540 marks or 540 questions by learning, by a 1 year learning. It is something you develop, an amalgamation of all the knowledge that you collect in 4.5 years, whether in the library or whether in the ward. None of it can be given way to.
Okay, thank you.
Thank you, sir.
One more question, please. How this next will affect the internship?
Ma'am, unfortunately, like I mentioned, there are innumerable stories of colleges actually encouraging internship escapism, whether monetary or whether in kind. However, when we are talking about measuring a clinical skill of a student after the internship, a student is going to be more dedicated to his time in the wards. It is not like the skills you develop in internship are mainly practical, which is not the same you develop in your second, third, and final year wards that we visit. Internship is the main year for practical. And if you are not going to pay attention in your internship, there is no way you're ever going to pass your next two. Thank you.
Thank you. Now I call upon Khyati Hambardikar to put forth her views.
Next exam sounds more like my next panic attack, frankly. Good afternoon. I, Khyati Hambardikar from VDGMC Latur, will be speaking against the implementation of this disorganized next exam. Why does our government always have to take a 360-degree turn when it comes to medical entrance exams? Let it be next, let it be NEET UG, NEET PG, MHCT, AIPMT, all the time, it's only medical entrance exam. Next is not only a haphazardly organized exam, but it is also an unnecessary exam, according to my point of view. NMC Bill 2019 was passed and implemented next exam in 2023 without declaring the official pattern of the exam, which led to a lot of anxiety in the medical students. I'm talking from my personal experience being a third minor student. They expect us to study for the final year university exam along with next, which comprises the entire syllabus of MBBS. Both these exams have completely different pattern and structure. Is this fair or even possible? Medical students in India face a lot of competition in the NEET UG. They are the bright minds of the country, but they are excessively pressurized by this organization, by the system, they have to keep proving their worth every now and then by exams like next and the always recurring changes occurring in our pattern of exams. Internships, they provide better understanding of which specialty we need to pursue in the future. If next asks us to lock our ranks and scores before our internship, how do you expect us to make the right choice? This will take a toll on the mental capability of that student and the future medical services that that student will provide. Next also asks us to reattempt the exam if we do not obtain the required score. But all of this without an undergraduate medical degree, it takes a toll on the mental status as well as the financial status of the student. Doesn't this scenario sound a little bit similar to you? This is exactly what happens when we are giving our 12th board exams as well as NEET UG. We are always focusing on the entrance exams, but we are simultaneously stressing upon just passing in our board exams. Instead of implementing next, I would suggest we create such an internship program which has good quality, which makes students come out and attend these internships, improve the attendance. We can also include clinical scenario-based questions in NEET PG to assess the clinical skills of the student after the completion of internship. Lastly, I would like to state that we are still a developing country and we require a large number of doctors to be practicing. Next will only be prolonging this undergraduate period.
Your time's up.
Okay, thank you.
It's time for the judges' questions.
So you are saying we are still developing in the we are developing nation, right? So don't you think that our degree should be at par globally with other degrees of other developed countries? So will next not help for that?
Yes, ma'am, I completely agree with you that we need to stand.
Because at present, what happens? This university is different. This is different. So will next bring that MBBS graduate at par with the graduate from other developed countries? So what is your view about this?
Ma'am, I feel that we as Indians, I would totally agree that the Indian medical system is actually very well structured. We give really rigorous exams, competitive exams. And my only opinion is that we do not need another completely new pattern of an exam. We can improve what we already have. Next, NEET PG is an exam which we can develop. Already clinical based scenario questions are coming up, which can be added as the comprehensive questions, which they keep talking about in the next. So I think we already have what we're already doing very well. It's just that we need to improve on what we already have, not implement something completely different and terrorizing the students who are already in the medical stream. Implementing this such a last minute takes a toll on the mental health of every medical graduate in the country.
Do you think it is totally different? It is based on your syllabus only, all the 4 phases.
Yes, ma'am.
So
But
will it not help for that preparation? Will it not help to clear next?
Ma'am, when we sit to revise the entire syllabus of next, it takes quite a lot of time. If our final year university exams are and next only has a few months in the middle, it's not very possible for anybody to prepare that rigorously for a competitive exam and to crack that exam to gain the seat which they want. If they want a good AIR, you need good competitive skills. You need a good rigorous curriculum that you have prepared. You won't be able to get that, and that's it.
Okay.
Thank you.
Thank you. Now I call upon Dr. Sharad Agrakhelkar sir to put forth his views on the topic.
Good afternoon. Good afternoon, students. Good afternoon, judges. And good afternoon, my opponents. I am here to, after 42 long years in this college, in this auditorium, in 1977, when I passed out of this college, and I was lecturer here till 82, but then this is the first opportunity to participate in the debate in our college. Thank you very much for that. I'm here to talk in the favor of the motion. Is the next exam a boon? I feel it is a boon. As my student friends have already elaborated on these points, we people do have inertia. We are resist anything that is going to change. Now, why this change has come? See, MCI has gone and NMC has come. We know what was that foreign medical graduates examination was happening in Delhi, where somebody else can appear on behalf of you and clear the exam, and people are paying huge sum of money to get through that exam. Is that what we want? That's not the idea. So that's why we need to have the uniformity. As sir has said that there should be separate exam for government colleges and separate exam for private colleges. BJ Medical is an exception. Is that standard there available in Yavatmal and newer colleges? Because the teachers have been sent on loan, and that teachers are not there, going to be there permanently. So how they are going to commit themselves to training the students in proper way? So the idea of next is to have the transparency. Transparency is the most important thing that we need in our examination. Otherwise, foreign medical graduate exam was going on for many years, and people used to appear 2-3 times. Ultimately, they used to go through the back door and get clearance. Regarding the uniform standards, I am teaching in a private medical college, a deemed university, and I get students from all over India. And I can see the difference in their basic understanding. What you all students say, BMR, basic mein RADA. So if such material is coming to us, and then we need to make them good graduates and good qualified doctors, then it is very, very late for us. So we need to have the uniformity in the assessment method. Somebody said that during internship, you can acquire the skills. My dear friend, that's too late. We learned our skills when we used to visit the ward in our second MBBS. What you people are doing in second MBBS, you are attending JAS classes and learning some various courses, and you are not attentive enough in your clinical posting. So that's my point. Clinical teaching is lacking. We need to upgrade our clinical skills.
Thank you, sir. Now I call upon Dr. Manish Machwe, sir, to put
Rebuttal.
Judge's question.
So is it required for the faculties? My question is, the competitors are only students here. So whether I should ask?
You can, sir. You can. We are open.
Sir, you work in both government as well as in private as well as university. You said it is next exam is required, right? So is there any other way out without conducting exam? See, we have seen the change. Initially, we don't have the entrance exam for PG also. Now the students, they are preparing for the PG exam. So what change we have observed? Even from the second year, the students, they used to start for the exams, DAMs and all this. So Saturday, Sunday, you will not get any students in the campus.
Yes, sir.
Right.
That's same is our experience.
Right. So as you are saying, you are for the exam. My question is, the exam should not be there. What do you feel?
That will be happening only when we implement CBME. And we implement so skills. Skill labs are mandatory for all the medical colleges.
Yeah, sure.
And if we train them on the mannequins, then they will acquire the skills. I get a student who is now going to appear for MD exam. He is very good at theory, but he is not able to intubate and he is not able to get IV access. I said a pediatrician without intubation and in IV cannula is useless. Is like a barber without a razor. So that is the standard. We need to bring them at par with others. That's what is required.
Yeah.
Sir.
Thank you. Thank you, sir.
Respected. Okay, give me 30 seconds before I start. Okay, Hindi, English, Marathi, Khichadi. आई शपथ मजा आली. All right, Sanmaniya Vyaspeeth, respected judges, teachers, and dear friends. When we started, there was a sentence written there, and my senior Dr. Kulkarni madam pointed out. It read that to respect the dignity of other people's views. So it is only respecting their views and nothing else. Now, what I thought was, I had a dilemma. बीजे मेडिकल कॉलेज मध्ये जिथे आम्ही जन्माला आलो आणि सगळं आजपर्यंत लाईफ मध्ये जे काय मिळवलंय याच्यामुळे मिळवलंय, हिथे उभं राहून रिस्पेक्ट करू का खरं बोलू? लगेच लक्षात आलं रिस्पेक्टची PR. सो एनिवे, जे बोलीन खरं सोडून काही नाही बोलणार. आणि तुम्ही आतापर्यंत जे टेक्निकल ऐकलंय, मी टेक्निकल बोलणार नाही, मी फक्त इमोशनल आणि हॉर्मोनल बोलणार आहे. फॉर 2 reasons. की आता एक्झाम देऊन फर्स्ट MBBS, सेकंड MBBS, थर्ड MBBS, आता नेक्स्ट एक्झाम, त्यानंतर अजून एक नेक्स्ट एक्झाम, लिटरली आता तर कॅटरीना कैफचंही लग्न झालं. तुम्ही काय करणार? वी नाव हॅव UG people and it is about UG. So we now have UGs who have empty gonads. It's called empty gonad syndrome because there are no OA and there are no sperms left there exam देऊन. कारण एक्झामच्या वेळेस आपल्याला कपाळाच्या वर काय दिसतात तुम्हाला माहिती. Anyway, so the point is I am going to speak emotionally to you, and for the first time in my life I have been speaking in staff debate for so many years. My wife is sitting here, so खोटं तर बोलू शकत नाही because same batch. So whatever I speak, you can verify from her. See, MBBS undergraduate, system, because of your internal exams and so many type of exam, is already flooded with so many tests. It was not earlier times when जेव्हा आम्ही अभ्यास करत होतो 1.5 वर्षांनी एकच युनिव्हर्सिटीची एक्झाम यायची. आता असं तुम्हाला नाहीये. तुम्हाला ऑलरेडी इंटरनल एक्झाम्स असतात, प्रॅक्टिकल असतात, क्लिनिकल बेस्ड सिनारिओ, सिच्युएशन बेस्ड सिनारिओ सगळं ऑलरेडी असतं. आणि मला सांगा, MCQ बेस्ड कुठलीही एक्झाम, आता फॉर एक्झाम्पल तुम्हाला सपोज एक क्वेश्चन आहे, हाऊ डू यू मॅनेज मायोकार्डियल इन्फेक्शन और हाऊ डू यू मॅनेज ऑर्गॅनोफॉस्फरस पॉइझनिंग, याच्यामध्ये MCQ कसं घोषवणार तुम्ही? यू हॅव टू डिस्क्राईब द एंटायर मॅनेजमेंट. इट हॅज टू बी डिस्क्रिप्टिव्ह. Descriptiveness is the pattern of exams that we follow, and it is necessary. Life काय MCQ नाहीये. लाईफ जसं तुमच्याकडे आता फॉर एक्झाम्पल तुम्ही यंग तरुण मुलं मुली जेव्हा तुम्ही बघता एकमेकांकडे इथे आल्यावर, बीजेला तर बघतच असाल, डिप्लो को काय, अरे थांब ना भाऊ, तुझ्या कामाचं बोलतोय, तुला संध्याकाळी बरं वाटेल. लाईफ इज नॉट MCQ. लाईफ इज फर्स्ट वन लाईन आन्सर क्वेश्चन जेव्हा आपण बघतो, मग त्याची शॉर्ट नोट होते, आपण कॅन्टीन मध्ये घेऊन जातो, मग लॉंग आन्सर क्वेश्चन होता आपण पिकनिकला किंवा तुम्ही आता अजून कुठे घेऊन जात असाल, आणि फायनली रिझल्ट लागतो जेव्हा तुम्ही घरी घेऊन जाता. काय ते तुम्ही ठरवा, पण इट हॅज टू बी सब्जेक्टिव्ह. देअर कॅनॉट बी ऑब्जेक्टिव्ह एक्झाम. नेक्स्ट पॉइंट इज अबाउट इंटर्नशिप. मी बोलूनच संपणार आहे भाऊ, जे एवढं लिहून आणले तर. नेक्स्ट पॉइंट इज इंटर्नशिप. सी, द होल आयडिया ऑफ इंटर्नशिप इज लॉस्ट. कारण तुम्ही इंटर्नशिप मध्ये अभ्यास करत बसता. माझ्या बायकोला इंटर्नशिपलाच पटवलं राव मी. जमलं असतं का असं नेक्स्ट आणि अभ्यास करत बसलो असतो तर किती, म्हणजे इट्स नॉट इझी मुलांना आणि मुलींना सुद्धा. इट इज नॉट इझी. वधूवर सूचक मंडळामध्ये डॉक्टर मुलांना आणि मुलींना वर किंवा वधू मिळत नाही. त्यामुळे तुम्हाला जो काय स्कोप आहे तो आत्ताच आहे. नंतर एकटं राहायची वेळ येईल, लक्षात ठेवा. आणि नंतर याच्यासाठी वेगळे कोचिंग क्लासेस सुरू होतील. आणखीन पैसे खर्च करा. कालच मी ऐकलं आता नेक्स्ट कोचिंग क्लासेसचे पैसे आणखीन जास्त असणार आहे. अवघडच आहे. ऑलरेडी जसं आमच्या लोकांनी सांगितलं, तुम्हाला व्यवस्थित चांगल्या शब्दात समजून सांगितलं, इंग्लिश जे तुम्हाला कळतं मी तेच मराठीत सांगतोय. ऑलरेडी रेग्युलर एक्झाम्स आहे, रेग्युलर असेसमेंट आहे. चला, आम्ही सब्जेक्टिव्ह एक्झाम लिहून काय माझं झट वाकडं झालंय लाईफमध्ये, काय वाकडं झालंय. एनीबडी कॅन कम अँड सी, वॉच माय सर्जरीज, come and see, be with me throughout 24 hours, nothing went wrong. मग का तुम्हाला ते MCQच्या भानगडीत आणि आणखीन एक टेस्टच्या भानगडीत पडायचं मला माहित नाही. आणि सपोज असं गृहीत धरा की somebody who's good in first MBBS, good in second MBBS, good in third MBBS, he or she does not just perform once in that next exam, पुढचं सगळं आयुष्य वाटच लागली ना. मग एवढा चांगला स्टुडंट असून एक एक्झाम खराब गेली म्हणजे हे परफॉर्मन्स एन्झायटी. संध्याकाळी सगळे गुगलवर टाका परफॉर्मन्स एन्झायटी. टीचर्सला कळलेलं आहे त्यामुळे सर जोरात हसतायत. ज्यांना नाही कळलं त्यांनी गुगलवर टाका. आणि मग काय होणार, तुम्हाला तुमचे टीचर्स पण वर्गात येऊ MCQ बद्दलच बोलतील. आज कुठल्या 4 धड्यांपैकी काय शिकू, त्याच्यातलं काय. सो इवन द टीचिंग इन मेडिकल कॉलेजेस विल बिकम MCQ बेस्ड, विच फॉर्च्युनेटली कॅन नॉट बिकम MCQ बेस्ड. कारण शेवटी आपण काय कॉम्प्युटर इंजिनिअरिंगची किंवा CA ची किंवा दुसरी अशी काही एक्झाम देत नाही. आपण डॉक्टर होणार आहे, MBBS होणार आहे. सो आपल्या करिक्युलम मध्ये हे पाहिजेच. तर मी पण तुम्हाला भरपूर काय बोलू शकतो. मला माहित होतं इथे येऊन बेल वाजवायच्या आधी एकच गोष्ट सांगतो. आपण सगळ्यांनी 3 इडियट्स बघितलंय. रणछोडदास छानछडने आपल्याला त्यात व्हेरी क्लिअरली व्हॉट डिड ही से, काबिल बनो, कामयाबी झक मार के पीछे आएगी. एव्हरीवन रिमेंबर्स. हे असे एक्झाम येत गेले ना तर काबिल जाऊ दे, कबाड होईल तुमचा. लक्षात ठेवा. मी अजूनही सांगतो, मी परत इमोशनली आणि हॉर्मोनलीच बोलणार आहे. तुम्हाला तुमचं आयुष्य सेट चांगलं करायचं असेल, इंटर्नशिप सारखा वेळ, UG PG चांगलं करायचं असेल तर हे नेक्स्ट आणि ही कटकट आपल्याला नकोय. थँक्यू सो मच.
सर, थोडं का होईना आपल्या जुन्या डिबेटची आठवण आली. या मुलांनी ते तर सगळं मिस केलेलं आहे, म्हणजे त्यांना माहिती.
मी आता तुम्हालाही रिक्वेस्ट करतो आणि मॅडमला रिक्वेस्ट केली, एकदा तसले डिबेट करा परत. नाही, एक चांगली गोष्ट आहे की तुम्ही आता डिबेटचे टॉपिक अकॅडमिक, आम्ही पण अकॅडमिक टॉपिक्स वरच डिबेट करायचो. शुड अ डॉक्टर मॅरी अनदर डॉक्टर, एकदम अकॅडमिक टॉपिक आहे. सिल्क फॅक्टर इन इंटरव्ह्यूज म्हणजे सेक्स इन्फ्लुएन्स लक नॉलेज, एक अतिशय अकॅडमिक आहे. फक्त एक्झाम बद्दल बोलायचो आम्ही. सो आता मी तो सिल्क फॅक्टर इन इंटरव्ह्यूज असं करून आम्ही बोलायला आलो होतो. त्यातल्या एका स्पीकरला वाटलं की सिल्क फॅक्टर इन इंटरकोर्स आहे वगैरे. सो आम्ही पण अकॅडमिकच करायचो, फक्त तुम्ही खूप अकॅडमिक झाले.
सर तुम्हाला असं वाटत नाही का जे सब्जेक्टिव्हिटी तुम्ही जे बोलताय ना, तर आपल्या जनरेशन मध्ये मग ऑर्थोपेडिशियनचा मुलगा ऑर्थोपेडिशियनच होणार, त्याच्यासाठी ते सीट रिझर्व, ते अशा गोष्टी व्हायच्या तेव्हा, ते कुठेतरी कटशॉट झालंय का?
नाही होत मॅडम. माझे वडील पॅथॉलॉजिस्ट होते, मी गायनेकोलॉजिस्ट आहे. माझ्या बायकोचे वडील गायनेकोलॉजिस्ट होते, ती ऑफ्थॅल्मॉलॉजिस्ट.
तर तुम्ही एक्सेप्शन आहात, पण
मी तुम्हाला अजून 200 एक्झाम्पल्स देऊ शकतो मॅडम. सो इट इज नॉट दॅट, द होल कन्सेप्ट इज दॅट ऑलरेडी, आणि आपल्या वेळेपेक्षा पण द एज्युकेशन सिस्टम हॅज नाव बिकम केस बेस्ड. आता तुम्हाला फर्स्ट इयर पासून केस बेस्ड प्रॉब्लेम असतात, अॅनॅटला असतात, फिजिओला तुम्ही केस बेस्ड प्रॉब्लेम देता. सो ऑलरेडी ती ऑल दॅट इज बीन इनकॉर्पोरेटेड इन द करिक्युलम. छोट्या छोट्या एक्झाम्स असतात. सो एकदम 1.5 वर्षांनी एक एक्झाम येत नाही. सो ऑलरेडी सगळ्यांचं सगळं टेस्ट होतंय. आणखीन नवीन एक्झाम देऊन इट्स टू मच ऑफ अ बर्डन आय थिंक. अँड इंटर्नशिप डोंट वेस्ट इट. आय एम अगेन टेलिंग यू, वधूवर सूचक मध्ये तुम्हाला कोणी मिळणार नाही. जे करायचं आत्ताच करा, इथेच करा.
तुम्ही जेव्हा स्टेजवर येणार ना, तेव्हाच आम्हाला माहित होतं की तुम्ही धमाका करणार आहेत. पण पहिली तुमची जी ऍक्शन होती सर, तुम्ही तिथून बेल उचलली, म्हणजे तुम्हाला युनिफॉर्मिटी नको असं लक्षात येते त्याच्यामुळे. या लोकांना जे आहेत त्यांना टाइम लिमिट होती, तुम्हाला टाइम लिमिट नको असं त्याचा अर्थ होतो.
सर यू आर राईट, बिकॉज ते लोक कॉम्पिट करताय प्राइस साठी, आम्ही कॉम्पिट करतोय खरं बोलण्यासाठी. आणि जो माणूस खरं बोलतो, म्हणून मी तुम्हाला म्हटलं की माझा जन्म बीजेला झाला, मी वाढलो, आज मी या स्टेजवर बोलून उभं राहून खोटं बोलू शकत नाही.
नाही, तुम्ही म्हणताय ते बरोबर आहे सर. दुसरे ठीक आहे, थँक्यू सर.
थँक्यू सो मच. येस मॅम.
सर मी तुम्हाला काही विचारत नाहीये, पण मला असं ओपिनियन तुमचं घ्यायचंय. जर नेक्स्ट नकोच आहे तर मग नीट तरी कशाला हवी? मग त्याच्यात पण मुलं 3-3, 4-4 वर्ष स्पेंड करतात सर.
करेक्ट.
देन दॅट इज ऑल्सो इमोशनल अँड हॉर्मोनल अकॉर्डिंग टू यू.
येस, अकॉर्डिंग टू मी. यू आस्क मी इव्हन नीट पीजी काय झालं? नीट पीजी होऊन कुठे ऍडमिशन झाले? मग पूर्वीची सिस्टीम चांगली होती, तुम्ही अभ्यास करा, मार्क मिळवा आणि तुम्हाला पीजीला. ती सिस्टीम चांगली होती. आता नीटची एक्झाम मागच्या वर्षीपासून झालेली आहे. लोक डॉक्टर्स अरेस्ट होत आहेत, सुप्रीम कोर्ट केसेस चालू आहे. काय फायदा काय झाला? असं आमच्या वेळेस तर आम्ही आमच्या वेळेस पण स्ट्राईक करायचो, डेक्कन क्वीन अडवायचो, पण चांगल्या गोष्टींसाठी, पेशंटला पैसे मिळावे यासाठी. गव्हर्नमेंटमध्ये कोणी पैसे खाऊ नये, आपल्या पेशंटसाठी चांगला व्हावं, किंवा एखाद्या डॉक्टरला मारलं. आता तर तुम्ही डॉक्टरांना मारूनच आत ठुसताय. काय करू शकतो? हे नीटचे परिणाम आहे बघा मॅडम. सो यू आर राईट, ती पण एक्झाम नकोय. थँक्यू सो मच.
Thank you, sir. Now I call upon Dr. Kalpana Kulkarni ma'am to. So I'm so sorry. Now I call upon Dr. Kishore Gujar sir to put forth.
थँक्यू मनीष. टेम्पर वेगळा नेला, वेगळ्या लेवलवर डिबेट नेलं. आय विल डिस्कस ऑन फॉर द मोशन. I started reading after somebody called me, organizer called me, and are you going to take a part in this debate? Then subsequently I started gathering the information, what is exactly next. And I found it's a big milestone to improve medical education and produce talented doctors, which will help society at large. And it is mandated by NMC Commission Bill 2019. Even we debate, we have to follow it. It's a law of land. It's a progressive and very bold decision, creating single window for medical education, license for practice, and secure admission for post-graduation. That will create equal education throughout country. All colleges are supposed to provide standard education and enhance their education level. And overall, somebody mentioned earlier, overall enhancement of medical education to follow same education standard culture as developed country has. It will definitely create a healthy competition. It one nation, one exam. That is best idea I would consider. It will definitely provide best and confident doctors to the nation, because they will have a better understanding of the how to manage a clinical setup, patient in a clinical setup, and how to identify and manage them. It will definitely filter the unqualified student, and it will help foreign student also to appear with the single window. There won't be much hassles. Simultaneously, it will be problem solving, comprehension, analysis, recall very less importance has been given, and that is the right one. But additional applied basics has been included. So all subjects will be come in this examination, and preventing public health are also given a 10% importance. That is very good idea. Preventive mental, not necessarily mental, physical health is very much important, and that will be most rewarded on medical, further medical development and research. It will definitely sharpen the basics like problem solving, understanding, and people, student have to focus on the fundamentals of the problems instead of just mugging it and recalling it and producing it. Critical concept, special attention to practical skill will be given. Then module will encourage creative and analytic thinking process, problem solving, which will essential in day-to-day medical practice, because most of the patients do not present with the typical diagnosis, or management is very complex. That's why if they get the clinical skill and appropriate understanding with fundamental knowledge, that will help a student. And at the end, I will say, honest, sincere student who are diligent towards a medical profession did not worry, will be enormously benefited by this next. Oh, thank you.
So thank you very much. Sir, I am from forensic basically. We have most of the time seen so many students, they are committing suicide after 12th exam, after MBBS. Recently, there is a news that in the IIT and IIM, so many students, they have committed suicide. Do you feel, being a psychiatrist, exam should be there basically because the anxiety is there for the exams?
Okay.
Because many times assessment, the other way around, many times they said rather than taking the exam, assessment can be carried out on day-to-day basis, and the progress of the students can be assessed.
There are two objections for this, because huge number of medical students appearing all over the India, it's very difficult and quantify it and standardize it. You asked me first question, that is exam related phobia and culminating in a suicide. That is related to societal standard, because of societies to giving a too much pressure on academic achievement than academic understanding. Exam orientation is too much given, because of which students become phobic of the exam, and chances of committing suicide, anticipated failure or actual failure. For that, overall community change has to be there, as like a Western country where there is no pressure of the exam. There is no suicide in response to the examination or results. We have to change the society at a large. That is what my suggestion will be.
Hello. Hello, sir. Sir, I want your opinion. According to me, more the exams, more will be the private coaching classes. So for the classes will be for next one, classes will be there. For next two, again, the classes will be there for. So I just want your opinion regarding these private coaching classes and the next.
Okay, that's a totally different topic, but simultaneously, I would consider classes for the 12th examination, classes for the MBBS entrance, classes for PG entrance. This focus is a little different. Here, next exam, anyway, NET will be replaced by next one. But what will be the next two will be more practical. Otherwise, internship is nobody taking it seriously. Even a student who get the qualification of MBBS level do not have an idea how to understand and administer therapy for a diarrhea also, simple presentation. And that definitely will help with this next two examination.
Thank you, sir. I now request Dr. Kalpana Kulkarni ma'am to present her views.
I'd like to thank my teammates and my opponents as well. They have said a lot for me. So my job is very easy over here. Next, NEET. These two things were discussed. Manish is not aware of anything. Manish, debate topic हा NEET आहे का नाही हा नाही अरे. Next चा चाललाय. त्यामुळे NEET चं कशाला मध्येच घेतो. But on the same line, I will like to say की ते कोणी गोविंद घ्या कोणी गोपाळ घ्या त्याला नीट म्हणा नाही तर नेक्स्ट म्हणा ती एकच परीक्षा घ्या ना. नीट मध्ये तुम्ही आता घालताय ना ते प्रॉब्लेम बेस्ड 60%, 30%, 10%, MCQ based, only 10% recall. That is what she said, and I got it from her. So you are doing that job. Yes, change the timing because you are thinking kids are not working in or not learning their skills in internship. Change the timing, take it before internship. Why to have another exam called next? And in that, part 2 next will be practical. Students, you are not aware. Now it is 250 batch. For us teachers, arranging practical exams for 250 students is a big headache. Are we doing that real? That is what CBME pattern and all. We are trying to do real skill assessment, which is not happening at minute. That is the reason they have put many formative exams in between throughout the year, assess them throughout the year. Then you are making mockery of that assess throughout the year, assess throughout the course. If you are going to assess them again at the end, and because they have to be on the same level. Sir, you have said very well that BMR, basic mein hi rada hai. Because you said many new government colleges are starting and there is no staff available. There are many, it is the fact. There are many private colleges, there are no patients for them to see. Sir, basic mein hi rada hai. You are not having uniform education system. How you can demand for uniform exam or assessment system? It is not good for them. So, change that basic mein rada na, sir. Change that, provide that education. Sir, you said we have to have uniform education. We are not talking over here about uniform education. We are talking, unfortunately, about uniform assessment. When there is so much of diversity, how you can assess them on one level, sir? What we are doing is right. We are going towards our aim that we have to have good doctors. They have to have good communication skill. Introduce communication skill. We have done that. Introduce formative assessment. We have done that. One more thing, sir. We are saying have that practical exam. Who is going to conduct that practical exam? The same examiners who has done that before. You have to reduce that clap timing from mine. The last point I will like to say, on one side, sir, this whole team said there has to be uniformity, all should be equal, good doctors should be produced. This is on one side. What is there on the other side? There is bridge course. Take admission for homeopath, take admission for Ayurveda, do your MD, do that bridge course and come in mainstream. So why? Why this uniformity for only for MBBS student? Why not for everybody? Then have next for everybody, MBBS, homeopath, Ayurveda, Unani, and then only they will be licensed for the practice. Sorry. Sir, तुम्ही तर आमच्या बाजूच आहेत असं आम्ही आता कन्क्लुजन काढलं.
No. Considering the response, you might think, right? No, as you said, there is no uniformity, right? And for that NMC, there are a certain high-class people, they are sitting and they have suggested, there is advisory group to the NMC. They have suggested this NMC exam should be there, the next exam should be there. Then why they thought on that line? If
I couldn't get you, sir.
See, NMC bill has passed. Direct NMC has not directly introduced this next exam. There is certain research which was carried out all over the India, and the research group, they have suggested the NMC to do next exam so that each and everyone should be at par.
Yes, sir.
Right. Then why do you think the next exam should not be there? It will not help.
Sir, research, it is the meaning itself, sir. You have to research it. They will find it out that next is of no use. NEET was better. So it will occur, sir. They will realize it after some days, after the problems they will face. Because taking practical exams, sir, 250 students, we are really, I mean, first year, they are really tired of taking. We have to do that yet. And I think PG exam 1.5 lakh or 2 lakhs, that is the figure she shared with me. 2 lakh students are appearing for the NEET exams. Next NEET, they are appearing now. We assume 50% passed. Still, sir, more than 50,000 students exam at a time practical. Who is going to conduct? We have objection for that, sir. You change the name to next. We
NMC
don't
will
mind.
find out the solution for that. But question is whether the next exam should be there or not. So NMC, if they have decided to conduct the exam, they might have thought on some different line. Whether you want to change that.
Yes, sir. That is the reason there should be more and more debate. There should be more thinking, brainstorming should be done. And really it is going to work. And as I said, I am strongly from that point of view, sir. There has to be increase in the infrastructure and undergraduate student, more of formative assessment, more of skill assessment at that level.
Thank you. Thank you, ma'am.
Am I permitted to move? Thank you.
Thank you, ma'am. We will now move on to the open rebuttal round. So there are a total of 10 minutes that are given for the open rebuttal round, in which the opposing teams can ask questions to each other. We'd request one person to ask a question at one time and let the answers be precise and to the point. So who would like to go first? Urbi.
Hello. Thank you. So my first question is for Khyati. You said to improve the internship facility which is being provided, improve it. How do you say we should improve it? You noted 2 points: improve the quality, improve the attendance. How to improve the attendance? Today we, the organizers, we shed our blood, tears, sweats, everything to get an attendance of audience to attend the lectures in the morning. We have postings. I am from CBME curriculum. In my batch, we have 20 posted students. Only 3 people attend the postings in a day. 3 people running every day to psychiatry, people not going to psychiatry. It's a boring subject. How do you think that we'll get the attendance?
Yes, thank you for the question. I'd like to answer this by saying that I am a student, but I would love to go to the clinical postings. I have tried, I have pushed in my college itself. Nobody is there to give us that knowledge. Everybody, every day we go there. The only thing they say, aaj nahi. Residents will tell us, aaj nahi. Professors will not be there. So this is how it works. If you grab our attention, we will definitely come over there. We want to come there. We have taken admission into this medical college for a reason. We want to come, but if you provide us that knowledge, we will definitely come. If we are thrown away for a week continuously, what are you testing?
If during a tibial intermedullary approximation surgery, if a resident is explaining me how each and every rod or screw is being inserted along with the X-ray shoots, if that is not interesting, then I highly doubt what is.
This is your personal experience. I am talking about 95% of the cases. You might be talking about 5% of the cases. After going again and again at the doorstep of every OPD and every surgeries, only after that they will explain us something maybe. But this is not how it should work, right? It should be a two-way street. We are coming, you also give us something. No offense.
Adding to that, don't you think if there is some answerability that the university has in order to make you prepared for something as big as the next exam, which is putting their reputation also at stake? The teachers who you mentioned are not coming, the residents who are not coming. Don't you think they have a certain responsibility towards you, and it would improve even their aspect when they are coming to you? There would be a better treatment that you get in your wards as well.
I think you're deviating from the topic, but
No, I am not.
Yes, you are.
Yes,
No,
ma'am.
I am not. All I am saying is you mentioned that the teachers who take so much pain to sit here next to you today do not attend a posting that they have so much of condition to teach. You mentioned that. So
Yeah.
all I am saying is, don't you think a next exam puts their reputation at stake as well?
How
And
will?
it would get a greater answer. There is, the university has a greater pass percent if they give you a better teaching.
Excuse me, see, there is no, my main point is there should be a difference between next and NEET. Okay. So how are you saying that in next there is the university is accountable or the college is accountable? Even in NEET PG, if a student cracks NEET PG, gets a good rank, नाम तो कॉलेज का ही होने वाला है.
Definitely, नाम
NEET
तो कॉलेज
PG
का ही
होगा,
होगा,
next
but वो
वो
पर्सन
same
को
चीज़ है.
इंक्यूबेट करना भी नहीं आएगा, आईवी कैन्युला लगाना भी
क्यों
नहीं
नहीं
आएगा,
आएगा?
इंटर्न
आएगा.
जेआर को सिखाएगा,
आएगा.
सीट तो जरूर लाएगा, बट उसको कुछ आएगा नहीं.
इंटर्नशिप में करते हैं लोग, सब लोग करते हैं.
Then that's good. You
तुम्हारी
also
personal
mentioned,
choice-
you
तुम्हारी
also
personal
mentioned,
choice है वो.
I also want to, adding to this point, you also mentioned, the stance was not very clear, hence I would like to continue this point. You mentioned that there should be a certain way in which you measure the clinical skills that you develop at the end of your internship.
I didn't
Isn't
say that.
next to my friend the same
I
thing?
didn't say that.
You
I'm
did.
sorry, no, I didn't. Please check your.
Your question was right about internship skills, right? So if it's before internship, then they'll pay attention to internship. I addressed that point actually. तुम अगर 5 साल के बाद internship के बाद एग्जाम रखो, internship में people will study. तुम internship के पहले एग्जाम रखो, 4 साल people will study. All the 4 years, they will miss the postings that they are currently attending according to our opponent. जो 3 लोग हैं वो भी चले जाएंगे because all of them will be behind the rat race of passing the exam. So do not forget that. I'll give you an example. Just let me complete. I'll give you an example. 12th ke, after 12th when JE came in, before that people were not enrolling themselves into tuition so much. After JE came in, or after the IIT exam became a huge, bigger exam, JE for engineering through all the colleges and NIT and everything, almost there was a 70% jump in the people who enrolled themselves into the institution. Tum wahan par, you cannot solve the problem that way. I'll tell you why. If you want to increase if you want to make the driving experience of a car better, सिर्फ road अच्छे बनाने से problem नहीं है. कार में चीजें बदलनी चाहिए. The tires should involve and everything should improve.
Right,
So
right.
just like ma'am said, education में change लाओ. First year, second year, third year, fourth year, education में change लाओ. Exam में change लाके सिर्फ लोगों को fail करोगे. You will be only increasing the burden on the healthcare right now.
Right, sir. आप जो बोल रहे हो ना, next exam वही करता है. वो 4.5 साल लगाता है एक गाड़ी को Mercedes बनाने के लिए. All I'm trying to say is, you mentioned about the grassroots level. You mentioned about people not focusing on their studies all these years. Don't you think something like a next exam, which is measuring your clinical skills, cannot be developed in 1 year or 1 night or in a coaching institute? You can only develop it when you attend your 2-hourly daily rotation, whether psychiatry boring ho ya nahi, whether dermatology boring ho ya nahi, whether surgery pasand ho ya nahi. Don't you think?
I would like.
And also, just a minute, I would like to add a point. Sir, I am from 2019 batch with CBME curriculum. We have practical posting every day, every month. I have my gynecology exams from 2nd of January, which we are going to attend. So how are you saying कि पढ़ाओगे नहीं, गाड़ी को सुधारोगे नहीं, तो कैसे काम चलेगा? गाड़ी को सुधारने के लिए भी तो चीजें कर रहे हैं. The next exam is going to start from 2023, which is my batch will be attending next for the first time. We are getting prepared for it.
Not your batch, it will be our batch, most probably 2023. So that is our batch that will be giving next. She said it will be her batch giving the exam first. She's in 2019 batch. So listen, you are only talking and emphasizing on next 2. We have to also consider next 1 because our PG seat will be given to us on the basis of next 1. If our next 1 is conducted in, most probably it will be conducted in the first half. That means it gives us around few months in our hands to prepare for that exam after a final year university examination. Do you think that is fair on the part of for the students? Do you think it's fair and it's possible to crack a good rank? Doesn't that give us a bias?
Absolutely.
How is that fair? Do you think?
The NMC has announced the advent of next, not today, not yesterday, in 2019, my friend. It is not
Another
something that
point.
was introduced
This is
today.
another point I would like to mention. I was in.
It has given you 4
2019.
years of your medical life
Yes.
to prepare yourself in order to sit on that day and get a licensing exam and save a life.
2019. I was in second year. I would like to say something. USMLE. I would like to mention, take their example. They made a small change in their curriculum. Okay, so the step 1 was converted into pass and fail, and they gave a lot more time for the students to take in that change. Okay, they started it in 2022 and they gave it a long time back. They took the students' mentality, the framework, their mental peace into consideration, which our government has never done in case of UG as well as PG. If I have to give you UG's example, NEET UG 2016 also, it was implemented right in the last minute. MHCET was cancelled at last minute, and then NEET UG was implemented. So much stress for the students.
Absolutely. I'm from the 2016 batch. Ask me how I got my admission, but the fight here is not about the government being inefficient. The fight here is about next bringing a change in the medical fraternity to bring better clinicians for tomorrow. We are not talking about the government. We're talking about future doctors, my friend.
Sorry to interrupt. We'll now have the faculty also asking questions.
It's not faculty, but she was talking about her some gynec exam and preparation. You are preparing for the exam or not preparing for the exam? So you are. So there you are preparing for your formative exam. So you are learning your gynecology. If our aim is they should know their gynecology principles or techniques or whatever they are supposed to know. If she is studying for her formative exam, for that she should learn for that. You have to have next exam. What is this? That is what we are trying to tell all the time. These formative, they have done excellent job. CBME, they have put many formative examinations. They are added many skills and all. This is excellent. That is what we all need. So you are studying, no, in spite of not having fear of that next, you are studying. So that is what we want.
Ma'am, absolutely correct. But she's 2019 batch, was going to give her exam. That is why she studied. And 2016 batch, I have not studied.
Listen, we are not talking about any batch. We are talking about the future of coming all generations or this generation, for whom not, it is not for this batch or that batch, for all the batches. Whether is it really needed to do this such drastic changes where you are going to just put the old wine, the same examination, practical examination you are going to take and just give different name and sell it with the higher price. Is it really? We are having objection to that, dear.
Ma'am, I'm really sorry to interrupt, but if पढ़ाया जा रहा है तो exam का डर क्या है? If we are learning, then there's no fear to give an additional exam.
डर नहीं, wastage of time और energy और mental health है इसलिए.
कहाँ wastage of mental health और energy
We haven't
है?
asked the question. We were just answering. So I want to point out one thing. You know, what I would suggest, and I want your opinion on this. You mentioned foreign medical graduates को एक साथ एक exam में, so that you increase the number of people in India, so that more doctors are there, better healthcare. Before this, they were giving 2 exams. One MCI exam, which has high difficulty and low pass percentage. Secondly, the NEET PG exam. Why they were giving both the exams is so that they are at par with the doctors over here who are passing out. Somebody in Russia will not face TB as much as we do. यहाँ पर ऑफ्थाल में जाओ टीबी, ऑर्थो में जाओ टीबी, मेडिसिन में जाओ टीबी, गायनी में जाओ, तो ऐसे उनको नहीं मिलता. Even other cases, RTAs are so less. That's why they were giving that exam. You know, with this one exam, they will come directly into the competition, and you will, in order to increase the number, you will be further diluting actually the foreign medical graduates level. They should be giving those both exams.
Thank you so much for bringing
I haven't
that.
finished my
Oh,
question.
okay, sorry.
That was one. So please, please answer that. Secondly, if you want to increase the education level. Okay,
right?
cool. Because we were just going back and forth. That's
Sure,
why
sure.
abhi पूछ लिया, इसके बाद बहुत चलेगा पता है.
All right, sure. Coming to FMGEs, where I do my internship, we have innumerable FMGEs currently there. They take 2 years, sometimes 3 years, because the pass percent is 50%. And like I mentioned, there is an 84% fail rate. Fortunately, with the advent of next examinations, all of us are at an equal level. Let the next decide whether they are capable of sitting next to you or not. Who are we to decide whether they are eligible or not? Who are we to decide whether they are capable or not? There is a system introduced for the same reason, where they give their next one, check their clinical skills based on theoretical aspects. They complete the same internship that you and I do in the same wards. Ophthalm में भी उसको TB दिखेगा और हर जगह उसको TB दिखेगा. And then the same exam that you and I give, the person gives and then becomes eligible. And hence the discrepancy is solved.
ओके काय ना एक काय मेजर गोष्टी केली गव्हर्नमेंटने, तुमच्या अजून लक्षात कदाचित आलं नाहीये, पण एक छोट्याशा गोष्टीने तुम्हाला सगळ्यांना कळेल. प्रॉब्लेम वेगळाच आहे आणि आपण वेगळ्याच डायरेक्शननी चाललोय. कसं? तुम्हाला HIV चा स्प्रेड प्रिव्हेंट करायचा आहे, काय करायला पाहिजे? युनिव्हर्सल बायोसेफ्टी प्रिकॉशन्स पाळायला पाहिजे. एम आय करेक्ट? एव्हरीवन वुड ऍग्री. याच्यासाठी प्रत्येकाला कॉन्डोम घालून फिरायची गरज आहे का? हे असं झालंय नेक्स्ट एक्झामचं. युनिव्हर्सल बायोसेफ्टी कडे आपलं लक्ष पाहिजे. जसं सगळ्यांनी सांगितलं की जर काही प्रॉब्लेम असतील आत्ताच्या एज्युकेशन सिस्टीम मध्ये तर ते आपण चेंज करून, करेक्ट करून, इम्प्रूव्ह करून चांगलं करायला पाहिजे. आणि नेक्स्ट एक्झाम इज लाईक टेलिंग समबडी ओके यू वेअर अ कॉन्डोम अँड देन यू डोंट फॉलो बायोसेफ्टी, तर को थोडी HIV होने वाली. सो असं ते फोकसच चेंज झालं असं मला तरी वाटतं.
नाही, आता मनीष नेहमीप्रमाणे ही प्लेस टू द गॅलरी. आता या ठिकाणी HIV आणि कंडोमचा काही संबंधच नव्हता, राईट? बिकॉज टाळ्या मिळतात म्हणून वाक्य टाकायचे असा प्रकारचा प्रकार आहे. करिक्युलम कॉम्पिटन्सी बेस्ड मेडिकल एज्युकेशन. आता घरी गेल्यावर गुगल करून बघ त्याच्यात काय काय आहे, राईट? प्रॉब्लेम बेस्ड लर्निंग PBL, स्पेसिफिक लर्निंग ऑब्जेक्टिव्ह, व्हॉट इज COPO, ह्या सगळ्या गोष्टी करताना मेडिकल टीचर्सचे घामटं निघतंय. बरोबर ना सर? आणि आता करिक्युलम बसवायचा आहे, त्याचं मॅपिंग करायचंय, हे सगळं आम्ही करतोय. आणि हे आम्हाला सगळं इम्प्लिमेंट करायचंय केव्हा? जेव्हा आमचे शिक्षक उधार उसनवार साताराला जातात, बारामतीला जातात आणि इकडे तिकडे जातात. दे आर अंडर ट्रिमेंडस प्रेशर. आय हॅड अ हार्ट टू हार्ट डिस्कशन विथ कुलकर्णी. शी वॉज ऍक्च्युअली इन फेवर ऑफ दिस रेझोल्युशन, बट शी स्पोक व्हेरी वेल अगेन्स्ट द रेझोल्युशन. सो आय फील दॅट तुम्ही कोंबडं झाकलं म्हणून सूर्य उगवायचा राहणार नाही. आणि इट इज अन ऍक्ट अँड इट इज गोइंग टू बी इम्प्लिमेंटेड. आपण इथे डिस्कशन करून नेक्स्ट काढून टाका असं घडणार नाही, कारण वरती एक पंतप्रधान बसलाय जो सहसा मागे जात नाही. फार्म लॉज एक्सेप्शन.
सर एक्झाम्पल फक्त दिलं लोकांना कळावं म्हणून, बाकी कारण कॉमन गोष्टी काय एक्झाम्पल शिवाय कळत नाही. हा पहिला गोष्टी. आणि दुसरं महत्वाचं आहे, कबूल आहे तुम्हाला खूप काम पडतंय किंवा मॅडमला खूप काम पडतंय, पण आपला डिबेट अंडर ग्रॅज्युएट या लोकांसाठी आहे, तुमच्या आमच्यासाठी नाही. यांची वाट लागू नये यासाठी ही एक्झाम नकोय असं माझं म्हणणं आहे. ऑलरेडी अंडर ग्रॅज्युएटची भरपूर, म्हणजे आय फील रिअली यू शुड गो अँड सी हाऊ अदर अंडर ग्रॅज्युएट पीपल डुईंग अदर स्पेशालिटीज दे आर इन देअर लाईफ. We are already done with so many things. Now putting one more exam on your head is really killing too much.
Practically, they are also for the exam, but only problem lies with how to execute, and that's difficulty they are facing. There should not be any debate. Everybody is agree for next should be there. That will be helpful for the society at large.
सर
only execution they have a difficulty.
नाही
That can be
सर,
sorted out.
नेक्स्ट आणि नीट मधला फरक जो आहे त्यांनी ते लेवल 2 केलेली आहे, प्रॅक्टिकल एक्झामिनेशन घ्यायची. तो एक मोठा फियास्को आहे असं आमचं अगदी प्रामाणिक मत आहे. नेक्स्ट 1 जे आहे ते नीट सारखंच आहे सर, त्यात काही फरकच नाही आहे. त्याच्यामुळे आम्ही ते नाही, कारण नीट हवी का नको असा डिबेटच नाहीये ना सर. त्यामुळे आम्ही एक्झाम नको आहे असं म्हणतच नाहीये. आम्ही जो नेक्स्ट नावाखाली ते जे त्यांनी घातलेलं आहे, पिल्लू सोडलेलं आहे, प्रॅक्टिकल घ्यायचं, त्याला काय अर्थ आहे एवढंच आमचं म्हणणं आहे सर.
म्हणजे दोज हू आर इन फेवर हॅज वन, बिकॉज 5 of people are on this side, 3 on the other side. And if we don't have NEET, I was a student when in 1978, when our merit depended on our subject merit, and there was a lot of manipulation of the results. It's like she mentioned the orthopedician's son has to become orthopedic surgeon, surgeon's son has to become surgeon, And that kind of, if he doesn't do well in practicals, manipulation in theory marks was done in Pune University. So that kind of a thing, whether you want boys, you can have it. Enjoy that thing. Because then the bosses will dictate the terms and you will have to please the boss. And examination, it depends on whether I like you or not. That's not the system we want. We want the transparent system.
Thank you. Thank you everyone for your enlightening views. I would like to take audience questions if there are any in the next 5 minutes. Anybody?
So I just
अभ्यास झालेला दिसतोय तुझं.
So I'll give a suggestion also, and I'll just object on one question or fact which someone has said. Someone said that we should just take NEET because we have to make our education along with USMLE type, means we just want to improve standards of examination. I want to ask, does standards just improve by taking exams? It isn't. Okay, so coming to the point, do you want to just improve the standards just of exams? Have the standard of facilities in hospital pan India as improved? आज भी इंडिया में ट्रॉमा मैनेजमेंट की ब्रांच नहीं, पर नो हाउ टू मैनेज पेशेंट इन इमरजेंसी के क्वेश्चंस पूछ लिए जाते हैं. इंडिया में आई के लिए इंसिजन सर्जरी की जाती है, पर एग्जाम्स में फैको पूछते हैं. ब्लड हीमोग्लोबिन के लिए आज भी हमारी इंडिया में सालीज मेथड से कलर मैच किया जाता है, तब तक तो पेशेंट मर जाता है. हमको दो चीज पढ़ाते हैं, मोस्ट कॉमन और मोस्ट आइडियल इन्वेस्टिगेशंस, है कि नहीं? Why? क्योंकि इंडिया गवर्नमेंट को सिर्फ परवर्डेबल एंड अफोर्डेबल ही बताए. जब मोस्ट आइडियल इज इक्वल्स टू मोस्ट कॉमन हो जाए, तब गवर्नमेंट को बोलो नेक्स्ट ले ले.
You have a question or
suggestion plus? No, just a minute. Okay, I couldn't take part, so I'm here. जब हमने देखा ही ना हो कि व्हाट बेस्ट एंड एडवांस्ड इज, फिर एग्जाम को यूएसएमएलई से कंपेयर क्यों करो? जब देखेगा इंडिया तभी पढ़ेगा इंडिया, तभी तो बढ़ेगा इंडिया.
Sir, do you have a question for the participants?
Okay, just one thing. Everything has ended, and just there should be no obstruction for feelings, because when this event will be over, I will be not there. They will be not there. The thing will be all over. So please.
No, this event goes on. You can come next year.
Just one session request. Just one session. So I'll tell you just what is the suggestion. In India, this is the game of tyrants. Everyone is best. But what India wants, कैसा है? मतलब कि 20 people are there. There are 20 competitors. In USA, you have 30 seats. You have 30 seats for medicine. You have 30 seats for surgery. So those 20 people have a doubt कि यार ये ले या वो ले. उन लोगों को 50% से ज्यादा नहीं पढ़ते, बट इंडिया में सब लोगों को 90% से ज्यादा पढ़ते हैं. बट इंडिया में सिर्फ 20 लोगों के लिए 2 सीटें मेडिसिन की. मतलब उन बेस्ट लोगों में से भी बेस्ट चूज करता है. एंड दिस इज द प्रॉब्लम कि हमें 20 लोग सब बेस्ट है, but we don't worship that talent and we just take examinations, and this is wrong. So thanks.
I have a question for Dr. Agar Khekar, sir. Sir, you said that when you were a student at that point of time, because the marks were in the hands of a select few people, there was a lot of manipulation and there was no uniformity. Next two will be a practical exam. And in that case also, there will be people testing us, and it won't be a written examination.
It may not be from your college. They may not be from your college.
But still, if there is, it is very subjective. So, I mean, and it's also putting a lot of load on the faculty.
I will give you an answer to this. There is a lot of reforms are going on the assessment methods as well. The assessment methods will be objective, as he said, subjective. Subjective has no role. Objectively assess. Like you start with the chief complaints, we give 1 mark. Then you start with the ODP, we'll give 1 mark. Like that, we'll come to diagnosis, then you will get good marks. So that is how the assessment will be made. Osler is one method of assessing the long case. So these reforms are coming in the medical education technology, and that will be implemented. And that has started in 2019, and it will be implemented is being implemented because we are training the students vertical and horizontal integration from fourth term, third term, fourth term. So that is how the teaching is being implemented, and it will be, every student will be knowing. Let me tell you one thing. One of my friend was working in Australia. The director of NICU, he did not clear the NRP exam. He was removed from HOD's post and made the resident again till he cleared that exam. So this is what situation is. Every 5 years, people have to renew their skills. PALS, SELS, and all these techniques has to be acquired by every doctor. Recently, there was a death of one pediatrician in Pune city. He died due to anaphylaxis after ceftriaxone, and nobody could save him. Simple thing like adrenaline could have saved him, but it was not done. A 62-year-old pediatrician, a very healthy sports person, died because of anaphylaxis. So if you are not able to manage anaphylaxis in your clinic, then people will definitely beat you black and blue. That's what the training is. The training is, I have seen my teachers in ENT and ophthalmology, whenever there was a cardiac arrest, the first thing they did, they shout for the help. Are doctor koni hai, doctor koni hai. The ENT surgeon and ophthalmologists are also doctors. But the first thing he did, because in Pi's surgical handicraft, it didn't mention that you call for the help, shout for the help. The first thing they did, came out and helped for the doctor, forgetting that they are also doctors. So everyone must be skilled enough to manage the anaphylaxis to emergencies, and that is mandatory. And if you go in the various clinics in Pune city, you'll find there is no oxygen cylinder, there is no suction machine, there is no laryngoscope, there is no endotracheal tube. How are you going to manage the anaphylaxis? How are you going to secure the airway? That's what is required. And that's what is necessary. It is underlined after this COVID pandemic, and limitations on the healthcare system were exposed. And now the things are improving. So that is what is required, and it is mandated, because every 10 years we are getting pandemic. Last was swine flu. This was corona. I don't know. Xi Jinping will produce one more virus and that will come.
Thank you for your answer, sir. But regarding the same practical question, I would like to ask Urbi the same thing.
Could you repeat your question, please?
I'll give you a different question on the same lines. My question is regarding the practical examination, which is next to. Urbi, how would you feel as a student? Because this is with special reference to the undergraduate students. As an undergraduate student, your future will depend on the hands of the person in front of you who is given the exam. Can I please finish my question? And at that point of time, if something goes wrong, then who will you hold accountable for the same?
By the way, as the rules say, next two is not accountable for marks. It's just a pass-fail exam as a licensing exam. Either ways, you pass your practical for being a doctor, getting a DR in front of your name. Only next one is there for your PG entrance exam. Next two is not there. And unlimited attempts.
3 years your score will be valid. You can attempt as many times.
I have a question for
So
participants.
keep on giving exams throughout your life. तेवढंच राहिले आपल्याला करायला.
I have a question.
After 2 years, there will be another next to next exam, then super next exam, then hyper next exam, then under next exam. And these people will say that somebody sitting there had appointed a committee who thought all these next to next
This
to
is,
next to
this
next
is what I
exams.
like about Manish Matswe. He keeps on diverting from the main issue.
No,
now
sir.
that lady is very serious about the questions, and you should address that question.
At the first instance, if we do not put our opinion, if we do not work, we have all these laws. Amongst all of them, I can tell you, I have done LLB. I fight for doctors in court. I know how our seniors have gone wrong in not opposing important laws at their inception itself. So if we are discussing something today, and even though I am joking or whatever jokes I am creating, it's very serious discussion, sir. आपणच आपली वाट लावून घेतली MTP Act, PCPNDT Act, NMC bill, because we did not represent there. We did not go and say, and when we try to do something, our own people are put behind jail and bars. Have you seen videos yesterday? So although it is very easy to, say ki he चांगलं आहे, but again, if I put myself in your shoes, and again, I'm saying for undergraduate students, already 4.5 years you are giving exams, then internship, then again exam. And what happens? 4.5 years you are good. Only on that day, for some reason, जुलाब झाले तुम्हाला. अरे होऊ शकतात. So एका एक्झाम वर तुम्ही सगळं कसं अवलंबून ठेवू शकता? शक्य नाही. That is wrong. It is not something which is physiological and hormonal.
Okay. I have one question for participant number 3. So there is an argument that this exam is meant to produce good doctors because it is a good exam. So my question is, now there are some problems at the grassroots level. I want to continue Khyati's point that there are many postings and stuff where we are not taught. It is a waste of time. So according to me, no matter how many exams you conduct, whatever you make a pattern at the topper level, like the highest level, that is the next. But the real problem lies at the grassroots level. So why put one more tension on the student's head of one more exam when you're not addressing the grassroots questions?
Your interest is directly proportional to the interest of your faculty. That is what I have learned in 4.5 years of my medical education. Every time I chose to go to the ward to my professor always looked at me with a smile, helped me with research, helped me with extra things in the ward, helped me with whatever I needed. Unfortunately, if you must have come across a professor, I mean, it's very unfortunate. I have never ever come across such a professor. But if something like that exists, I am sure the next exam increases the answerability that the faculty member has to the principal, to the dean, to the university, because he or she has to make you prepared in order to pass that exam.
How does a next exam increases the answerability of the faculty? The student is getting affected.
Because by the end of the day, your college...
The student gives the exam and goes. But how will it increase the answerability of the faculty?
I will answer this question. In this NMC, under NMC bill, there is one thing called feedback from the students about the teachers. You have the right to give the feedback. If somebody is not teaching you, that feedback should go. And that is what is included in this NMC bill. And that feedback has to be there so that you can improve the system.
So sorry to interrupt, but sir...
Sir, एक minute. Let me complete his sentence. That feedback is very good addition of CBME. Sir, what is happening? We are mixing up CBME and next. त्या फीडबॅकचा आणि टीचरनी सुधारण्याचा त्या नेक्स्ट परीक्षा कंडक्ट करण्याशी काहीही संबंध नाहीये.
Yes, ma'am. And one more. I just want to add one point to ma'am's answer. मुलगा एक्झाम देऊन जातोय, त्याचं करिअर बर्बाद होत आहे, त्याची एक्झाम घाण गेली, पण तिथे फॅकल्टीचा परत त्या फीडबॅकचा काय उपयोग? एका मुलाचं तुम्ही पूर्ण करिअर बर्बाद करून टाकता.
Have you heard of something called the NAC accreditation? I know because my college is an A.
I just want to add something. Yeah, this is the fallacy of NMC. NMC खुद इंस्पेक्शन करने आता है, NMC इतना ग्रेड देता है, फिर वही इंस्पेक्शन के बाद next via an exam they are going to again one of the objectives of the next exam is so that all the peripheral medical colleges are brought to the standard of the premier institute. अगर वही इंस्टीट्यूट के स्टैंडर्ड तक लाना है तो इंस्पेक्शन में चेंज करो ना, एग्जाम में चेंज करके क्या फायदा? एग्जाम करके स्टूडेंट चेंज हो रहा है, कॉलेज वही का वही है. इंस्पेक्शन जब होगा, कॉलेज को पास मत करो, कॉलेज बंद करवाओ, स्टूडेंट्स नहीं पढ़ेंगे, फालतू के 5 साल नहीं जाएंगे. 5 साल स्टूडेंट पढ़ने के बाद फिर उसके बाद एग्जाम देके फिर बाद में बोले अरे नहीं कॉलेज खराब है, तो रेट्रोस्पेक्टिवली नहीं, प्रोग्रेसिवली करो.
और सर आप कहते हैं कि इंडिया में डॉक्टर्स की कमी और कॉलेज बंद करवा दे.
हाँ तो
है ना सर,
FMG से ऐसी क्वालिटी लेस वाले डॉक्टर्स को करने से तो अच्छा ही है, जितने हैं वो लाइफ सेविंग बने बस.
Thank you everyone.
I have one question for that team. I'm so sorry, but I want to ask that question. Like I have asked them one question, but about when I was thinking, I want to ask your team one question. Next is about bringing a uniformity, right? So next gets that uniformity is one of the argument. So if you are saying that remove next, how will you bring a uniformity in the entire education system of India? Like, because if I'm from Tamil Nadu, I'm from Maharashtra, I want to take admission in a college which is in some other state. They have some other system, we have some other system. So there should be a level playing field and there should be a level playing exam. So if you are saying that take away next, then what? Uniformity is, how would you address the uniformity
We can
issue?
still maintain the uniformity. We do not need to completely extract what we have already built. We can make changes for the betterment in what we already have. Like next for NEET PG jo abhi bhi hai, we can make improvements in that. Why do you want to add something called next? तुम लोग INICT निकाल दो, JIPMER निकाल दो, सब निकाल दो. You keep only NEET PG. What's the problem in that? Keep clinical scenarios in NEET PG. Change the pattern of MCQs in NEET PG. Why do you want to completely add another segment to this and stress the students so much when it's just 1 year that we have and we really don't know what exactly the pattern of the exam is, when the exam will be conducted? And I strongly believe कि exam के लिए पढ़ने से पहले exam को पढ़ो. We have come to that situation because NEET UG ने हमको उधर लाया है. NEET PG में भी हमको वही करना पड़ेगा because we need to get that rank to crack that exam. We need to know how the exam is being conducted. They are just putting stress on the medical students of the entire country day in and day out. Thank you.
Thank you. I request the judges to say can we I'm so sorry. I would request the judges to say a few words and announce the results.
डिबेट करण्याच्या मूड मध्ये नसणार होते का आता सगळे. So thank you very much. I would like to thank both the teams for putting their views and competing also in the both in a healthy way, right? So thank you very much. And I would like to announce the prizes for the competition. So the best speaker for today's, it is the, any guess? For or against? See, most of the clapping they are for against, right? So I thought the prizes might be for the against, right? So the best speaker is Sahiba Maniyar. Congratulations. And best rebuttal is Khyati Hambardikar. Congratulations again. Even those who have participated, again, congratulations for them also. It is not like they have lost, they also won. So don't feel wrong about that, right? So only 2 prizes are there, that is the issue. And thank you for the speaker. There are no, there are no prizes, but thank you for the contributions. No. So again, thank you very much. Yeah, thank you.
Good afternoon, one and all. It gives me immense pleasure to deliver the vote of thanks to the dignitaries assembled here. A debate competition is not just about the views, counter views, and the arguments. It's about the perception and the vision. It broadens our horizons and gives us different perspective to think about. We are empowered by the ideas and the thoughts of the speakers we listen to, and invariably during the process, each one of us develops some opinion and end up being a part of the debate. Thus, it would not be wrong to say that each of us owns the event, and the event would not be possible without any of us. We are honored to have eminent judges, knowledgeable faculty, speakers, and enthusiastic students with us today. Last but not the least, our debate enthusiasts and wonderful audience who have with their presence elevated the enthusiasm of the debate. Without any further delay, I would like to declare that the debate has ended. Thank you once and all again.
घटेगा. Here I am interested in ऐसे ये सारे जो एलिमेंट्स हैं इनके वैल्यू सारी 3 मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना है कवर करना.
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walk.
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis. But which kind of episodes, everybody? Chronic episodes.
We have the tonsil, then we have the lateral walls of pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in 2 axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, it is passing in the optic canal. And last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or brow presentation.
If they're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic.
When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I have given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect.
The presence of segmental cafe-ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
As I was looking at the file, maybe I was half sleepy. Something interesting happened. The file just slipped off my hand and fell. What happened was, when the file went and fell down next to the child suddenly startled. The moment the child startled, my sleep went away. I was wondering what happened. I just took the file again, put it down again. The gush of air, another startle. That's when my brain tickled and said, could it be something which we are missing? I took a water bottle nearby, poured water next to the child. The child started gasping and startling. That is what we call as hydrophobia. Most important point was, this child was in neurology wards under the best doctors for about 3 days before, and nobody had picked up rabies in that child. When I saw with half sleep, picked it up. What is most interesting to say here is, anytime when I doubt my clinical abilities, I remember this and I say, Sunil, clinical skills will always help you. So, welcome to Marofy edition, where we'll be talking about a lot of clinical vignettes and a lot of things which will matter for life, not just for the entrance. Natural or environment phobias could be something like hydrophobia, which makes you not go to places where there's a lot of water, lakes, ponds, swimming pools, such kind of natural environments, and those can make them trigger having extreme fear, hydrophobia. They can also have acrophobia, which makes them find it difficult to go to hill stations and those where heights kind of are a bother to them.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स हैं, इनके वैल्यू सारे 3 मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना है, कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walk.
As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis, but which kind of episodes, everybody? Chronic episodes.
So we have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in 2 axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, it is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or bro presentation.
If they're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic. When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I've given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect. The presence of segmental cafe ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6x6x6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population.
Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added, and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects, which you feel are the dry subjects of the medicine, you have to learn it with clinical correlation. Then only you will get a motivation to learn it. And this is what is expected from you in all the competitive exams that is going to come in the future. And that is where the Clinical Core Edition 5.0 stands apart. You can see 4 pyrols are coming, and you can see now this is a porphyrin. So we will learn about the different porphyrins first. You don't have to write all the rings every time. You can just use a simple diagram like this, which means these are the pyrrole rings. You can see the first, second, third and the fourth pyrrole ring.
As I was looking at the file, maybe I was half sleepy. Something interesting happened. The file just slipped off my hand and fell. What happened was, when the file went and fell down next to the child suddenly startled. The moment the child startled, my sleep went away. I was wondering what happened. I just took the file again, put it down again. The gush of air, another startle. That's when my brain tickled and said, could it be something which we are missing? I took a water bottle nearby, poured water next to the child. The child started gasping and startling. That is what we call as hydrophobia. Most important point was, this child was in neurology wards under the best doctors for about 3 days before, and nobody had picked up rabies in that child. When I saw with half sleep, picked it up. What is most interesting to say here is, anytime when I doubt my clinical abilities, I remember this and I say, Sunil, clinical skills will always help you. So, welcome to Marofy edition, where we'll be talking about a lot of clinical vignettes and a lot of things which will matter for life, not just for your entrance. Natural or environment phobias could be something like hydrophobia, which makes you not go to places where there's a lot of water, lakes, ponds, swimming pools, such kind of natural environments, and those can make them trigger having extreme fear, hydrophobia. They can also have acrophobia, which makes them find it difficult to go to hill stations and those where heights kind of are a bother to them.
Here I am interested in ऐसे ये सारे जो एलिमेंट्स हैं, इनके वैल्यू सारे 3 मेजर कॉन्सेप्ट्स हैं जो बेसिकली हमें क्या करना है, कवर करना।
What? We are going live, right? We are going to start on Saturday.
फ्रिक्शन का मैक्सिमम यूज हम करते हैं in a phenomena known as walking. As soon as you see such a pupil, this is characteristic of uveitis, anterior uveitis. But which kind of episodes, everybody? Chronic episodes.
We have the tonsil, then we have the lateral wall of the pharynx, and then lateral to that, this space is what is known as the parapharyngeal space.
Fluctuation should always be done in two axes to confirm whether it's true fluctuation or not in any swelling.
The ophthalmic artery, it is passing in the optic canal, and last branch, this is our anterior choroidal artery. These are the intracerebral branches of internal carotid.
Thyroid gland, which has taken up most of the radionuclide iodine isotope that we have injected, is now going to emit radiation.
Anything which is preventing flexion is going to lead to face presentation or bro presentation.
If they're talking about altered sensorium, then they're talking about delirium tremens. If they're talking about clear sensorium, they might be talking about alcohol-induced psychosis.
This integrated phage DNA is now called as prophage, and we call this bacterium as lysogenic. When the glenoid labrum get avulsed from the anterior-inferior part of the glenoid because of anterior shoulder dislocation, we call it the Bankart lesion.
BPCs with a short coupling interval or RONT phenomenon are more likely to complicate into proper arrhythmias like ventricular tachycardia.
The dried reagent for the reverse transcriptase enzyme and all the things are in a dried format, which we are doing very fast.
I reduced the oxygen flow, our nitrous oxide flow also is reduced. So this is known as link 25 system.
I've given you the way to remember. Turner syndrome is left-sided heart defect and Noonan syndrome is right-sided heart defect. The presence of segmental cafe-ole macules associated with fibrous dysplasia and precocious puberty is going to clinch the diagnosis of McCune-Albright syndrome.
6 by 6 by 6 strategies. You have 6 interventions with the 6 beneficiaries with the 6 eligible population. Retinal vessels are fragmented. It is seen within few minutes.
It was a busy day in our casualty. A 30-year-old man was brought to the casualty with generalized seizures. The patient was not responding to any of the anticonvulsant. I found that Ehrlich test was positive. So I did the differential extraction and find out that the urine metabolite was urine porphobilinogen. The message was conveyed to the physician. She changed the anticonvulsant and IV dextrose added, and the patient responded immediately. That's why we say the phase 1 and the phase 2 subjects which you feel are
He who studies medicine with books sails an uncharted ocean, but he who studies medicine without patients does not go to the sea at all. Good evening, everyone, and welcome to the finale of Cognizance, the medicine quiz, which is an integral part of Respirare. Respirare Respirare is a student-organized international conference which has been successfully organized each year since its inception in 2015. This year, all events, including the Cognizance quiz, are broadcasted live for the delegates. It is a great pleasure to welcome the quiz master, Professor and Head of the Department of Medicine, Dr. R.T. Bose, sir. He has done his UG and PG from BJ Medical College itself, after which he became a lecturer and the Professor of Medicine. Sir has worked non-stop for the patients during the COVID pandemic, for which he was awarded the Maharashtrian of the Year 2020. He had also been invited to speak in the prestigious Man Ki Baat with Honorable PM Narendra Modi. He has also received the Dr. Ratna Award in 2006. He has also been the part of various research projects and clinical trials. I request you, sir, to come on the stage for felicitation. I would also like to call Dr. Avanti Bhosle ma'am to come on the stage. I would like to call Dr. Meenal Chandanwale ma'am to come on the stage. Okay. I would request Dr. Neha Suryavanshi ma'am to come on the stage. I would like to thank Dr. Prasad Bagre, Dr. Mohit Kumar, Dr. Milind Karade, Dr. Shubham Mandre, Dr. Deepak Tripathi for their contributions in the quiz. The aim of our quiz is to move beyond books into the real world of medicine for us to be more holistic in our approach, and that is the philosophy behind our quiz and our questions. I congratulate all the teams that have been selected for the finale. Now I request all the teams to introduce themselves, starting with Team Fanconi. Just mention your name and your year of study.
Taha Hussain, final year MBBS. Khan Zabiullah, final year MBBS.
Team Hodgkin.
Advait Melankari, third first.
Johan Joseph, third first.
Team Parkinson.
Ayush Doka, intern.
Ganesh Bogawde, intern.
Team Wilson.
Gautam Shrotri, final year.
Amish Panda, final year.
The quiz has total of 5 rounds, consisting of the clinical case round, supervised round, pictorial round, rapid fire round, and the buzzer round. The rules and marking scheme for each round will be mentioned before the individual round. An extra tiebreaker round will be conducted at the end if 2 or more teams end up getting the same final score. We'll conduct the rounds in a clockwise manner, starting from Team Fanconi. Now I call Dian Magdum on the stage to conduct the first round.
Hello, I am Dian Magdum. Congratulations to all the participants. Let's start the first round. Clinical case round with a quote by Mahatma Gandhi. A correct diagnosis is a 3/4 the remedy. Okay. The rules of this round are, in this round, each team will be asked 2 questions. Question will be in the form of clinical case, which the teams have to diagnose. Correct diagnosis will be awarded 10 points each. There will be no negative marking. Time limit to answer the question is 30 seconds. Timer will start after the anchors have finished reading the question. No marks for partially correct answers. If the question is answered incorrectly by a team, the other teams have to write their answer along with the name of the team on a page provided and fold it in the form of cheat. Time limit is 10 seconds for the same. These cheats will be collected and 5 points will be awarded to all the teams that answer correctly. The decision of the quiz master will be final and binding. So are you all ready for the clinical case round? Scorekeeper ready? Timekeeper ready? We will start with Team Fanconi. The question is, 14-year-old female was admitted with history of diffuse abdominal pain, vomiting, along with bilateral lower limb mild swelling and bilateral lower limb rash since few days. She also had a history of fever and headache few days back. On examination, vitals are stable, bilateral lower limb purpuric rash present, bilateral localized knee and ankle edema present. Systemic examination was normal. Routine labs are as following. Hemoglobin of 10 gram per deciliter, TLC 17,000 per mm cube, platelet 4,20,000 per microliter, creatinine of 1.5 milligram per deciliter, urea 26 milligram per deciliter, potassium 3.3 milliequivalent per liter, sodium of 135, urine shows albumin 2 positive and raised ESR. Ultrasound abdomen shows mild free fluid. Skin lesion biopsy shows leucoclastic vasculitis. What is the likely diagnosis? Time starts now. Time's up. Wrong, incorrect. Incorrect. Other teams have to write in the cheat. Correct. Hodgkin's incorrect. Team Parkinson and Team Wilson. Correct. 5 points each. The correct diagnosis is Henoch-Schönlein purpura. The next question for Team Hodgkin's is, next slide please. A 44-year-old female, known case of diabetes mellitus, is on a treatment with injection Mixtard 30/70, 16 units before breakfast and dinner. She was diagnosed 5 months back with HbA1c 8.8%. She presented with fasting hyperglycemia with a level of 288 milligram per deciliter. On examination, vitals were normal, systemic examination was normal, routine labs were within normal limits. Insulin dose was increased subsequently in further visit to injection Mixtard 30 units BD with no improvement in fasting hyperglycemia. However, HbA1c has decreased from 8.8 to 6.8%. BSL profile of 2 days on self-monitoring showed the following figures on the screen. And the question is, name the following phenomenon or effect. And the time starts now. Time's up. Other teams have to write on the cheat. 10 seconds. Team Parkinson's correct, 5 marks. Team Wilson wrong. Team Fanconi correct, 5 marks. So the correct answer is Fanconi and Parkinson. The correct answer is Somogi effect, early morning hyperglycemia, which occurs due to rebound effect from late night hypoglycemia. Okay. The next question for Team Parkinson's is, next slide. 54-year-old male, known case of diabetes mellitus, since 10 years, presented with history of tingling and numbness of feet and sleeping of sleepers, without awareness for past 4 months, followed by swelling of feet, difficulty in walking since few weeks. On examination, vitals were stable. On local examination, feet were swollen with hyperpigmentation, with right foot calluses, ulcers at pressure points, and loss of foot arches. CNS examination showed loss of foot sensation, absent ankle jerk, knee jerk, and imbalance on closing eyes while standing. CVS, RS, and per abdomen examination is normal. Routine laboratory tests were within normal limits. X-ray foot lateral view is as shown on the slide. The condition is called as, your time starts now.
Diabetic neuropathy.
Incorrect. Other teams give the cheat. Team Fanconi correct. Team Wilson's correct. It is Charcot's neuroarthropathy or Charcot's joint. X-ray lateral view shows dislocation of talonavicular joint, destruction of calcaneum, disorganization of tarsal joint, and soft tissue swelling. Okay. Now the next question for Team Wilson's is, next slide. 14-year-old female was admitted with complaints of fever with chills since 2 weeks. Fever was high grade, intermittent, associated with breathlessness, with mild cough since 2 days. Progressed at rest. No history of cold, lower limb swelling, diabetes, hypertension, TB, and asthma. On examination, the patient is thin-built, febrile, pulse of 78 to 90 per minute, irregular, low volume, BP of 100 by 60 mmHg, mild pallor. Systemic examination is as follows. CVS examination showed tapping apex bit, left parasternal heave, mitral area auscultation showed loud S1, diastolic murmur was present, pulmonary area auscultation showed loud P2. RS examination showed bilateral basal crepitations. Per abdomen examination is mild splenomegaly. CNS was normal. Routine lab was raised TLC. ECG shows rate of 80 per minute, irregular rhythm, right axis deviation, P pulmonale, left atrial enlargement. What is the likely detailed diagnosis? Your time starts now.
The second point that you should have mentioned was the atrial fibrillation. It is irregular pulse that is there, right? So atrial fibrillation, but the rate that is there is 80 per minute. Am I right? It is 80. So it is a controlled atrial fibrillation, right? That is second. And then the infective endocarditis. Perhaps infective endocarditis is not because of rheumatic fever. Infective endocarditis is altogether different entity. Mitral stenosis is because of rheumatic fever. Okay, so that should have been the complete. One more point that you are forgetting, the pH is also, loud P2 is also there. Loud P2 is also there, right? So pulmonary hypertension. Okay.
Correct answer, 10 points. Team Wilson, 10 points. Now the second round of the same questions, clinical case. We'll start again with Team Fanconi. The question is as follows. A 60-year-old woman is admitted in an ICU for several weeks. Her hospital course has been complicated by aspiration pneumonia and sepsis. which have required prolonged use of antibiotics and mechanical ventilation. In last few days, she had spiking fevers with profuse watery diarrhea. Her ABGA shows the following. ABG is as following, as on the slide. What is the primary acid-base disorder? Your time starts now.
Respiratory alkalosis with compensatory metabolic acidosis.
Yes. Yes, sir. Is the answer correct?
It is other way around. It is the metabolic acidosis with compensatory respiratory alkalosis. And if you find out the anion gap there, can you find out the anion
Find
gap?
the anion gap.
Find the anion gap.
.5. 19.5.
How have you calculated it?
Sodium minus potassium and chloride.
Yes.
Sodium minus potassium minus chloride.
How is the anion gap calculated? Yes, interns.
Question.
In anion gap,
PPT.
Sir, sodium minus chloride and bicarbonate.
Ah, yes. So how much it is now?
Is 938 8.
So it is 8. So what is the normal anion gap?
8 to 12.
8 to 12. So it is a normal anion gap. Normal anion gap metabolic acidosis with compensatory respiratory alkalosis. Okay. So that should be the answer. Right.
Sir, how much marks to be given?
50%, 5 marks. Out of 10, 5 marks.
Okay. So team Fanconi, 5 marks. So the next question for team Hodgkin is: a 36-year-old man has a stable ulcerative colitis for 5 years. He is being treated with sulfasalazine 1000 milligram 3 times daily. On routine follow-up, he is found to have an ALT of 250 international units per liter, an AST of 225 IU per liter, and alkaline phosphatase of 450 international units per liter, and a bilirubin of 2 micromole per liter. Ultrasound of abdomen reveals no bile duct dilatation or gallstone. Endoscopic retrograde cholangiopancreatography, that is ERCP, reveals multifocal strictures and dilatations of both the intrahepatic and extrahepatic bile ducts. What is the most likely diagnosis? Your time starts now.
Primary sclerosing cholangitis.
Can you repeat?
Primary sclerosing cholangitis.
Yes, that is correct. 10 points for team Hodgkins.
Can you answer why is not the problem because of sulfa drug? Can you mention it? Can you explain? Because the patient has been on sulfasalazine 1000 milligram 3 times a day. So is there a possibility of sulfasalazine giving rise to hepatic damage? Now the answer there is very simple. Why it is not a sulfa related hepatic problem?
Because there's
Any other team interns?
Because there's intrahepatic and extrahepatic bile duct damage.
Basically, there are two things those are there. One is the ulcerative colitis, is case of ulcerative colitis, right? And ERCP, that is mentioning retrograde cholangiopancreatography. Multifocal strictures are there with dilatations of both intrahepatic as well as extrahepatic bile ducts. That means there is some chronic problem that is going on in the biliary tree. And in a patient of ulcerative colitis, right? One of the important complications that they'll end up as far as the hepatic complication is concerned is the sclerosing cholangitis. Now, if at all it is sulfasalazine related hepatic problem, right? The patient is on this sulfasalazine for many years. Why should there be a problem, sudden problem that should be there, or say subacute problem that should be there? If at all, it should give rise to acute problem. The enzyme should have been very high. That is one. And second thing is ERCP is very classical of, sclerosing cholangitis here. And that's why the answer has to be sclerosing cholangitis, right?
Sir, 10 points. Okay. Next question for team Parkinson's is, okay, a 58-year-old female was admitted with history of dizziness, palpitations, restlessness. On examination, pulse was 130 to 145 per minute, irregularly irregular, tremors were present, neck swelling present. Systemic examination is as follows: CVS examination, S1, S2 heard, tachycardia present, RS, PA, per abdomen and CNS examination are normal. ECG is narrow complex tachycardia with a rate of 134 per minute, irregular rhythm. No P wave seen. Patient received IV diltiazem for rate control and was stabilized. 2D echo showed no valvular lesions. What is the likely diagnosis?
The patient has thyrotoxicosis and he is in atrial fibrillation.
Yes, correct. 10 points for team Parkinson.
Yeah, very correct. Why are you thinking of thyrotoxicosis here?
Sir, because the symptoms like palpitation, restlessness, and tachycardia and neck swelling. Neck swelling suggests a thyroid problem, and the other problems are due to hyperthyroidism. So that's why I'm thinking of thyrotoxicosis.
Okay, right. And then the 2D echo is absolutely normal.
Yeah.
There is no valvular lesion,
Yes.
right? What cardiac problem that can be there in a patient of thyrotoxicosis apart from atrial fibrillation? Though 2D echo here mentioned is no valvular lesion. There can be some other problem with some other structure in the heart, which can give rise to atrial fibrillation. What can that be?
So
No doubt, you have been given 10 points. Answer is very correct.
Answer is correct.
So the patient with thyrotoxicosis can have mitral regurgitation as other.
Very rarely. Okay, very rarely. But before that, it can be the cardiomyopathy. Okay, it can be cardiomyopathy. Okay, go ahead.
Okay. The next question for team Wilson's is, Miss WS, an 18-year-old girl, complains of severe fatigue. Her investigations are as follows: hemoglobin of 5 gram percent, hematocrit of 15%, WBC count 5,000 per mm cube, DLC is as shown on the slide. The reticulocyte count is 6%. Peripheral smear shows microcytic picture. Polychromasia is present. And bilirubin count is total is 1.2 and direct bilirubin is 0.6. What is the reticulocyte production index and the likely cause of anemia is? Your time starts now. Time is up.
Hemolytic anemia.
Which anemia?
Hemolytic.
No. Question again. Your 10 seconds, other teams. Over. Cheats. Team Parkinson's has given partial correct answer. RPI is 1. That is correct. RPI is reticulocyte production index is 1. That is correct.
Who has given the answer?
Team
How
Parkinson.
have you calculated it?
First, we have to calculate the corrected retic count. Then for calculating the reticulocyte production index, the corrected reticulocyte count is the retic count multiplied by patient's HB divided by standard HB, which comes out to be 5 into 5 by 13, 5 by 15. So that is 6. And for calculating the reticulocyte production index, we need a maturation factor. And for hematocrit of 15, the maturation factor
Next
is
slide.
2. And then we divide it by 2, then we get the reticulocyte index, which
Very
comes
good.
out to be 1.
Very good. Very correct answer. Let us give a big applause to him. He has nicely explained it. Perhaps the team who has given the hemolytic anemia as the answer. Go back to the slide. Go back. Perhaps they might have thought of the reticulocyte, considering the reticulocyte count. Am I right? It is 6%. And so you thought it is more than normal, and that's why it should be the hemolysis.
Yes, sir.
Now just go through this microcytic picture. Which hemolytic anemia you get microcytic picture?
Iron deficiency, thalassemia.
In which hemolytic anemia you get the microcytic picture?
Thalassemia.
Thalassemia, right? But then all the time you did not go always with the just taking help of the reticulocyte count. And that is the significance of providing this quiz to you. What you are supposed to calculate is the corrected reticulocyte count and reticulocyte production index, right? Here it is RPI just 1. So actually it is hypoproliferative anemia. And hypoproliferative anemia with microcytic picture. Hypoproliferation, microcytic, has to be some nutritional support is not there to the RBCs. That's why the hypoproliferation that is going on. So likely it is iron deficiency. Okay, so it is iron deficiency. Okay.
The correct answer is RPI of 1 and iron deficiency anemia. So now 2 questions will be asked in the audience.
No, it is 10.
And the audience has to raise their hands if they know the correct answer. Modified Duke's criteria is used for I think everybody knows this answer. 60. Okay, other question. Who is the father of clinical medicine? Anyone? And chocolate. So now when the correct answer is Hippocrates. Okay, now I hand over the mic to Mayuri Saste for supervisor round.
After the clinical based round, we are here with the second round, the supervisor round. This round is to check your basics and the depth of understanding of the subject. The rules are as follows. Each team will be asked a question to which they are expected to provide an adequate explanation. Depending upon the explanation provided, the quiz master will allot 0, 5 or 10 points, that is maximum 10 points. There is no negative marking in this round. Each team will be given 60 seconds to provide their explanation. The decision of the quiz master will be final and binding. So are you all ready for the supervisor? Any doubts? Scorekeeper ready? Timekeeper ready? So we'll start with Team Fanconi. Question is, why is staphylococcal infections followed by influenza infection? Your time starts now.
Pass.
Okay. So, sorry, Team Fanconi, you won't be getting any points for this question. So the correct explanation is staphylococcal infection has IgA1 protease, which acts and cleaves the IgA, which is present in respiratory ciliary lining and mucosal secretions. They break protective barrier and helps the influenza to easily attach to ciliary epithelium and facilitate colonization. So can you please, sir, the team has some doubt.
Yeah.
So can you address your doubt to Quizmaster?
So the question was asked other way around rather than this way.
Absolutely correct. Yes. Why are staphylococcal infections followed by influenza infection? So they are thinking what? They are thinking it is the infection, influenza infection first, and then it is followed by the staphylococcal infection. So the question is not correct that way, right? It should have been why the influenza infection is followed by the staphylococcal infection, because it is the staphylococci, protease 1 that is there. It is, cleaved by the staphylococci. So the protease is not available there, and hence the IgA is not going to work there, and that's why the viral infection like say influenza is going to come up there. Getting me? So he has pointed out very nicely. That was the thing. Actually, I was expecting that the question should have been the other way around.
So
right?
So sir, is the question wrong?
Yes.
So we'll ask another question after Team Wilson is done.
No, they should be given some points. So I'll be giving 5 points to them.
Vanshaj, are you ready with the scores for first round?
So 5 points for Team Fanconi for this question. Next question. Go to the next team now.
So actually, we'll be displaying the round points for the first round. Clinical round.
No. Display it after second round.
Okay. Okay. The next question to Team Hodgkin. Scorekeeper ready? Scorekeeper ready? Timekeeper ready? So the question is, why can't pralidoxime be used in organochloride poisoning? Your time starts now.
It worsens the condition, pralidoxime in organochloride poisoning. Because
what is the explanation? Team Hodgkin is supposed to give the explanation, no? So what is the explanation like?
because irreversible binding to organochlorides, that's why it worsens the condition.
Sorry, Team Hodgkin, the time is up.
No, answer is not correct. 0 points. 0 score.
Okay, so the next question to Team Parkinson is, okay, the correct explanation for the previous question was, organophosphates act by getting attached to hydroxyl component of the enzyme acetylcholinesterase and block it. PAM attaches to the other half of the active site and displaces phosphate. But in organochloride poisoning, this acetylcholinesterase is carbamylated and PAM cannot attach to it. Hence, it is not effective.
Right, go ahead.
Okay, so next question to Team Parkinson. Explain Wartenberg's reflex. Your time starts now.
Wartenberg reflex is just like the Hoffman reflex, which is used for diagnosing UMN conditions. It is based on the principle that there is loss of inhibition of the upper motor neurons, and that's why there's spasticity in these fingers when we elicit the sign. It's called Wartenberg.
So what it is actually?
Something like this.
It is not the theory that is important. Its practical aspect is very, very important. How? What is this Wartenberg? Theoretically, you are right. How are you going to do it?
Something with the fingers. Yes.
See, two of you are there together. Do it on your own. Yes, very correct. The position of the hands is very correct. Fingers is very correct. Then show that you both neither of you are having hypertonicity. Hypertonia is not there. Show it. How he is going to? Yes. Don't flex it right now. Keep it like this. Right? Try to pull your fingers. I am trying to pull his fingers. You are trying to pull. Don't pull me to your side only. Okay. Okay. Do it. Do it. Normally, what should be there? Normally, extension. It is an extension and slight flexion at the terminal interphalangeal joint. Right? So this is extension. Don't consider extension means abnormal. The way that you consider for the plantar response. Plantar response extensor is abnormal. Here extensor is normal. Okay. And then when there is hypertonia, what is going to happen? There will be flexion here. Adduction. Adduction of the thumb, that is going to be there. So adduction. This is the reflex that is going to tell you about the hypertonicity. Right? If you are not, it is equivalent to what? It is equivalent to the plantar response or Babinski's, but exactly reverse thing that you are supposed to remember. Babinski's abnormal is extensor. Here extensor is normal. Okay, go ahead.
So, sir, how many points would you like to give to Team Parkinson?
5 points.
Okay. Okay. So the correct explanation for this question is, in CNS examination, when patient supinates his hand, slightly flexing the fingers, so examiner pronates his hand, interlinks his finger with patient's and tries to pull against each other. Normally, thumb extends with slight flexion of the terminal phalanx. In hypertonia, thumb of the patient adducts and flexes strongly, indicative of pyramidal tract lesion. Can be taken as Babinski equivalent in absence of both lower limb amputation. So next question to Team Wilson. We'll wait for some time. हो गया था ऑडियंस क्वेश्चन ना अरे दिख गया हमको दिख गया ना
Okay. Just continue.
Actually, the question was displayed by mistake. We'll take the next question.
Yeah.
Why are deep tendon reflexes delayed in mixed edema? Your time starts now. So they are giving the explanation.
Hello. So this is called Voltman sign.
This is
Voltman sign. That is deep tendon reflexes are delayed in hypothyroidism or myxedema.
Right.
It's caused due to because of low thyroxine. There is a delayed binding of the myosin light chain kinase, causing delay in the deep tendon reflexes.
okay. Answer is acceptable. So we'll give 10 points.
So actually team Fancon is requesting for another question, but we have already awarded them points for the wrong question. So what should we do?
If the question that will be given now, if it is correct, then whatever 5 points are given, those won't be counted. Right? Then only 10 points will be counted. Or if the answer is wrong, then 5 points will be counted. Okay? Go ahead.
Okay. So then next.
So give the question to them.
Okay. So they don't want to attempt the question. Okay. So there are few audience questions. So is the audience ready?
Is there a question available for?
Yes. Two extra questions are available.
So let us put one question common to all 4 teams.
Okay. But no points will be awarded.
Yes,
Okay,
we'll give some points. Yes.
Okay. So the next question for all the teams. Are all teams ready?
They are supposed to write it on the sheet.
Okay.
Write down your name, your team name, and they are
Write
supposed
down
to
your
write.
answer on the chats. Okay. So don't say the answer. Just write down on the chats. So the question is: 19-year-old female complaining of nausea and vomiting goes to the hospital and receives some medication. On next day, she develops involuntary jerky movements. Why?
I think team Parkinson should give the correct answer because there are jerky movements.
Sir, can I reveal the answer? I have to little bit change it.
So this is the sheet.
Yes.
Answer is given by you.
Yeah.
But then once it is given, is final. So 3 of them are answering. Who is the team who is not answering? Not answering?
Team
Hodgkins.
Wilson.
They seem to be very benign, though the name is Hodgkins, malignant. It is not Tonden syndrome serotonin syndrome. It is not acute akathisia due to D2 blockade. But it is very correct answer is metoclopramide. That is giving rise to extrapyramidal syndrome.
Sir, D2 blockade due to metoclopramide, I have mentioned in that, not the drug. Actually, the patient was taking antiemetic.
Your answer is what? Acute?
It is actually acute dystonia due to D2
But
blockade.
what have you written it here? Acute akathisia.
Sir, that was written in past.
No. Also, it is not correct. Okay. So
Okay.
metoclopramide related extrapyramidal syndrome. Okay, right.
Okay, so how?
5 points. 5 points.
5 points to team Parkinson. So the correct explanation is patient may have received metoclopramide, a commonly used antiemetic. It causes extrapyramidal syndrome due to its dopamine antagonistic action. Also, so there is one more question. So should we ask to the audience or to the teams?
Audience participation. Okay.
So is the audience ready? Time. So the question is, 19-year-old female with 16 weeks of amenorrhea presented in OBGYN OPD with palpitations, per vaginal bleeding, on obstetric USG, patient had a molar pregnancy. In view of persistent tachycardia, a thyroid function test was sent, which was suggestive of increased T3 and T4 and very low TSH level. Explain.
Yeah, chalo, who is going to explain?
TSH and HCG both are glycoproteins and the alpha subunit is common amongst them. So because of the elevated HCG, the HCG acts on the TSH receptor, because of which we can see the hypothyroid features.
So the correct explanation was, for above patient, the thyroid profile is suggestive of hypothyroidism. Molar pregnancy is associated with very high levels of HCG. HCG molecule is made up of alpha and beta subunit, which has structural similarities with TSH molecule. Due to its structural similarity, HCG acts as TSH.
Right. So the second round is over, I think.
Yes.
Right?
Yes.
Now display the score for each team. I think the team Parkinson is doing better. Then second seems to be Wilson's. Let us see the correct, what is the score like. Third seems to be Fanconi's and fourth seems to be Hodgkin's. So the first is, okay, first is Fanconi's, 20 points. Okay, big clap for 20 points. Rest of Parkinson has 35, Wilson has 30. So Parkinson is 35. First one, second one is 30, that is Wilson's. Third one is Fanconi and fourth one is Hodgkin's. Hodgkin's, don't be so, benign. Let us go on malignant side. Right? But don't get nervous. You are going to pick up it. In next 3 rounds are going to be there. Right? So right, we'll go to the third round.
Okay, Dr. Meena Chandanwale ma'am has joined us right now. I would like to call her on the stage. I would also like to call Dr. Regina Ralte ma'am. For the next round, I call Meenal on the stage.
Hello everyone. After the amazing Supervi round, we are now going to have the pictorial round. This round will test your knowledge with image-based questions. I hope you all have fun while answering the same. So now let me tell you the rules for this round. There will be a total of 2 rounds. In each round, 1 question will be asked to each team. The teams will be shown an image. They have to answer the question pertaining to it. Correct answer will be awarded 20 points. Time limit to answer each question is 30 seconds after displaying the image. You will get only 1 chance to answer the correct question. If the image is identified incorrectly or if the question is passed, The other teams have to write the answers along with names of team on page provided and fold the page in the form of a sheet. Participants will get 10 seconds to write their answers on sheets. These sheets will be collected and 10 points will be awarded to all the teams that answer correctly. There is no negative marking for this round. Quiz master's decision is final if there is any confusion. Participants can ask doubt if any regarding the rules. Clear? So let's start with the round. First round. Scorekeeper ready. Timekeeper ready. First question is for Team Fanconi. Identify the condition. Your time starts now.
Pancoast tumor of the lung.
That's the right answer. The correct answer is superior sulcus tumor or Pancoast tumor. Team Fanconi gets 20 points. Next question is for Team Hodgkin. Identify the organism whose life cycle is shown in the image. Your time starts now. Time's up.
Nipah.
It is Nipah. Hello.
Team Hodgkin gets 20 points. Next question is for Team Parkinson. Connect the images and identify. Your time starts now.
Aortic dissection.
That's the correct answer. Team Parkinson gets 20 points. Next question is for Team Wilson. Identify the condition from images. Your time starts now. Time's
Moya
up.
syndrome. Moya syndrome.
No, that's not the
it is
correct
not.
answer. The question is passed. Please write your answers within 10 seconds. Collect. Time is there. 10 seconds. Over. Time's up. Please collect the chips. All the three teams, the answer is incorrect. The answer is basal, exudates, and ring enhancing lesions of TB meningitis. It's okay. So for this question, none of the teams gets any points. Let's start with the next round. First question is for Team Fanconi. Identify the instrument. Your time starts now.
Central line venous catheter.
Repeat.
Central line venous catheter.
No, that's not the correct answer. The question is passed to other teams. Please write your answers in 10 seconds. collect the chips. Team Parkinson has answered correctly. It's a dialysis cannula. It's a catheter. Sir, they have answered it's a dialysis catheter double lumen. Is it correct?
50% marks. 50%.
5 points then, because it
5
has 10
points.
points. Team Parkinson gets 5 points. Next question is for Team Hodgkin. Identify the instrument. Your time starts now.
EBL catheter.
That's the incorrect answer. Question is passed to other teams. Please start writing your answers. The answer is given correctly by all the 3 teams. All the 3 teams, that is Parkinson, Fanconi, and Wilson, gets 10 points.
The answer that is there is yes.
The answer is Sengsteken Blackmore tube.
Correct.
Next question is for Team Parkinson. Identify the test. Your time starts now.
Nerve conduction study.
That's the right answer. Team Parkinson gets 20 points. Next question is for Team Wilson. Identify the given instrument. Your time starts now. Time's up. So,
Eurobag.
okay.
Eurobag.
That's the incorrect answer. The question is passed to other teams. None of the teams have answered correctly. The correct answer is intercostal drainage tube. ICD. So they've written just ICD bag.
That is okay. That is okay. ICD is correct.
Team Parkinson gets 10 points. I didn't understand. Now till the final scores are calculated, we will have some questions for audience. Are the audience ready? The first question for the audience is, identify the cardiac condition. Your time starts now. Where can I answer? Please give them the mic last.
Takotsubo. Octopus at Takotsubo.
Please remove your mic mask.
Takotsubo.
That's the correct answer. Excellent. Please give them the prize. Second question is, identify the ECG. Please give them the mic. Manali ma'am, please give at the last. They have answered. They have raised first. Shit.
Brugada syndrome. Brugada syndrome.
Remove your mask.
Brugada syndrome.
No, that's the incorrect answer. Someone else have to answer.
Acute pericarditis.
No, that's not the answer.
Ventricular bygem. Ventricular bygem.
No.
Anterior wall MI. Anterior wall MI.
No. No, it's not.
So we can see bradycardia here, and we can also see ST elevation in V2, V3 lead. V2, V1, V2, V3. Sorry.
See, if nobody is able to answer it properly, anybody wants to? Yes, yes. No. No, no, no. Yes. No, no, no. No left bundle branch block. No, no, no. It is much simpler. Remember, very, very important sign that is there. Very important sign. Look at V1, V2, V3, V4. V1, V2, V3. Look at V1, V2, V3, V4. Can you identify the something that is, above the isoelectric line after the QRS? After the QRS. That is going above, and at the same time, look at the T wave. Look at the T wave. T wave has got two components. One is the positive component and another one is negative component. That is there in V1, V2. If you see in V2, it is but very conspicuous there, right? Very easily seen. V2. Again in V3, who has prepared this quiz? Who has prepared amongst you? Am I right? So you want to suggest the same thing. Okay. So the T wave that is there has got two components. One is the positive and second one is the negative component. We call it as biphasic T wave. This is important sign, that is valence sign. Am I right? This is valence sign. And this valence sign is going to tell you that myocardial infarction is going to be there in near future. Right? Very, very important. It is not the myocardial infarction that has developed, but it is the myocardial impending myocardial infarction. And most importantly, the culprit artery is to be proximal LAD. Proximal LAD is going to be the abnormal artery. So very important sign. Once you see it, keep it in the brain. And why means this, you just remember the significance of this sign. That impending infarct is where the patient is all right. Patient is not complaining to you about the chest pain, right? But if you take the ECG and if you see this particular sign, tomorrow also, even in the night also, the patient might get myocardial infarction, right? So that's why this is the importance, right? So this is called as valence sign.
Yes. The last question for audience is, identify the syndrome. The next question, please, the next slide.
Yes. Yes, audience, yes.
subependymal nodules and tuberous sclerosis.
That's the incorrect answer. Anyone else have to answer? That's the correct answer. Final scores after the round.
Okay, Parkinson is getting 100 points. Fanconi is getting 50 second. Okay. Then is the Wilson 40 points and Hodgkins is 30 points. Let me announce one thing here. The cohort that is there is not matching. 3 of the participant group are the undergraduates and one of the group already has passed their MBBS. That is the Parkinson, I suppose. Parkinson, both of your interns, right? So at the end, I'm going to, give some negative marking. Because they have already crossed, MBBS examination. Still, rest of the 3 groups are still to appear for the examination. So this will be at the end of, all 5 rounds.
But those who are appearing for the exam, their preparation is much better than ours because
perhaps I consider that you are also preparing for the post-graduation. Okay.
You're preparing for NEET PG. ना?
हमको सिर्फ 2 महीने मिले अभी फाइनल ईयर में
ठीक है ले लो
How many 3 rounds are over, right? 3.
Yeah, this was the 3rd round.
3 rounds are over. Let me announce here. I'll be cutting 30 points for this Parkinson. I'll be cutting 30 points. So now we show they won't be cutting henceforth. If you are jumping, then okay, that will be considered. Show the points, minus 30. Yes. So still, I think the Parkinson is ahead. Parkinson, okay. 70 minus 30, so 40 points. Go ahead. Yes. Acha, cut karke 70, so 70. Okay. So still the Parkinson is number 1.
Now I would like to call upon stage Ritvish Tope to conduct the next round. Thank you.
Hello. Okay, so we have an unexpected twist in this quiz. That so the next round that we are having is a rapid fire round, and can the teams please submit their mics to the volunteers because only one team will be needing the mic.
So I'll read out the rules. Next. Each team will be asked 10 questions and the time limit for each team is 60 seconds. Correct answer will be awarded 10 points and there is no negative marking. If the team doesn't know the answer, they can say pass in order to attempt the next question. If the team attempts all 10 questions before the end of 60 seconds, the past questions will be repeated. Okay. So we'll start with the first team, Team Fanconi. Are you ready? Can you just check your mic once? Is it on?
Hello.
Okay. So, timekeepers ready? So we are starting in 3, 2, 1. Meyerson sign is seen in.
Pass.
Groove sign is seen in.
Leishmania.
Wrong. Kerry Coombs murmur is heard in.
Mitral valvulitis.
Correct. Hakim stride is seen in.
West syndrome.
Wrong. Mutated gene of Wermer's syndrome lies on which chromosome?
10.
Wrong. True or false? Splenomegaly is seen in primary ITP.
ITP. False.
Correct. Anti-LKM2 antibodies are seen in.
LKM2. Wait. LKM2. Drug-induced autoimmune hepatitis.
Okay, correct. McDonald's diagnostic criteria is used to diagnose which disease?
MS. Multiple sclerosis.
Correct. Wells score is used for?
DVT. Pulmonary embolism in DVT.
Okay,
Pulmonary
correct.
embolism.
Okay, correct. Okay, so Team Fanconi has answered 5 correct questions, for which we'll display the questions on the screen. So Meyerson sign is seen in Parkinson's disease, which they passed. Groove sign is seen in lymphogranuloma venereum. Kerry Coombs murmur is heard in the probability of DVT, and they didn't attempt the last question. The time was up. Okay. We'll move on to the next team.
Hello.
Team Hoffman, are you ready?
Yeah.
Timekeepers, scorekeepers ready? Okay. So your time starts. 3, 2, 1. Hoffman sign is seen in.
Skip.
Shawl sign is seen in.
Dermatomyositis.
Correct. Key Hodgkin murmur is heard in.
Can you repeat that?
Key Hodgkin murmur is heard in.
Skip.
Clinical triad of global confusion, ophthalmoplegia, and ataxia is seen in.
Skip.
Trisomy of chromosome 13 leads to which chromosomal disorder?
Down syndrome.
Wrong. True or false? Delta sign on CT of brain is seen in brain tumor.
True.
Wrong. Which antibody is seen in all patients of mixed connective tissue disorder? MCTD.
Anti-Ro1.
Wrong. West Haven staging is used in which condition?
Skip.
MEST C score on renal biopsy is used for which disease?
Skip.
Who is known as the father of modern epidemiology?
Skip.
Team Hodgkin answered 1 question correct, for which they'll get 10 points. So can we have the questions? Hoffman sign is seen in a UMN lesion. Shawl sign is seen in dermatomyositis. Key Hodgkin murmur is the diastolic murmur of aortic regurgitation. Clinical triad of global confusion, ophthalmoplegia, and ataxia is seen in Wernicke's encephalopathy. Trisomy of chromosome 13 leads to Patau syndrome. Next. Delta sign is seen in lateral sinus thrombophlebitis. And antibody in mixed connective tissue disorder is anti-U1 RNP antibody. West Haven staging is used for hepatic encephalopathy. And MEST score is used for IgA nephropathy. And the father of modern epidemiology is John Snow. Okay? So we'll move on to team. We'll move on to team Parkinson. Is team Parkinson ready?
Yes.
Timekeeper, scorekeepers ready? So your time starts in 3, 2, 1. Lermit sign is seen in
MS.
Correct. Buttonhole sign can be demonstrated in which dermatological condition?
Skip.
Austin Flint murmur is seen in
AR.
Correct. The clinical triad of bronchiectasis, recurrent sinusitis, and situs inversus is seen in
Cartagena syndrome.
Correct. The chromosome involved in Angelman syndrome is
Chromosome 15.
Correct. True or false? Heliotrope rash is seen in SLE.
False.
Correct. Anti-CCP antibody is seen in
Rheumatoid
IA.
arthritis.
Correct. Binet and dry staging is used in
What staging?
Binet
CLL.
and dry. CLL. Correct. Curb 65 score is used in
Pneumonia.
Correct. Name the scientist who discovered penicillin.
Alexander Fleming.
Correct. Buttonhole sign can be demonstrated in which dermatological condition?
Psoriasis.
Wrong. Okay. Team Parkinson has answered 9 questions out of 10 correct. For which they'll get 90 points. So let us reveal the questions, the answers. So buttonhole sign is seen in cutaneous neurofibromatosis. The rest they answered correctly, so you can move on. Okay, let the audience. Can we move on? Okay, next. Now for team Wilson. So is team Wilson ready?
Yeah. Yes.
Timekeeper, scorekeepers ready? So we are starting in 3, 2, 1. Name the sign. Flexing and suddenly releasing the fourth toe elicits an extensor plantar reflex.
Pass.
Lupus pernio is seen in
Pass.
Dox murmur is seen in
Pass. Earlier answer sarcoidosis.
Correct. The clinical triad of muffled heart sounds, distended neck veins, and hypotension is seen in
Next, right. It's in cardiac tamponade.
Correct.
Cardiac tamponade.
The chromosome involved in DeGeorge's syndrome is
Pass.
True or false? Sugarcane dust causes bicinosis.
False.
Correct. Anti-centromere antibody is seen in
Pass.
Hunt and Hess grading is used in
Earlier answer limited systemic sclerosis.
Correct. Hunt and Hess grading is used in
Pass.
Hess bled score is used for
Esophageal variceal bleeding.
Wrong. Name the scientist who discovered treatment for scurvy.
Pass.
Name the sign. Flexing and suddenly releasing the fourth toe elicits an extensor plantar reflex. Okay, time up. So team Wilson has answered 4 questions correctly, for which they'll get 40 points. Can we have the questions? The first question, the sign described was Gonda sign. Lupus pernio is seen in sarcoidosis. Dox murmur, LED stenosis. Then they answered the triad correctly. Then a chromosome involved in DeGeorge syndrome is 22. Sugarcane dust doesn't cause bicinosis, cotton dust. Anti-centromere antibody seen in systemic sclerosis, and Hunt and Hess grading is used in subarachnoid hemorrhage. Hess bled score is to know the risk of bleeding in atrial fibrillation. And the scientist who discovered the treatment for scurvy is James Lind. Okay. So score. So at the end of the rapid fire round, Team Fanconi is still leading with 100 points. Team Hodgkin has 40 points. Team Parkinson is leading with 160 points. Team Wilson has 80 points. Okay. So I will now call Tanishka Patel to conduct the next round. Thank you.
In the inspiring words of Usain Bolt, no matter how far you get ahead of me, I will catch you. Now let's see which one of our teams catches up with whom as they race towards the finish line in our last round, the buzzer round. Here are the rules for this round. A total of 6 questions will be asked in this round. The team that presses the buzzer first gets the chance to answer the question. Correct answer after displaying the question will fetch you 60 points. If no team answers within 30 seconds after displaying the question, the first hint will be displayed. The second hint will be displayed automatically after 30 seconds. Once hints are displayed, the question will not be displayed again. And the scoring system is as follows. Correct answer without using the hint gives you 60 points. Correct answer after using the first hint will give you 40 points. Correct answer after using the second hint will give you 20 points. But for every incorrect answer, 30 points will be deducted. Please note that the team pressing the buzzer has to answer immediately within 5 seconds. And if any team presses the buzzer before I finish reading out the question, then I will stop reading out the question and the team has to answer immediately. Are the rules clear to all the participants? Yes, but yes, you can test. We'll be testing the buzzer.
No, I'm saying before you've read out the question, can we press the buzzer?
Yes, you can, but you will have to answer immediately within 5 seconds. Any doubts regarding the rules? I request all the participants to test the buzzers. Please reset the buzzer.
Is this working? Yeah, okay, reset now and don't press.
Has the buzzer been reset? Has the buzzer been reset? Okay. So are all the participants ready? Timekeeper and scorekeeper ready? So here's the first question. A 48-year-old female, known case of rheumatoid arthritis and hypothyroidism, on treatment came with complaint of yellowish discoloration of eyes since few days, with history of repeated episodes of pruritus in past few months, associated with fatigue. There is no history of fever, blood transfusion, jaundice, melena, and hematemesis in the past. There is no history of diabetes and hypertension. On examination, the vitals were found to be stable. So the team is answering primary sclerosing cholangitis. The correct answer is primary biliary cirrhosis or primary biliary cholangitis. So 30 points will be deducted from team Fanconi. Please reset the buzzer. I'll be starting with the second question. A 48-year-old female, known case of ischemic heart disease, was admitted with history of headache, vertigo, dizziness, gait imbalance since few days, followed by onset of difficulty in swallowing both liquid and solids and drooping of left eyelid. On examination, the pulse was found to be 84 beats per minute, blood pressure 150 by 90 millimeters of mercury. The systemic examination findings are as follows. CNS examination, the patient was conscious and oriented. There was dysphagia, loss of gag reflex, left eye ptosis and meiosis compared to right eye, gait ataxia falling towards left side, and decreased left side facial sensation. The power was 5/5 in all 4 limbs. CBS, RS, and per abdomen examination was normal. What can be the likely diagnosis?
Pica stroke,
Sorry? Please could you?
posterior inferior cerebral artery stroke,
Syndrome like
Wallenberg syndrome.
very correct. Yes.
So, Team Hodgkin gets 60 points. Has the buzzer been reset? I'll read out the third question now. A 24-year-old male had come in the casualty department with complaints of diaphoresis, breathlessness, weakness, and bluish discoloration of skin and mucous membrane after undergoing dental treatment under local anesthesia. There is no history of fever, cough, and chest pain. There is no past history. Team Hodgkin has pressed, Team Fanconi has pressed the buzzer.
Methemoglobinemia.
Yes.
Okay, correct. Methemoglobinemia is correct. It is due to what? It is due to? Yes.
Due to local anesthesia.
Okay, so it is acquired methemoglobinemia. Okay.
So Team Fanconi gets 60 points. Please reset the buzzer. Moving on to the fourth question. A 28-year-old male was admitted with complaint of pain in right-sided region of abdomen, which was acute in onset. Urgent ultrasound abdomen was done, which showed cholelithiasis. On examination, the vitals were found to be stable and icterus was present. Systemic.
Sickle cell anemia.
No. The answer is not.
Thalassemia.
No, the answer is not correct. Yes.
Team Fanconi gets minus 30 points.
Now let us explain this thing, no? Go back, go back. Let us concentrate on this. Young male patient. Pain in right side of the region, right sided region of the abdomen, which was acute in onset. Urgent ultrasonography revealed what? Cholelithiasis. So there are some stones. Vitals are okay. Icterus is present. Icterus plus stones together. Now the picture is getting combined. Systemic examination is revealing what? Right hypochondriac, tenderness, and there is splenomegaly. So additional now splenomegaly. So the stones, the icterus, the splenomegaly, the right hypochondriac, tenderness that is there could be there because of the stones. Rest of the other system examination is normal. Now look at the lab. HB is 8.8. The platelets are okay. The TLC is okay. MCV is okay. MCH is on lower side. Reticulocyte count is 3%. And this RDW, that is 15%. It is above the normal. Upper limit of the normal. Bilirubin is 4.8. Direct is 1 and indirect. Now, if you calculate indirect here, 1, 4.8 minus 1. So 3.8 is indirect. So indirect hyperbilirubinemia, that is giving rise to icterus along with splenomegaly, along with stones, those are there, right? It is a hemolytic anemia, right? Hemolytic anemia. And there is family members also have suffered from the cholelithiasis. So this altogether, this picture goes in favor of hereditary spherocytosis. There is a familial condition that is hereditary spherocytosis. You thought of hemolytic, but then thalassemia and sickle cell anemia was thought of. Now the PBS is going to give lot of clue. Yes, go ahead. See the arrow that is mentioning is what? Arrow that is showing what? Spherocytes. These are the spherocytes. And that's why it is hereditary spherocytosis. Okay.
So we'll move on to the fifth question. Please reset the buzzer. Has the buzzer been reset? Okay. Fifth question. A 60-year-old female was admitted with convulsions and altered sensorium. There is no history of fever, diabetes mellitus, hypertension, tuberculosis, asthma. On examination, core temperature was found to be 34 degrees Celsius, pulse 60 beats per minute, blood pressure, team Parkinson, team Fanconi.
Mixed edema.
Yes, sir. Explain everything. You are partly right. Explain everything. Mixed edema is there. Giving rise to what? Pulse of 60. Okay.
Sir, it's
The
mixed edema
temperature of 34.
it's-
Okay. What else?
Sodium is there and there.
Patient has got altered sensorium. Patient is drowsy. So does mixed edema explain this thing? What is the specific entity that we are supposed to call? You are right. Mixed edema diagnosis is correct, but then you should go one step ahead. Yes, yes. So that is because of mixed edema.
Yes, sir.
That is all. How will you explain this? The convulsions, those are there, and altered sensorium, that is there. Convulsions and altered sensorium. You are partly right. In fact, I will consider.
Mixed edema coma.
Yes, very correct. So it is a mixed edema coma as a complication of mixed edema. Look at the ECG. Look at the ECG. Look at the ECG. Go back. ECG is showing low voltage complexes. Why should it be low voltage complexes? And the X-ray chest is showing cardiomegaly, oblique something. Low voltage complexes in a patient of mixed edema.
Is it
Gives you
is
the
it
clue to
pericardial
the diagnosis
effusion
of, yes, pericardial effusion. So it can be pericardial effusion that is associated in a patient of mixed edema and mixed edema coma. Now, why the convulsion should be there in a patient of mixed edema? The convulsions are there. Why the convulsions should be there in a patient of mixed edema? Altered sensorium is okay. That is accepted. Yes, both the things are possible. Because of what?
Ideally, there should be brain should be depressed in mixed edema coma, but sorry.
Yes, some electrolyte problem. Any electrolyte problem they can have.
Hyponatremia.
Yes, very correct. So hyponatremia.
Edema.
Yes. So hyponatremia can give rise to these seizures as well as altered sensorium. So everything is explained on the basis of basic diagnosis, that is mixed edema, that is complicated with one, the pericardial effusion, second, the mixed edema coma, and third thing is the hyponatremia. Okay, right.
So the correct answer is mixed edema coma with pericardial effusion. Team Fanconi gets 60 points. Now we'll move on to the last question of this round. Has the buzzer been reset? Starting with the sixth question. A 53-year-old female was admitted with complaints of difficulty in opening eyes completely and double vision since 2 days. She had difficulty in swallowing, chewing, and speech. Did any? Which team press the buzzer? Team Wilson has pressed the buzzer.
Myasthenia gravis.
Yes, right. Correct answer. Team Wilson gets 60 points. So, well played teams. We are very impressed with your performances, but the final scores shall tell us who the winners for Cognizance, the clinical medicine quiz will be. The final scores are being calculated and the results will be announced shortly. I request the participants to please be seated in the audience till further instructions. Meanwhile, I'd like to call Dr. Bose sir on stage to say a few words. Okay. Participants, please be seated. We'll be having a tiebreaker round. Participants, please be seated. We'll be having a tiebreaker round.
That was a final decision, so we are going to make it a minus. So let us enjoy for a few more questions, no? Why not? So the tiebreaker is there between the Fanconis and the Parkinsons. Let us give a big round of applause to them.
Okay. Now there is a tiebreaker round. It is tie
Okay.
between Team Parkinson.
Okay,
and
what are you going to do? Let me know.
Sir, it
You
will
are
be
going
buzzer
to
round.
give some few questions.
Yes, sir. Buzzer round.
It will be
Between both the teams.
or shall I interfere and I shall ask some questions to them?
Sir, whatever you feel is correct.
That will be okay. One is third year, the final year batch. Final year, no? Final year, and another one is intern. Okay. Okay. Chalo. Whatever questions those were asked. Lermit sign, apart from multiple sclerosis, will be there in, come on. Cervical spondylosis. Okay, very good. Correct answer. Tell me. The peculiar feature. Oh, okay. Anybody wants to demonstrate the Lermit sign on their own? The tiebreakers, team tiebreakers, Lermit sign. How are you going to demonstrate? Demonstrate on your own. Yes.
I can describe it.
No, show it here. Come ahead.
We have to make the patient lie supine.
You do it on your own. What is going to happen? Is it only in supine position, or it can be in a standing position also? It can be any position. Why you want to supine position? It can be in any position. You are partly right. But remember, friends, I like to tell you here, this is the thing that happens at the time of examination. These signs are very, very important. What is there is Lermits. Lermits, this is just one example. And you are, I think whenever you are there in the wards, you should be well versed with these simple signs, those you should be able to elicit. Now, Lermits is what? Lermits is just you are supposed to do the flexion at the neck. And when you are doing the flexion at the neck and somebody is observing or realizing shock-like sensation right from the neck to the back, this is with the flexion. Remember, the answer that is given in the examination is with the flexion, but it is not always with the flexion. It can still be with the extension of the neck. This is a simple point with the flexion also, or it can be either with the extension also. With the extension of the neck, with the flexion of the neck, if somebody is experiencing a shock-like sensation in the neck also and at the back, then we are supposed to consider it as the Lermit sign. And remember, Lermit sign is not equivalent to multiple sclerosis. Is not only there in multiple sclerosis. Remember, it can be there in patients with cervical spondylosis. He said about it. It can be there in radiation myelopathy. Somebody is receiving some radiation to the spinal cord, radiation myelopathy. And Lermit sign still can be there in very, very common condition that we come across is the B12 deficiency, that is subacute combined degeneration. B12 deficiency, very simple to be identified, right? So now here, the another question that was there in the, the quiz, what was that? Slow relaxation. Yes, slow relaxation of the ankle jerk. That was there. Somebody answered the myxedema, right? But remember, all the time, B12 should be in front of your eyes whenever you are dealing with a case of neurology. B12, 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 lot of problems. See this, slow relaxation of the ankle jerk can also be there in B12 deficiency. B12 deficiency. And the SACD can also give rise to Lermit sign, which is again because of, say, B12 deficiency. Remember? So these are the simpler things that you are supposed to know in the examination. Very, very vital points. Okay. Anybody will like to, amongst the Parkinson and ankle. Come on. Either of you show the Parkinson gait. Parkinson gait. Don't fall down. Don't fall down. Don't fall down. What is that gate called? Face-tendon gate. Face-tendon gate. Okay, good. Now, can anybody amongst the two, Fanconi's? What are the different types of Fanconi's you know in medicine?
Fanconi syndrome and Fanconi anemia.
Yes, very good, very good. Give a big clap to him. There are two Fanconi's. One is the Fanconi's anemia, and second one is the Fanconi's syndrome. Fanconi's syndrome is in connection with the
type 1 RTA.
Yes, yes.
Type 2 RTA.
Yes, very correct. And Fanconi's anemia. What is the peculiarity of the Fanconi's anemia?
There is absence of splenomegaly.
Anemia is the, yes, very
Inherited.
good, very correct, very correct. Yes. It is anemia. It is congenital anemia. It is a familial type of anemia where you get not only anemia, but also the pancytopenia that can be there. Anemia or oblique pancytopenia that can be there. There is no splenomegaly. It is hypoproliferative. There is no proliferation of the RBC cells. So hypoproliferative type of anemia. And in fact, what can there be is the certain congenital, the orthopedic manifestations, those can be there in the form of some, the club foot or some distortion of the bones that can be there. So Fanconi's. Very good answer. Fanconi's anemia and Fanconi's syndrome. I think, how many questions were asked? How many questions? Now, in fact, we can go on till 11 o'clock also, no problem. But then we'll stop here. Among 4 questions are asked, and how many are? You answered
Actually,
3?
the Parkinson gate, we can show also that.
Acha. Okay, show it. Come on, again. Let me see again Parkinson. They were partly right. In fact, the Parkinson gate that they showed, they were partly right. But then let me see whether you are correct or not.
And he won't be able to stop himself.
Show it.
Still rolling.
No.
Reverse, still rolling
No.
reverse.
No. That is not a classical Parkinson gait. Right? So you are not correct. So he has answered, the Parkinson team has answered 3 questions. So we'll be giving 60 points to them. 20, 20, 20, 60 points. Right. Now I think it is time to get the final score. Right.
Now we'll display the final scores.
The final scores are being calculated and the results will be announced shortly. I request the participants to please be seated in the audience. On stage. To say a few words.
Dear friends, first of all, let me congratulate all the participants, like say Team Wilson, Team Parkinson, Franconis, and who is Hodgkins. They have made a very good attempt in answering so many questions. Let me tell you frankly, the questions, few of the questions were really difficult. Because the questions were prepared by our difficult lecturers. The Meenal is there, Neha is there, Avanti is there. So all the questions, those were there. Few of them really were simple, but then most of the questions were difficult and not for the undergraduate level. Few of the questions, I think the postgraduate students would have even not answered. So let me congratulate all the participants, those who are there. It hardly matters who is winning, who is the first team and who is the second and who is the last team. But then everybody, all the teams, they have made very good efforts in answering all these questions. If you see the type of questions, those were there in front of you. Certain questions were as far as the examination is concerned, from the theory viewpoint, certain questions were important. Certain questions were important from the practical viewpoint also, because Lermit sign, Hoffman sign, Wartenberg sign, etc., right? Or say a sign that is there in a patient of myasthenia or in a patient of say sarcoidosis, etc. So really, the efforts were taken by our lecturers to prepare this particular quiz questions. I must congratulate them also. I must congratulate all the audience. I think they are very much eager in knowing who is going to be the number one. But the kind of response that I found amongst the audience also was very good. I am really happy the way you concentrated on the quiz, and I hope the certain knowledge you must have got from whatever the questions those were asked and whatever answers were given by our participants. So again, wish you all the best. Coming new year is going to be very good for you. Wishing you all the best for this coming new year. Thank you so much.
Thank you so much, sir, for your inspiring words. So the final scores are with me, and they are as follows. At fourth position, we have Team Hodgkin with 100 points. At third position, we have Team Wilson with 140 points. At second position, we have Team Fanconi with 180 points. And at the first position, we have Team Parkinson with 220 points. Congratulations to all the participants. The awards will be given in the valedictory ceremony tomorrow. Now, I'd like to call on stage Manoj Kumar Vishnoi to deliver the vote of thanks.
Good evening. Good evening to one and all present. On the behalf of organizing team, it is my privilege to give vote of thanks on this occasion. My heart fills with lot of gratitude and respect for our distinguished quizmaster, Dr. R.T. Borse sir, for sparing his invaluable time and guiding us throughout the preparation and conduction of the quiz. Thank you, sir. I am running short of words to express my humble thanks to the medicine faculty for providing us with the questions. I would also like to thank all the participants for their energetic participation. Next, I would like to thank the organizing secretaries of Respirare 2021, Meher Kaur and Shonak Pimpalkar, for providing us the opportunity to organize this quiz. Special thanks to all Cognizance team member, hospitality team, technical team who worked hard to make this a grand success. Thank you everyone. Now I request all the participants and medicine faculty and Dr. Borse sir to come on the stage for a group photograph. All Cognizance members are also requested to come on the stage. All the participants, please come on stage. Hello.